Good morning, everyone. Thank you for joining us for the Medical Board of California quarterly board meeting. While this meeting is being conducted with participating board members and staff at the Sacramento meeting location, this meeting is being streamed interactively using WebEx to allow for remote public comment in the same manner as recent meetings. Public comments for those who wish to speak will be heard for each agenda item from individuals attending in person and remotely. To be ready for public comment, we ask that you please ensure your comments can be heard clearly by being connected to the audio of this meeting through the proper method. If you are having difficulty hearing the audio of this meeting, it could be because your device you are connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the bottom of the WebEx application or the audio and video menu item at the top of the WebEx application and then select Switch Audio. You'll see an option to call in and will be provided with a telephone number, access code, and attendee ID that can be used to connect to the meeting audio via phone. Using the information provided, it will automatically disconnect your device's audio and connect your phone to the name you joined the meeting with. By using this method, if you are having audio problems with your device, this will still allow you to participate and hear the audio of the board meeting. Please see the View Additional Meeting Information link on the first page of the meeting agenda for more information on connecting to the meeting and accessing meeting materials. Thank you, President Lawson. We can now start the meeting.
Thank you, Sean. Good morning, everyone. I'd like to first ask everyone to please turn their mobile devices to silent. You may notice board members accessing their laptops, phones, or other devices during the meeting. They are using these devices to access board meeting materials that are in electronic format. If you're a member of the media and require assistance or information, please see Ali Shembra. Ali, please identify yourself. Thank you. This is an official business meeting of the Medical Board of California, and disruptions of the board's business will not be tolerated. Government Code Section 11126.5 allows the board to remove people who willfully interrupt a meeting and to clear the room if order cannot be restored by removing or muting the disruptive people. We will have a designated time on the agenda for public comment on items not on our agenda, and we will also ask for public comment on agenda items. The board welcomes public comments on any item on the agenda, and it is the board's intent to ask for those comments prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please raise your hand or come forward and you will be recognized. This meeting, as Sean mentioned, is also being streamed via WebEx. Individuals attending the meeting remotely via WebEx will have an opportunity to provide public comment and will be assisted by the host who is facilitating the WebEx meeting. During each agenda item, the host moderating this WebEx event will activate the hand raising and Q&A features of WebEx and will ask anyone wishing to make a public comment to indicate so by raising their hand or entering yes in the Q&A window. The host will then call on individuals who indicated they wish to make public comments by the name provided by the individual, which may be a pseudonym. When called upon, the host will unmute the microphone of the individual and they will have 3 minutes to make their public comment. But this time period may be reduced depending on the number of people who wish to speak so that more people may be heard. The host will audibly announce when 30 seconds remain. Excuse me, I got off my script here. The host will audibly announce when 30 seconds remain to conclude the public comment. After the individual's time for public comment is lapsed, the individual will be placed back on mute, and only one public comment per agenda item is allowed per attendee. During agenda item 2, public comments on items not on the agenda, the board has limited the total public comment period for individuals to 40 minutes. Therefore, after 40 minutes, no further comments will be accepted. During public comment on any other agenda item, 20 minutes will be allowed for the comment period. After 20 minutes, no further comments will be accepted, and each person will be limited to 3 minutes per agenda item. I'd like to remind all speakers to please stay on topic and keep your comments to the allotted time or less. Today's meeting will be run according to the Open Meeting Act as required by law. We are planning to end today by 5:00 p.m., but I also wanted to call your attention to another notation on our agenda, which is that we may get through all of our items today. We have some that were originally calendared for tomorrow, Friday, May 16th. But to the extent that we can get through all of those items today, we will get through all of those items today. So I'd like to officially call the meeting of the Medical Board of California to order at 9:04 a.m. And Ms. Struther, if you could please call the roll.
Dr. Ayala Rodriguez.
Here.
Dr. Bolat.
Present.
Ms. Chung.
I'm here.
Dr. Helzer.
Here.
Dr. Mahmood.
Yes.
Ms. Remke, Dr. Thorpe,
Here.
Ms. Torres,
Present.
Dr. Sy,
Here.
Mr. Watkins, Dr. Yip, Ms. Lawson.
Here. All right, a quorum is present. I'd like to remind the members again that we will take a roll call vote on all action items. Moving on to agenda item 2, public comments on items not on the agenda. Before I call for public comments, I would ask individuals making comments to not discuss pending complaints, pending licensing applications, or pending disciplinary actions that may come before the board for a decision. Such discussions would be considered ex parte communications, as they could provide information to the members that is outside of the record in violation of the Administrative Procedure Act. Therefore, such discussions could create a conflict and lead to a board decision being challenged in Superior Court. The board can receive comments regarding the board's processes in general, but it cannot receive comments on specific case circumstances where the decision is still pending. In addition, the board requests the public to address the board as a whole and not individual members. And again, please be aware that public comment during this agenda item should provide information to the board members and is not a discussion between the board members and the public. The only action board members can take is to listen to comments and decide whether they want a future agenda item on the topic. No other action can be taken on the item at this meeting. Though this may seem at times like the board's members are not being responsive, following these guidelines is critical to ensure the rules of the Open Meeting Act are followed and to avoid compromising the speaker's goals or the board's mission. If you'd like to comment on an agenda item, please do wait until we get to that agenda item. Comments at this time are only for items not on the agenda, and please limit your comments to 3 minutes. First, are there any public comments from those present in the hearing room? Good morning.
Good morning. Good morning, board members. My name is Marcus Friedman, Administrative Director for the Consumer Protection Policy Center at the University of San Diego School of Law. I was unable to attend the February meeting, but I did review it and reviewed all the materials that was given at that meeting as well. One thing that did strike me was when Mr. Watkins brought up the public participation and public comment. There was a lot of animosity towards Mr. Watkins bringing up this type of request and interpretation of the intent of what public comment and public participation would be. So far as one of the board members comparing his rhetoric to the dismantling of our federal government by unelected officials. This is disappointing, especially when we were used, our organization, as a talking point that we met with the medical board in February. And it's true, we had a conversation about pending legislation. But what really disappoints us is nothing in that conversation was relayed to this board. And nobody on this board asked what was discussed in this meeting. It was not provided in any of the materials. We raised new issues and we presented those arguments in front of the legislature as well. If you have not heard those arguments, and if you are unaware of the new issues that we raised, then I believe this is something the board should be aware of. And they should be asking these questions as to what is going on with these conversations. And without that information being relayed to the rest of the board, it does feel silencing. It does feel like our work and our effort is not being communicated with the rest of the board. That's all I want to say at this time. Thank you.
Thank you for your public comment. Are there any other commenters in the room?
Hello, I'm Olga Airy. I'm from San Francisco. I'm a volunteer with Consumer Watchdog. I've been attending these quarterly meetings since 2020. I'm not paid to be here. I'm here because the medical board failed to investigate my complaint regarding the death of my sister. The medical board's missteps and inaction turned me into a dedicated patient advocate. Since there are so many new board members, I'd like to share a bit about my story and then go into my suggested agenda items. Patient safety is deeply personal to me. I lost my older sister to a preventable anesthesia error. She was a research scientist who focused on rare genetic diseases in children. Her anesthesia error was so catastrophic in destroying her lungs that she needed a lung transplant. Another error led to her never receiving one. My sister's life meant something. She didn't deserve to die so young from a preventable medical error. As board members, you all have the ability to make a meaningful difference in the lives of thousands of patients across the state. It's your job to protect the practice of medicine and to ensure the medical standard of care is followed by all physicians. Don't ever forget, the public is your largest and most significant stakeholder. Now to the agenda request for future meetings. 1, the quarterly meeting schedule. This is the second quarterly meeting in a row that you have scheduled on the same day and time with the Osteopathic Board. Given the topics are similar with both boards, is it fair to make the public choose between meetings? If you truly value the public's input, then you would make sure your meetings don't conflict with the Osteopathic Board. 2, meeting locations. There haven't been any meetings in SF or the Bay Area since at least 2020, from what I can remember. I understand there are underserved areas that need attention too, but given where most of the population resides, please have a meeting in the Bay Area or even San Diego before having one in another small city. 3, advance notice for meeting locations. Given you hold each quarterly meeting in a different city, it would be helpful if you give more than 2-week notice for meeting locations. 2 weeks may be the required minimum, but if you truly value the public's input, then you will give the public ample notice. 4, follow up to the August 2023 Bakersfield meeting. It's been nearly 2 years, and the maternal health report still hasn't been provided to the public. Why the delay, and what is the ETA on providing it? It isn't enough to simply listen. You also must actually do something. 5, equal airtime and balanced presentations regarding future proposals or initiatives. If you're going to invite a speaker to present one point of view, please also invite a speaker to present the opposing view. Otherwise, it comes across as biased when you only present one point of view. The public is only allowed 3 minutes to comment on an agenda item, and yet your speakers have unlimited time. Your speakers are also allowed to respond to the public's comments without any reciprocity to the public. This happened recently with your handling of the Physician Health and Wellness Program. You invited physician speakers to address the pros of the program, and no one addressed the cons. To make matters worse, these speakers criticized and made incorrect assumptions about members of the public, like me, who spoke, and it was infuriating because we had no way to correct the record. And finally, 6, coordination with CDPH. Many complaints to CDPH, including my own regarding a San Francisco hospital, are forwarded to the medical board for investigation because CDPH lacks medical expertise. However, these referrals seem to get lost in the shuffle. There needs to be better coordination between the medical board and CDPH regarding enforcement, and one way to demonstrate that is to have CDPH speak at your quarterly meetings. Thank you.
Thank you for your public comment. Other commenters in the room? All right, seeing none, are there any, oh, excuse me, come forward. No problem.
Good morning. I am Tina Manassian. I am from Roseville, and I'm a volunteer with Consumer Watchdog. I was once a passionate advocate for change with this board. However, I have not been active recently due to the profound harm I have suffered at the hands of a California doctor. This unfortunate experience has led to a cascade of complications that I've faced for decades. The physician responsible for my botched surgery was a substance abuser and a repeat offender, someone who had previously participated in the former confidential physician diversion program. Initially, I sought a consultation with Dr. Brian West for elective surgery. Trusting his expertise, I made the grave mistake of proceeding with his recommendation. In hindsight, it was one of the most disastrous decisions of my life. The result was nothing short of a complete mutilation of my body, leaving me to grapple with endless physical pain. Experts have unequivocally stated that I was never a suitable candidate for the procedure I underwent. Just 4 months after my surgery, Dr. West shuttered his practice. In the aftermath, I unearthed shocking details about him. He was abusing alcohol, drowning in financial troubles, had declared bankruptcy, and was entangled in multiple medical malpractice lawsuits. To top it all off, he was involved in a chilling situation where a former fiance who had hired a hitman to kill him. This is not the premise of a sensational television drama. It was the unsettling reality of my life, wrought by the medical board that at that time allowed a flawed and ineffective diversion program to let doctors dodge discipline, leaving vulnerable patients like me in the shadows. Determined to seek justice, I filed a complaint with the medical board. This expert concluded that Dr. West grossly negligent in my case, was grossly negligent in my case. What's more, they uncovered 5 additional instances of extreme departure from the standard of care in the harm and deaths of 5 other patients, revealing that he was under investigation yet again. Yet the board still closed my complaint with no disciplinary action. Ultimately, he lost his license in another case, not due to the extreme patient harm, but because he lied to the board. It was devastating to realize that the board permitted him to continue his practice for so long, allowing him to inflict further harm, all while prioritizing his professional status over the well-being of patients like me. I am devastated that I have to come back here to this meeting again 18 years later to implore you to prioritize patients' lives. I am devastated that you are nowhere close to the sentiments of the previous board that understood the risk that programs like this place on California patients.
Please conclude.
We are stakeholders. You must prioritize the needs of California patients. We have come so far in terms of balancing the interests of substance abusing physicians with the interests and well-being of patients, with the interests and well-being of patients. You cannot take us back to a time when there was no concern for patients' lives. Thank you.
Thank you for your public comment. Are there other commenters in the room? Okay, Sean, if we could go to WebEx, please.
Okay, first up here we have Eric Andrus. Eric, you should be receiving that prompt.
Hello.
Good morning, Eric. Your line's open.
Okay, can you hear me?
We can.
Okay, so I'm concerned about Christina stating that there might get through all of the agenda items in one day, including the items from tomorrow. As usual, you're not considering the public who may have made plans to attend for 2 days and might have paid a lot of money to fly up for 2 days, including hotel reservations. If you go through tomorrow's agenda items today, you're not considering the people who might still be there tomorrow expecting to do those agenda items. Further, if they don't watch today, they won't know that you've completed everything today. Usually, a meeting takes place in one day. It's unusual that this board does cover them over 2 days. If you schedule 2 days, you really need to keep it for 2 days, considering those who expect to be there for the second day. Thank you.
Thank you for your public comment. Next here we have Maria Ibarra Navarrete. You should be receiving that prompt. And for anyone else wishing to make a public comment, I'll mention, I forgot to mention it.
Navarrete.
You can use
Hi.
the hand raising feature or type anything in that Q&A window will get you called upon. Sorry,
Hi.
Maria, please go ahead.
Oh, it's okay. Good morning. I am Maria Ibarra Navarrete. I am from San Jose, and I'm a volunteer with Consumers Watchdog. I came to this board seeking accountability for the tragic death of my younger brother. He endured so much, and his passing was entirely preventable. I had faith that this board would honor its mission of consumer protection, but I now see I was mistaken. While my faith in this board's commitment to consumer protection may have flattered, my resolve to fight for consumer protection remains unwavering. In recent months, this board has effectively left the public feeling dismissed, unheard, and disrespected. I am grateful to be part of a supportive team as I cannot fathom facing the situation alone. It's clear why some advocates who once spoke out to this board are now absent because their voices were not heard. Perhaps your intention is to discourage us until we withdraw from these meetings. But rest assured, we will not waver, especially having had this meeting with the osteopathic board as well. It's a conflict. Our loved ones are worth every ounce of our effort, and the issues leading to their ultimately death, deserve our unwavering attention and affection. We have engaged in meaningful discussions with this board about the critical need for actual interest parties meetings. I want to clarify that I am not referring to the previous format where the board invited a speaker followed by a mere 3-minute public comment period. That approach falls short of fostering effective dialogue. What we truly seek are interested parties meetings that embrace open discussions, enabling us to respond to your comments and work collaboratively toward mutual understanding. And the very best, we hope to leave interest parties meetings with a sense of fulfillment, feeling that our time and effort invested in participation have truly mattered. Because our participation in these meetings do truly matter, we, the public, are your main stakeholders. Please try treating us like one. Thank you.
Thank you for your public comment. Next up here in queue, Marion Hollingsworth. Marion, you should be receiving that prompt. Oops. Try again, Marion. Sorry about that.
Okay, how'd that work out?
Yeah, we can hear you now. Thank you so much.
Thank you. Good morning. My name is Marion Hollingsworth, and I'm a patient safety advocate. I would like to ask the medical board to have an agenda item updating the public on how the rollout of the confidential letters of concern is going. You'll remember the board wanted to allow the executive director to send letters to doctors who had complaints that, while serious, didn't rise to the level of actual discipline, in their opinion. These letters of concern are now covered under Business and Professions Code 2227.3. It's been well over a year since this program started, so it would be helpful to have the letters of concern included in the enforcement report at every quarterly meeting. This could just include how many letters were sent out and possibly an opinion on the from the executive director on how this is working out. From other medical board advocate groups I work with, I know that other states send out letters of concern and give regular updates on the number being sent, so you would be joining other boards to realize the importance of keeping the public informed about this. This could also include an example of the type of letter that is sent out, like to a Dr. Doe or something like that. I hope you will consider an agenda item on these letters of concern and an update on the number both at future quarterly meetings and in the written and posted updates as well. Also, are you really planning to finish all the agenda items today and cancel tomorrow's meeting? Did I hear that correctly? Can you do that at the last minute without an adequate notification to the public? There could be someone who planned to travel tomorrow specifically for an issue to be reviewed on Friday. Please be more considerate of the public when you plan your meeting so the public is able to follow you better and participate. Thank you.
Thank you very much for your public comment. Lower that hand. Michelle Montserrat Ramos, you're next. You should be receiving a prompt on your end. Good morning, Michelle. The line's open.
Good morning. I am Michelle Montserrat Ramos, and I am with Consumer Watchdog. I miss the days when this board embraced collaboration with the public on pressing issues. It wasn't too long ago that we united to tackle challenges, fostering improvements that benefited both consumers and your processes. In those times, the public felt a genuine partnership with this board, where their voices resonated and their contributions were valued. Yet now, advocates feel sidelined and unheard, which is profoundly disheartening and undermines the very essence of this board's purpose. It's essential that we rekindle that spirit of engagement and respect for the good of all stakeholders. I would like to remind you of a recent Senate Rules Committee hearing where 2 physician board members participated in the reappointment hearing. During this hearing, both the physician members and this board received commendations for their concerted efforts to mend their relationship with the public. Notably, this progress was fueled by projects and proposals brought forward by the public. Unfortunately, it seems that the board has strayed from this positive path. Public perception suggests that you're now focused on a single stakeholder, neglecting your largest stakeholder, the public. We have expressed this request before, and we urge you once more to schedule interested parties meetings with the public regarding our pressing legislative issue. What we seek is not merely an extension of a board meeting with our voices limited to a 3-minute comment period, but rather a genuine conversation that fosters meaningful dialogue. Only through such an exchange can we collaboratively navigate these challenges and find a way to move forward toward what should be a joint goal: consumer protection. Thank you.
Thank you, Michelle. Next up here, we have Pat. Pat, you should be receiving a prompt on your end. Morning, Pat. Looks like
Right.
your mic's open.
Okay. My name is Pat Irving, RN, and I'm an advocate for chronic pain patients. I want to thank both President Lawson and Dr. Thorpe for their supportive comments and actions made at the last meeting. President Lawson's recommendations to reopen the opioid prescribing task force and to relook at the guidelines could not be more critical. These actions cannot come soon enough. It's time we openly acknowledge that we are in a most profound and serious battle over the most basic of human rights, the relief of pain and suffering. Many entities are depriving patients who are suffering from pain their human rights to adequate pain treatment. Specifically, beginning 2 years ago, the Permanente Medical Group in Northern California began forced tapering their legacy patients, treating them like addicts and forcing them onto Suboxone. Most cruel of all is that this protocol did not allow any pause in the taper, regardless of how much that patient was suffering. How do I know this? I was one of the patients. I was one of the multitude of patients that they forced tapered. And I know for a fact this practice is continuing today. I realize that guidelines are just that. They're guidelines. But they are worthless unless the medical board can at least try to back up what they have put on paper. With the suffering that is occurring, I am asking that the task force gets the support it needs. I understand that the board cannot stop forced tapers, but you have the influence to educate California physicians on best practices. More importantly, you have an obligation to ensure the safety and care of these marginalized patients. Please use your influence to ensure California pain patients are not left in agony. Thank you, President Lawson and Dr. Thorpe, for your leadership in this critical topic. We know we have been heard. We are grateful, but please do not stop with listening. Please continue your actions. Thank you very much.
Thank you for your public comment. Next up here, we have Susanna Zarayski. I hope I'm getting that close. Susanna, you should be receiving that prompt. Oh, let me send you another request there, Susanna. Looked like your line opened and went back on mute.
Can you hear me?
We can. Yeah, please go ahead.
Great. Hi, I'm calling to ask for the board to add an agenda item for the next meeting for AB 3119. This was the bill to add long COVID education for medical providers. It was passed unanimously by both the Senate and the Assembly and signed by the governor in September of last year. I spoke about this in the last meeting, and I'm very concerned that this bill was not added to your agenda item because I saw that bills that were passed after AB 3119 are on your agenda to discuss today. There is a desperate need for doctors to learn about long COVID. I have long COVID. My general physician referred me to the Stanford Clinic, which had more than a 6 or 9 month wait. It was ridiculous. Many doctors are not trained in long COVID, and people are still suffering from long COVID symptoms. And it's 5 years after the pandemic started. Some people aren't able to work. They can't take care of their kids. They can barely get out of bed. And doctors don't have enough training on which supplements and which medications could help people. So I'm asking you again to add AB 3119 to your agenda for your next meeting. Thank you.
Thank you for your public comment. Next here we have Kimberly Turbin. Kimberly, I'm sending that request now. Sorry, it's jumping around on me. Let's try one more time here, Kimberly. Should be receiving that request. Morning, Kimberly. Looks like your line's open.
Can you hear me?
We can. Please go ahead.
Okay. Good morning. I'm Kimberly Turbin. I'm from Reseda. I'm a volunteer with Consumer Watchdog. I have a few concerns. This is the second meeting where you're holding your meeting on the same day as the osteopathic medical board meeting. You did this once and we brought it to your attention. But with you doing this again, it feels like you are trying to minimize our voices and limit our participation in your meetings. We just want you to know that although we are capable of juggling both meetings at the same time, please go back to your regular scheduled time, which has always been the week following the osteopathic board meeting. In August in 2023, I was present at the Bakersfield Medical Board meeting on the second day of the meeting. We specifically requested a maternal mortality report, which this board agreed to provide the community. And it's almost been 2 years later. You have failed to do so. We need our report this year. Finally, in regards to public engagement, you have made us, the advocates, the public, feel like you are trying to minimize our voice. You cannot limit our voice. We'll keep coming back here. We do not take the work we do lightly. We are committed to make the changes needed, and we will continue to commit to this work. It would be much easier for you to meet us halfway, but either way, we'll be here and we'll continue to fight for the rights of our families. Thank you.
Thank you for your public comment. Next up here, we have Arnaldo Torres. You should be receiving that prompt on your end. Morning, Arnaldo. Looks like your line's open.
Okay. I wanted to bring to the attention of the board the phenomenal work that the Federation for State Boards have done with creating the new pathways for ITPs, International Trained Physicians. It is a game changer. It is long overdue, but it seems to be very consistent with comments that several of you have made in dealing with the legislative initiatives that I have written dealing with doctors from Mexico. I would like to request consideration by the board to have a special discussion at your next board meeting on proposals that we would like to have the board consider. I'd like to be able to be working with some of the board staff in preparing that, so that as we move forward with some of these recommendations by the Federation, that there is unanimity, there is a consensus between us and the board and board staff. I do think it is a great opportunity to address the shortages and to address cultural linguistic competency. I think that what we're doing with the doctors from Mexico is very, very solid, and we'll continue to do it the way we've done it there. But there is a need for other doctors from other countries with other cultures and languages for you all to consider. And I want to make sure that what we are going to be proposing to you, that the board staff will find it acceptable and that the board ultimately will agree and support as well. So that is my request of you, to please consider placing as a special item for discussion the recommendations and possible paths to move forward collectively. So I hope that the board will take that action and make a motion to that effect if it's necessary now, but if not, at least making sure that we place that on the agenda for the future, for the next board meeting. Thank you very, very much.
Thank you for your public comment. Next here we have Tracy Dominguez. Tracy, you should be receiving that prompt.
Hello?
Good morning, Tracy. We can hear you.
Good morning. Good morning. I am Tracy Dominguez, and I am from Bakersfield, California. I am a volunteer with Consumer Watchdog. As one of the members of our team, that encouraged you to bring the board meeting to Bakersfield. I was pleased to see you there, and I know the community was also. One thing we asked was that you produce the maternal mortality materials report. At the meeting, you and the board staff agreed to provide the public with the maternal health, maternity report. It's also been 2 years and we have not seen it yet. This report is important to us and it is vital to the work that we are trying to do. We are the families that have already lost so much. We also still live here in Bakersfield. Our families have to go to these hospitals and these providers. Well, you have hesitated in providing this report. More mothers and more babies have died. Please provide us with this maternal report this year. Most of you know I have been participating in every meeting here since I became a member of this team. One of the doctors responsible for my daughter and grandson's passing was a repeat offender doctor. It has taken a lot for me to come to these meetings and keep fighting to save mothers and babies. In the past few months, I feel disconnected with this board. I feel gone away from this board and agreeing that most public meetings in the Central Valley to this situation we are facing now. How we feel that you do not respect us or the stakeholders. We have had another speaker here tell us that we are not capable of engaging with substance abuse physicians issues. What is more troubling was when all of you sat there and didn't say one word. When we, the public, are disrespected. Not one of you could correct him by claiming that this board does respect the public views, even if you don't believe it. It was the right thing to do, but you choose not to do it. As a team, we have done a lot of work to be very favorable for this board. And once we felt that we had a working relationship with this board, but whatever corporation we once had is now gone. Whether you agree or not, we are your stakeholders. We are not going anywhere. We are committed to make an effect change here. It is up to you to meet us halfway, please. Meeting us halfway would be meaning planning, engaging interest parties, meeting where we have a back and forth conversation with the goal of accomplishing something that would benefit the public as well as the licensees. Thank you very much.
Thank you, Tracy. Last in our queue here, we have Xavier De Leon. Xavier, you should be receiving that prompt right now. I'll just say if anyone has not yet commented on agenda item number 2 and would like to, please use the hand raising feature or type something in that Q&A window. I also see a call-in user, so if you aren't connected to a computer, and only on a phone, you can press *3 to toggle raising your hand. Thank you, Xavier.
Hello. Good morning. Can you guys hear me?
We can. Please go ahead.
Okay, perfect. Good morning. My name is Xavier De Leon. I'm from Bakersfield and a volunteer with Consumer Watchdog. In August of 2023, I had the honor of attending the medical board meeting held in Bakersfield. It was a landmark moment, the first time the board had ever come to our city. While Bakersfield may not be the exact center of California, it is undeniably a critical part of the Central Valley, a place that's sadly known for having some of the highest maternal death rates in our state. That meeting marked the first time many in our community felt seen and heard by the board. On the second day of that meeting, our community stood together and asked the board for something simple yet important. We asked the board for a comprehensive report on maternal mortality and maternal death. At that time, both board members and staff assured us that the report would be done. Yet here we are nearly 2 years later, and we are still waiting. This may seem like another agenda item to some, but to us, it's a matter of life and death. Families like mine are the ones dealing with a healthcare system that's hard to trust and even harder to get through. We are the ones experiencing the loss, grief, and trauma reflected in those statistics. Our team continues to do the work, educating families, advocating for change, and organizing at the community level. But we cannot do this in the dark. We need data, we need transparency, and we need that report. So today I urge you again, please fulfill your promise. Deliver the maternal mortality and maternal health report this year. Too many lives are at stake. Thank you.
Thank you, Xavier. At this time, President Lawson, there are no additional requests.
Thank you all for your public comment. We had a couple of comments during the public comment period about the agenda. I did just want to call everybody's attention to the agenda between Thursday and Friday. We did recognize that folks may have planned for a 2-day meeting. We, as we were preparing for this meeting, realized that we might be able to accomplish everything in one day. So there is a notation on the agenda that's on the website currently that says that we'll recess if necessary, and that time permitting, all items will be heard on Thursday, May 15th. So I hope that's adequate notice for those of you who may have, planned for a 2-day meeting. We did recognize that in advance and wanted to make sure that it was on your agenda for reference. Okay, we are going to move on to agenda item 3, approval of minutes from the last board meeting. Just a reminder that the minutes are a summary and a record of the votes, but for the full recorded meeting, please reference the board's website. Are there any corrections to the February 13th, 14th, 2025 board meeting minutes from members? All right, seeing none, may I have a motion to approve the February 13th through 14th, 2025 board meeting minutes as submitted?
So moved.
Second.
Thanks, Dr. Helzer. Thanks, Dr. Balot, for the second. Are there any comments from those present in the hearing room? Any public comments? All right, Sean, if we could go to WebEx.
Anyone who'd like to make a public comment on agenda item number 3, you can type anything in that Q&A window or use the hand raising feature. If you're on a call-in only line, you can press *3. First up here, we have Pat. Pat, you should be receiving that prompt again.
Yes, can you hear me now?
We can, Pat. Please go ahead.
Okay, great. This actually has to do with the minutes. There was an entire section left out of the minutes, and I wasn't acknowledged during that part. I am sorry. The entire conversation between President Lawson and Dr. Thorpe, which was very important, having to do with reopening the opioid task force and Dr. Thorpe's heartfelt statements about his desire to help chronic pain patients, was entirely left out of the meeting minutes. I also noticed that it seems to be now written by AI, and the quality of the minutes has diminished greatly. I'd like you to take note of the fact that the minutes are now not as thorough as they used to be, and this is just one example of an extremely important topic that was missed. Thank you very much.
Thank you for your public comment. This time, there's no additional requests in queue.
All right. We will bring it back to the board. Ms. Struther, are there any further comments from anybody? Ms. Struther, if you could please call the roll.
Dr. Ayala Rodriguez,
I abstain. I wasn't present.
Dr. Bulat,
Yes.
Ms. Chung,
Yes.
Dr. Helzer,
Yes.
Dr. Mahmood,
Yes.
Dr. Thorpe,
Yes.
Ms. Torres,
Yes.
Dr. Sai,
Yes.
Dr. Yip, Ms. Lawson.
Yes. The February 13th through 14th, 2025 board meeting minutes are approved. Thank you. All right, we will move on to agenda item 4, which is the president's report. And I really just have a very brief report about AB 408 and our, just my testimony in the Assembly Business and Professions Committee regarding that bill. We're going to hear more about that bill and its current status and what we can expect later. But it was what I found it to be a good meeting with the Assembly Business and Professions Committee. I know that Dr. Helzer covered another committee meeting, and we may have future committee meetings as well on the topic. So that bill continues to advance, and we'll hear from Mr. Bone later. This is the section where we also now do communications with interested parties. I've continued, to have routine communications with those who are asking questions or seeking information about various medical board matters, all of which I pass along to our incredible staff. And so I'd ask if there are any other members that have communications with interested parties to report. Dr. Thorpe?
Thank you. I did have a meeting with Pat and with Monty Goddard and a number of other chronic pain advocates, along with Mr. Verghese, as a step to try to find a way to be more active in implementing the opioid guidelines.
Thanks, Dr. Thorpe. And just a reminder again, we asked the members to report on communications with interested parties relevant to any matter on the agenda. Dr. Helser.
Thank you. Earlier this week, Mr. Bone, Ms. Webb, and I met with leaders of the California Society of Anesthesiologists to discuss AB 985, which is being sponsored by CSA and is on today's agenda.
Thank you. Any other communications with interested parties to report? All right, seeing none, we'll go to public comment. Are there any comments from those present in the hearing room? Okay, seeing none, we could go to WebEx, Sean.
If you wish to make a public comment on agenda item number 4, please use the hand raising feature. Type anything in that Q&A window, or if you're in a call-only line, you can press *3. Give you a few seconds to see if anyone queues up. Not seeing any requests at this time.
Okay, we'll bring it back and we'll move on to agenda item 5, executive management reports. And just a note, we'll take questions and comments at the conclusion of all the reports. Sean, I think we're going to you first for technology updates. Is that right? Great.
Try not to knock anything over there. Thank y'all. Good morning for having me. I'll briefly go through the published report. Staffing updates, hired 2 new staff members. One of us actually with us here, Mac in the back there. You might talk to him if you're ever calling in on the help desk. Still leaves us 4 vacant positions we're working on filling. Actively recruiting on those. For the iOS update, having some difficulties with getting the Apple notification services to play nicely with how we want them to work. So testing, in between testing though, we're getting a lot of work done on that complaint tracking system there. So hoping we've made a recent breakthrough on the iOS update that will allow it to be reliable the way we're hoping it will be. But again, just in between long rounds of testing for long periods of time to make sure it's reliable. Just focusing back on the complaint tracking system. So hopefully publishing that here shortly. For the docs update, just general numbers update there, but I will point out to you the new section down there about the licensing document update. So this is the first time you'll have some published stats on how many documents we received for licensees, the postgraduate training requirements for their initial renewal and stuff coming from those programs and stuff. So that chart will get a little more interesting when we have a little more data in there. It's just a one little line right now. Voluntary physician registry update. More people volunteered for the signed up for the volunteer physician registry updates. We hope to have more newsletters and publications to keep driving people into there, but we'll continue to provide you those updated stats. The HCI survey updates. Again, this still about 0.5% jumped up there. We're definitely starting to plateau on the number of people that have completed that survey, but we'll continue to report that number there just because I think it's important. And then the pie chart there shows you the percentage. If you recall, before the HCI survey publication, we had about closer to 85%. So we're trying to get to that number. Wallet card updates, people still using their wallet cards. We love that, saving the board costs on generating the hard cards. And so people seem to use the wallet cards now and enjoy them. So we're happy to do that. The Breeze online complaint form, this one has a very significant update. The code from the vendor dropped for the requests that we wanted to have to change how the online complaint form works. And so the code is available. Now it needs to be configured. The medical board is going to be the pilot board for the Department of Consumer Affairs to implement this new functionality. It will save a lot of time. Again, if you don't recall exactly what this was, This was to save a lot of time on the back end in terms of our enforcement staff having to set up a complaint, basically taking information that was put in by a complainant and moving it around in the system to be in the right place. Now it will go into the right place. It'll be better quality coming from the complainant and less work on our side to set it up so that they can go immediately right to processing the complaint. Along with that, the complaints, if you're familiar with the online complaint form, there's just a ton of questions on one screen that were there from a time when that was all shared with multiple boards. We'll be refining those questions, cleaning those things up, hopefully making a better experience for complainants and for our staff. So we were scheduled to have a meeting on that. I believe May 7th was the date. That had to be rescheduled with the Department of Consumer Affairs, but I hope by the next board meeting we've got at least part of the changes implemented as that code is ready from the vendor now. So electronic, excuse me, the electronic only renewal notice project, still just providing guys numbers there to show how many are still renewing online. I'll mention here, because we talked about it in the last board meeting, about improving the email quality for our licensees, and we're working with the Department of Consumer Affairs. They've actually already procured a constant contact like system that it integrates with the current system we use for sending out these mass email blasts. So like we talked last time about blasts that go out on behalf of the Department of Public Health, things like that. We hope to soon have read rates, things like that. So not only that, hey, the blast went out to 160,000 licensees, but how many of them viewed them. And then we're also exploring ways on the back end. What we'd like to do as part of their renewal process would be to, every time you go to renew, you have to provide your email address. Right now, if your email address is already there, you just hit next and you proceed through. We're working to find a way to, without a costly change to the system, to have it so every time going through the renewal, the email address has to be re-entered to be verified. So that will at least ensure that every 2 years we get a verified email address from the licensee, make sure they're not just clicking through that address change screen and don't have to verify that every 2 years on their renewal. Currently, if they do change their email address, they have to verify it, but it's not very frequently that people do update their email address, even though they're required to update us on those email addresses. So and so that brings me to the complaint tracking system update here. And so again, during the iOS testing, the same developer is working on the complaint tracking system here. I'm going to attempt to share my screen from here so that you guys can see the PowerPoint that I'd like to go through. Sorry, this is hard to do from... Sorry, let me make this a little bigger so you guys can see it here in the room. Apologize, too many computers there. Let me get my notes up here so that I can make sure I don't miss anything. So again, the complaint tracking system in between the iOS testing patterns here, we've been doing work on the complaint tracking system. Last board meeting, I reported to you that we had built all the infrastructure services to be able to pull the data out of Breeze, and so now we're starting to put together the user interface. And so just a little background, because I know that some of the board members are new since we had these original meetings. Sorry, let me get that out of the way. So we held some interested party meetings in March and June of 2023. After the initial proposal, the board wanted to be sure that we asked for interested parties' feedback of the proposed features, including additional features and suggestions stakeholders would like to see in the system. Those two parties there held in March and June of 2023 were attended by former board member Lori Lubiano and current board member Dr. Bolot. We documented all suggestions from the public, and they were compiled into one document and reviewed for feasibility and legality, with the results discussed and published as agenda item 14 of the December 1st, 2023 board meeting. So if you're interested in going back and reviewing those are out there still on our website under that particular meeting date. At that meeting, we presented some mock-ups. If you recall, I know it's a long time probably since anyone's seen this presentation, so I want to just go back through it real quick. But some wireframe mock-ups were presented at that meeting as shown here. This was the complaint header information that would be pulled from the Breeze. We came up with some renderings of how the activities logged in the Breeze system would look for users. The two types of activities we came up with were, this one was the point in time activity. Basically, there was a single event that occurred on a single date, show up this kind of a format. And another type of activity we called the start to end activity, where an activity starts on a specific date and can have multiple outcomes. In this particular example here, the outcome is pending, and a yellow theme was used to indicate that the action may be required by patient or the authorized representative. As outcomes are updated, the colors could be used as themes to indicate the various potential results. In this case, no response versus a response received, just two different colors there. That we were all of these outcomes and pairings need to be defined and approved by board staff before launch, and were demonstrated and shown only for illustration purposes, because using colors was one of the features we were asked to incorporate to help relay information. So those were the two types of activity codes out there, and then we had a mock-up of what the list of all the activities on the complaint that were disclosable would look like for the user of the complaint tracking system. So now we get to actually where we've gotten so far with the development, and just so you know, some of these screenshots are from Monday. I mean, it's actively being worked on and stuff here. So we talked about how the authentication would work in that original presentation, but now I can actually show you how it'll work here. So this would be incorporated into our full website template. So you would basically have a page here where you would enter in the complaint number, and then you would have to enter in the email address as submitted initially with the complaint for either the patient or their authorized representative. The email address must match the email address associated with the patient or the authorized representative. If not, the user will be advised they are not authorized to view the status of this complaint. So just first check before anything else happens. Does the email address match the complaint number as submitted into our system? If it doesn't, the user just receives this prompt. If the email address does match the email address associated with the patient or authorized representative, a one-time passcode will be sent to the email address as a second factor authentication challenge to authenticate the user as the patient or the authorized representative before they can view the status of the complaint. The user will have to enter the one-time passcode before the authentication window expires. I'm sure you guys are familiar with this standard multi-factor authentication. It shows 29 seconds here. I think we have it set at about 1 minute right now, but it'll be somewhere in a expiring time frame so we can ensure security there. Again, this looks like that header screen that I just went through because we developed it to match that wireframe mock-up that we showed you there. But so all this information right here is being extracted in real time from the Breeze test environment. Cosmetic changes may still be made, but the ability to extract this complaint information in real time as a result of those web services I mentioned earlier, built in-house by our developer with cooperation for the Department of Consumer Affairs Office of Information Services. So as far as I'm aware, this is the first web service that's pulling complaint data out of Breeze in real time. Looks simple enough, but it's a lot of infrastructure there to have that working. And then this is the complaint activities list. So along with that header information, the disclosable complaint activities are extracted and displayed very similar to the mockups. Again, the formatting we're actively working on. There's some right now, some coloring things and things we want to change for ADA compliance and just cosmetic readability. I know this is very hard for you to read here on this screen, but very similar to those mockups. We have those blue activities there are those point in time activities. The red and greens in this case, in this situation here, there's no yellow ones, but we'll be showing those colors to bring attention to certain items for the user to take a look at to see if there's anything that they need to take action about. Again, hard to read in this projection here, but there's links in some of those descriptions. I don't know if you can make it out here, but this particular one here is red, saying that a required release form was not received. And so you can click that link right there. It'll take you right to our website where that form is. Print that form out and mail it in. We do want to, in subsequent releases, maybe not even as part of the complaint tracking system, but have the ability for those documents to be filled out and submitted just right online, one-on-one shot. We can link to that kind of an interface there as well too. So the only, and in fact, the only thing that from the original mock-ups that isn't present in those screenshots there that I just showed you, and I want to glance over how quick that was, that the app is basically you log in, you see your complaint details, a lot of ongoing stuff there, or a lot of infrastructure work there to get that information there on the screen. But in essence, it is a pretty small application once it's pulling out all that data and translating it. That's the hard part. So, but what we don't have yet, and what we showed in the original wireframe mockups, is the contact us form. And if you recall from the previous mockup demonstration that we showed, the user will have the ability to enter basically like an email, type in a message that they want to send into the analyst that's currently assigned to that complaint. We're still going to be building that feature in there. What we're working on for security is to not have email addresses on our website. We're switching to all contact forms. And so in earlier mockups, we did display it with the idea that there would be an email address there that the person would have to be able, the user would have to be able to contact their analyst. Now it's going to be a contact us form kind of a style thing where they don't get the actual email address. It's for phishing, security, and things like that we don't publish these email addresses. But they'll fill out the form, they'll hit submit, the message will get routed to the person appropriately in the back end. So that's actively being developed. I don't have a good screenshot of that to be showing you, but essentially, besides these, there's some ADA issues with the colors is currently in that screenshot there that we're working on, just for readability, playing around with the margins and the paddings and things like that. But the heavy lifting of getting the data out and translating it, that's all working. So, we probably have a few more weeks of development and making sure that all works. But after that's all done, the development will pretty much be wrapped up and we'll move on to testing. And if you recall from the original project plan, I said about 6 months development, which we're right on target for that. And then I said 6 months of testing, because we're going to be testing this thing over and over and over. The services and everything that pull the data out of Breeze, there's not much that can go wrong there. There's not that much to test. What we will be testing is, at the zoomed out level now. We've been looking at individual activities and what the translation should say and everything like that. But it's not until you start looking at these full screenshots, the full list of the activities, is the information clear there for the user and stuff like that. So when you start looking at them as big pictures, and I joke around, but I'm pretty serious that we're going to have to look at examples of thousands of complaints through this thing to make sure that the information being relayed is clear and understandable. Lots of tweaks there and things like that, and reviewing with legal, reviewing with enforcement staff. So I'd say within the next month or so, we'll be switching from the developer writing code to literally just sitting down and going through complaint after complaint in the system with enforcement and legal staff, having them review and having people, think about and stuff like that. I'm very confident that by the August board meeting, we'll be able to do a driving demo, for you guys, and it'll be better than these zoomed out screenshots. Sorry, those were so hard. I was picturing a bigger projection here, but by then we should have it would still be test data, obviously, that we'll be able to show you guys, but we'll set up some, several real world complaint examples and show you kind of the full picture of stuff like that. So very happy again with all the work that's been done so far. I thank our developer, Frank Islami, on this one. Nicole Kramer, who's now she was always my partner during the involved party meetings. She's still at DCA, working with DCA now, but still helping with this project. And again, all the staff at the Office of Information Services on their Breeze team and stuff like that to help set up all these services and stuff for this to be able to happen. So that concludes my update. I'll wait for questions.
Thanks, Sean. I think we're going to do questions all at the end, but it is always amazing to me with something so simple that, when we all use our phones or our computers to click on something and it produces a whole bunch of results, how significantly complicated it really is behind the scenes to make any of this happen. So thank you for all your hard work. We're going to move on to and if you have questions, just hold them until the conclusion of all the reports. We're going to move on to the licensing program summary. Douglas Hawk. Good morning.
Good morning, everyone. So for the licensing program update, for applications received and licenses issued, the board received 2,241 applications, and we issued 1,570 licenses in quarter 3. One of the main program updates that's really helpful to us is the applicants now have the capability to submit documents online via Breeze. This eliminates steps in the process, eliminates emails going to staff, and just makes the process so much more efficient. One of the things we've been focusing on is those who have a postgraduate training authorization letter that we received prior to January 1st, 2020. According to statute, the board can destroy those files if we don't have evidence that they've been in a board approved postgraduate training program by April 30th, 2025. So we've made efforts by sending out emails, physical mail to inform them of that April 30th deadline. Another major item that we've updated is our paperless renewal. So starting with those who have licenses that expire June 2025 or later, all renewals will be online through Breeze. We will still send, obviously, email renewal reminders to all those licensees. We continue our efforts for paperless for our entire licensing program. Licenses that expire for 5 years or more can now upload additional documents to Breeze. So those are applicants' reinstatements. Our CME audit process has been streamlined by eliminating creation of paper folders, transitioning to electronic record storage, and using email communication for contacting licensees and sending audit-related letters. Another item that we've updated is now medical schools can submit transcripts and other documents via docs without the need for a signature, graduation date, or school seal, since this is coming from authorized and verified representatives. Another docs update we're working on is we're getting all the programs to re-register. Those who have provided a registration form in May of 2024 or later were able to accept multiple electronic signatures, some of the more common ones that we weren't able to accept prior to May 2024. For Webmaster, we responded to 2,571 emails in quarter 3. The most responded topics were license updates, CME, and fictitious name permit questions. For outreach in quarter 3, we conducted a webinar to inform programs and applicants about the licensing renewal law that became effective January 1st, 2025. Additionally, licensed staff participated in the February board meeting in Fresno, where they answered licensing inquiries, guided programs, applicants, and licensees throughout the licensing process. And for our consumer information unit, they received 14,614 calls with an average wait time of 6 minutes. 3 of the topics most responded to were renewal assistance, complaint questions, and application questions. And that's the update from licensing.
Thank you very much. I think we'll move on to the enforcement program next. Charlene Smith.
Good morning. So all of the items that will be discussed will be found in the board material packet, agenda items 5C. So we are happy to report our collaborative process that's been ongoing. We're meeting with the Health Quality Investigation Unit and the Health Quality Enforcement section at the Attorney General's office. We're working on collaborating to focus on identifying case type categories, roles and responsibilities, processes and procedures and timelines. These have been very successful, and we're hopeful to be finalizing that process soon. In the Central Complaint Unit, we so far as of March have received 6,894 complaints. The complaints are being initiated within the mandated timeframes, and our average processing times are at 152 days, which is in with statute. We are noticing overall aging for enforcement has increased, and we recognize the impact not only to consumers, but other functions within the board and outside of the board. And so management and staff are actively addressing this issue. We also had an increase in our citation and fine caseload. This was partially as a result of the continuing medical education audit that licensing is doing, but we do have some assistance from retired annuitants on that process. So we are hopeful that that will resolve, that increase quickly. CCU staff, Central Complaint Unit staff, have been trained on the electronic process. As with any change, there's some who grasp it and some it takes a little bit longer, but otherwise it's going smoothly. And we're excited for getting away from physical files, paper, and the wear and tear on our machines from that. So some of the ways that we are addressing the increase in case aging, some of the duties that staff in the Central Complaint Unit, such as taking the analyst of the day calls, if you will. So when anyone calls into the board and has a question about complaints or enforcement, the Complainant Liaison Unit staff is now taking that over. They're also responding to emails that are sent to our Complaint Unit email address. So that's affording our staff in the Central Complaint Unit more time to focus on their aging, improving customer communication, and seeking clarification in instances where we don't have enough information. And then we are utilizing retired annuitants and other board staff to assist with, taking care of the aging. The Complainant Liaison Unit, as of April 1st, there have been 394 complaints referred. Interviews have been extended to 329 complainants, and we're really pleased with the response with this unit being stood up. So in the packet, we do provide information that there were 162 interviews offered, 25 scheduled, 4 declined, and 108 conducted. And then there were 30 that we did not receive a response from the complainant. So I think that's a great outcome. We're seeing that through the patient advocates bringing that concern, that this is really being fruitful and the efforts are being made, and it's a great outcome. Our probation unit, we do have some vacancies. Well, we have vacancies across the board in the enforcement program, in the Central Complaint Unit, in discipline coordination and probation. For the third quarter, there were 29 licensees placed on probation, 3 probationary licenses issued, and 19 licensees successfully completed probation. 3 licensees surrendered while on probation, and the information is provided in the packet. There's Walter Simmons, was one of the licensees who surrendered. Ellis Beasley is another licensee who surrendered, and Alan Steinberg. And the reasons that were provided were Dr. Simmons was unable to practice at this time, and the other 2 retired. There were no petitions to revoke filed, and there were 3 accusation petitions to revoke probation filed. This concludes my coverage of the enforcement program. Thank you.
Thank you very much. Okay, we're going to move on to the administrative summary, Mr. Varghese.
Thank you, Madam President. So my presentation, if you want to follow along,
It's in the board packet 5D. So I will start off with the administrative update by saying that the board staff and myself met on a regular basis with board leadership and individual board members on official business matters and other topics of interest. We have weekly and biweekly standing meetings with the Attorney General's Office, Health Quality Investigation Unit, for case reviews and developing enforcement collaboration process. In addition, myself and other staff members met with a variety of stakeholders listed in this report. Moving on to staffing update overall at MBC, we are still reporting about 14.8% vacancy rate, which is very similar to what I reported back in February. And main reason is reason why we are stuck at that number is largely due to internal promotions of to fill the vacancies. Moving on to another important report on budget. Budget update also remain unchanged as compared to my report to you at the February board meeting. As of February 2025, books closing in February of this year, we are still looking forward to repaying 2 outstanding loans in the amount of $14 million plus interest this fiscal year. That is by end of next month, that is June 2025. Also, according to current fund condition projections as illustrated on page BRD 5D 4, we are still projecting to close this fiscal year strong with expenses coming under budget and revenue collections to exceed what was budgeted, and the net result of starting the new fiscal year of 2025-2026 fiscal year, starting with not needing any loans for MBC operations. So moving on to media relations, since our last board meeting in February 2025, staff engaged with a variety of stakeholders. Like yesterday, Marina O'Connor, Deputy Director, gave a presentation at the California Medical Association of Medical Staff Services in Universal City. On May 7th, myself met with Self-Help and Astera Health and All American Medical Group in San Francisco. On April 30th, I met with the San Mateo County Medical Association at their virtual town hall meeting. And in April 24 to 27, I attended the Federation of State Medical Boards annual meeting. And it was a very interacting meeting with stakeholders from other states. And also on April 23rd, I participated at the Administrators in Medicine annual meeting. So basically, to conclude my report, myself and my executive staff will be happy to answer any questions you may have on all the materials that are presented. Thank you.
Thank you, Reggie, and thank you to all of our staff. Are there any questions or comments from board members? Dr. Thorpe?
Sorry, I did have a question for enforcement. I think that's where it was. Sorry, I got lost here. Yeah, and it just seems like all of the enforcement timelines are going up recently rather than coming down. They've been going down really pretty consistently for a while, and it just puzzles me why all of a sudden the numbers, the days to complete investigations in the complaint investigation office has gone, from 250 back in Q4 of 22, and just kind of steadily climbed, and now it's up to over 350, and I just wasn't, and this average days to complete complaints in the central complaint unit has gone up significantly over that same period of time. I just wonder what the explanation for that is.
So we do have some staffing issues, as Mr. Varghese pointed out. We've had some staff internally promote, and then filling those is taking some time, and then loss of knowledge and bringing in the new, getting them onboarded. We've also encountered recently with some of the facilities, they're requiring these attestations, which we needed to seek counsel on how to proceed with those, which is causing delays for us to get the records that we're needing to then, conduct our review.
I just know historically that's been a persistent concern from licensees and from the public about the length of time that it takes to get through the process. And so I just, yeah, I would appreciate whatever we can do to shorten those.
Absolutely. We're working on that as well and concerned about it.
Dr. Yip.
Well, first of all, thanks for the hard work. There are a lot of data here, and Sean also, and Reggie too. Few questions. One is that Sean mentioned the email need to match so that you can look into the tracking system. And I guess down the line, you would also have a way of allowing, for example, the licensee or the attorney that can log on with the authenticated email so that they can look at the tracking. And the second is that you said a standing meeting between enforcement and IT, as well as how to update, but also how to update the website. And let me give you an example, and then I bring on the third question. For example, there's a physician on probation, and there's certain criteria that the physician need to meet, such as pass the cognitive test, neurologic examination, etc. According to the medical staff, recently we have a case that actually we got an email from the investigator saying Dr. So-and-so, we can reach him and he failed his neurologic examination. But then on the website, nothing is mentioned about that. And the medical staff office kind of wonder what happened. So my thinking is that if my medical staff director cannot find that, the public would not know that. So maybe there should be a standing communication between enforcement and the IT team to update those information. And that brings up my third question is that I think Mr. Watkins' last meeting brought a point. We have such a long timeline between the complaint file to decision. And some of the case probably need to have some alert so the public can be alert that there may be a troubling physician out there that they need to be aware. I know it's a very complicated subject, and I hope that process being reviewed and being looked into. The last suggestion that I think I make the suggestion in the panel meeting that hopefully we can have a standing agenda for each panel about the probation physician so that we can know the case review, make decision 6 months ago, a year ago, where they are. Did they are they in compliance? Do they fail certain things? And so that we can make comment, we can make suggestions to improve the transparency. Thank you.
And if I can answer a couple of Dr. Yip's questions, I'll try to remember all there. But so first was they do have to right now the initial release, at least to everything we've designed for the complaint tracking system, it is only going to be accessible by the patient and the patient's authorized representative, the complainant, if they submitted a complaint on behalf of a patient. Attorneys, any other involved parties, at least for now, for this initial release, will be out of scope. The respondent will have no access. It's for the complainant to see the status of the complaint that they have submitted. So we can obviously look in the future to adding other users into some sort of a system like that. But yeah, for right now, it would just be the patient, the authorized representative. You mentioned the alerts to things. So yes, to inform the patient and the patient's authorized representative that a significant update has been made, that they'll want to log in and look into the complaint tracking system to see that update in there. They will receive emails, not necessarily from the complaint tracking system, but through another mechanism, through the BREEZE system itself. We're looking at setting up that'll say this event, an event occurred, because we can't put it in the email. Email is not considered a secure communication. So they'll basically get a notification saying, hey, go check out the complaint tracking system. There's something new in there for you to see, kind of a alert like that. So that'll be their kind of trigger to let them know, if you haven't checked recently, go take a look at your complaint here in the complaint tracking system is the way we envision that process working. And, as you mentioned, we're in constant communication with enforcement all the time, all of these activities and things like that. They're helping us with all the translations and things like that. And when discipline and actually changes to licensee statuses happen, Yes, if you're the complainant of that complaint, you would see that update in the complaint tracking system that, the complaint was closed and this, say probation or whatever happened, you would see an item in that activities list regarding that. But more importantly, for consumers in general, our iOS app, the app that we're working on updating, that will tell anyone who's not the complainant also, if they're following that doctor, they would get that notification there that, hey, that licensee's status changed, those kinds of things. So that's how we would envision the general public being notified about something like that, as opposed to just the individual, the complainant on that one complaint. I hope that got all your points there, but yeah, happy to answer any questions.
Other questions or comments from board members? We'll go Dr. Helzer and then Dr. Ayala Rodriguez and then Dr. Ballant.
Thank you. I have a question for Ms. Smith. In your report, you mentioned that there's an increase in cite and fine activity related to the CME audit, and I assume that means that there are more physicians who are not meeting our CME requirements. So what are our current results? What trends are you seeing? And what are the consequences of this that doesn't meet the audit requirements, or doesn't meet the requirements?
I'll need a little bit of assistance from Doug, our chief of licensing. He's kind of moving that work towards us. I haven't actually myself looked at those, and Douglas would be the one who would sign those citation orders if they're issued for those purposes. So.
Yeah, what we're seeing is there's been an influx in the letters that are going out. We're just not getting responses until we'll send out a 30-day letter, then we'll send out a final letter, and then once they get the citation and fine letter, that's generally what's creating a response from them.
So when you get the response, typically they have met the requirements, they just didn't respond when they got the letter?
They did not respond, but we're seeing many of them have not completed the CME requirements.
And what percent are compliant versus non-compliant?
So we audit 5% of license renewals each month, and we're probably seeing just generally about 530 that's the population, and I would say probably anywhere about 5% of those are resulting in a citation.
And what does citation imply? Just a warning or a fine?
That's a $1,000 fine.
And do they have to remedy the missing CME?
They do. So for their next renewal period, they'll need to show 100 hours of CME for both renewal periods and pay the citation.
Thank you.
Dr. Ayala Rodriguez.
Thank you so much. This question is for Sean, but if anyone else wants to chip in, that's totally fine. Virtually, there's open positions in every single department, and I think that that's relatively normal in any board, any industry, in any industry. In this particular case, the work never ends. Someone has to address it. We have to look at different things to make sure that we follow our timelines and everything. Have we considered any AI implementation to optimize or increase the efficiency in the departments? Because there might be something more similar or more simple, for example, like CME monitoring, CME trends, CME analysis, not necessarily the discipline, but something that we believe that could be safe for implementation and augmentation of staff efficiency and things like that. Because I believe that to a certain degree, that's a conversation that should happen in each department. How could the new technology help you? I know that we are doing a little bit of digitalization of certain processes, with licensing and things like that, but there's more technology available right now that potentially could augment the efficiency of the board. Thank you.
Happy to respond from that back here, if that's okay. Yeah, so it wasn't our normal updates there, but so the state has issued a policy on generative AI basically to make sure its main concern right now is that anything you feed into a generative AI system right now, you don't want that data leaking out publicly, obviously and stuff. And so along with the state policy, the Department of Consumer Affairs recently published to us their generative AI policy that aligns with the State Department's one, and the selected tool is called Microsoft Copilot Chat, and it's what you think of when you think of a generative AI. You're chatting with the AI, you know, kind of a thing, just like Chat GPT or anything else you've seen there. But the DCA's recently put out this policy. We're actually, it could have been released today, I don't even know, but Microsoft's making that available here in the government cloud. And the reason why that one was selected as the tool that is approved for use within the Department of Consumer Affairs is that we can feed into it whatever we want and it stays within our Microsoft tenant. So yeah, when you talk about generating CME letters, potentially chatbots on the websites, things like that, we can, without fear, feed in, you know, real names, real things like that, and have it generate form letters and that kind of, you know, stuff. It still needs to obviously be reviewed by an analyst and stuff like that before being sent out. But up until now, we've been prohibited, rightfully so, from feeding that kind of information into any open platform. So it was supposed to be released by Microsoft this week. And so, yeah, very soon, hopefully we'll be incorporating that into lots of business processes. Thank you for the question.
Dr. Bawat?
Thank you very much. I'll start off with you, Sean, your excellent presentation, and thank healthcare consumers for, I thought, which was a very productive opportunity for us to look at the complaint unit. And you've come a long way, and we're looking forward to seeing that in August. In terms of enforcement, I'm interested in understanding, I'm looking at the 24-25 numbers, and I understand each line item, right, is corresponding to something in statute that we have to look at: sexual misconduct, fraud, etc., conviction of crime. Are these numbers, because it's often hard when you start to talk about categorizing a complaint. So somebody has to say, well, gee, is it unprofessional conduct? Is it gross negligence? That may be a simpler bifurcation, but are these unique numbers that represents, that's not an overlap of a physician in several categories? Is that correct? And who determines that?
Well, those are being discussed. We do have mandated priorities. So obviously we're factoring those in, you know, impairment, sexual misconduct, the self-abusing, those are very high priority case. So those are being, considered and in our discussions. And, you know, there's always going to be some one-offs, you know, that aren't captured in that. You know, sometimes you just have to go with what the information you have, and like, this isn't feeling right. So we're going to need to make sure that we get this, you know, collaborative process going right from the start to ensure that we take care of it and it moves through the process so we can address it.
So for example, for unprofessional conduct, that's a very broad, right? And that can cover a myriad of things.
Sure.
Where people and health systems grapple with what is professional conduct and how is it defined.
Right.
So I would imagine that one's a little bit of a challenge category. Some of them may be less difficult. So in terms of the triage here, what would be interesting is, I think Dr. Thorpe may have asked it and Dr. Yip might have hit on it as well. When we have, like, for example, self-abuse and drugs and alcohol, 390, sexual misconduct, 496 days. How do we bump these up in triage? In other words, you've got all of these complaints, and making those a priority, which I know you're saying, and I believe you, but it just is the cycle time is a long time.
Sure.
Right. And where's it being held up?
So generally CCU, the Central Complaint Unit, is where everything starts.
Right.
And so those prioritization that are defined in statute, those are generally referred to the Health Quality Investigation Unit office. So for things such as the Business and Professions Code 8058, which is mandatory reporting for sexual misconduct, those will go straight to HQIU and they'll pick that up, and then they'll begin their process of their investigation, which generally, and I won't speak for Ms. Nichols and Ms. Whitley, but I have seen that those do require subpoenas, and sometimes there's some issues with those being accepted, and we might have to involve the Attorney General's office in those. So, you know, from CCU, we do triage, we do get those mandated priorities referred. We also have other, you know, concerns that we look at, like, you know, priors and history and things of that nature that we have information for. So we do try to get those as timely as possible, but there are sometimes some factors that cause delays and add to the aging.
So there's this pre-prep, you hand it off, and obviously in this country still you're innocent until proven guilty. I understand that, but I think that, you know, are there ways, and thinking back what Sean is doing, that communication to just say, you know, there's an alert. We don't have to be specific, but there's an alert. And I think that might be something as a board we might be thinking about, but I appreciate your responses. Thank you.
Any other questions from board members? Comments? Just one from me. I wanted to highlight again, we did this at the February meeting, the fact that we will not need any loans going forward. That's a significant achievement and demonstrates, you know, incredible financial stewardship on the part of our staff to get us out of that cycle of borrowing from other boards. I think it's, you know, a particular achievement in this budget environment. I think the May revise came out yesterday, which it's obviously a challenged budget. So thank you for all of your hard work to make that happen, and look for those efficiencies and opportunities. It is greatly appreciated, not just by us, but I'm sure by our licensees as well, who help to fund. Okay, we are going to move on to public comments. Are there any public comments from those in the hearing room? Morning again.
Good morning. My name is Tina Manassian. I'm a resident of Roseville, California. This was an interesting topic. Just recently, this past year, there was a fire outage in the senior community that I live in, and it caused us to suffer electrical power outage for over 3 months. We were on generators, but they were constantly going out. And the reason I'm bringing this up is because over 24 of us filed complaints with HCD, that's the Housing Community Development. And when I look back at the days when I used to attend all these meetings, I always thought about this would be a great idea to have a system where a complainant can file online and then kept abreast on all the different levels that the complaint goes through. Well, guess what? HCD does that. The Housing Community Developments, hcd.ca.gov. If you go to their website, they actually have that system in place right now, because all of us, a multitude of us, filed complaints with HCD regarding this power outage, because we discovered it was actually man-made. The fire was caused by someone that was unlicensed. So when I filed my complaint, I literally had an agent on the other end updating me every single time they had a question, they needed documentation, my ID, anything, my rental agreement, those kinds of things. And I thought that was amazing. And I'm listening to you guys talk about this. I think this is important for every patient, any complainant that's filing a complaint, because I would have loved to have this back then, because I was the one constantly calling the person that was assigned my complaint constantly, and all the other patients that I helped over the years. There was countless of us, and you'll hear their stories later on. But in addition to what you were talking about is keeping patients' complainants updated, I think you should also include subsequent arrest notices. And I'm going to tell you why. Dr. West was on his way to treat Becky Anderson in the hospital. He was arrested on the way there on a DUI accident that he caused on a family of 4. Now, if Becky's family and Becky had this, maybe an app in their phone that updated her with Dr. West's problems, that could have notified her, hey, your doctor just got arrested. You may not want him to come to the hospital and treat you. Something like that. If you guys get those notices, I think we, as consumers of California, patients, we should have the same right to know when our doctor's being arrested under DUI, drugs, cocaine, prostitution, you name it. We should have the right to know that, especially if it's someone that we're complaining about. Thank you.
Thank you for your public comment. Are there others in the hearing room?
Good morning, Marcus Friedman, Administrative Director for the Consumer Protection Policy Center at the University of San Diego School of Law. I just want to comment on one comment about the balance of innocent until proven guilty and whether or not waiting until complete sentences. Just a reminder, there are tools available for the medical board, especially when you guys first get the complaint and before it gets sent to the investigation unit. You do have some remedies to either hold or curtail a license at that time. There are also possibly other remedies to ensure that the public is safe. If there is a issue with a physician or surgeon that the board believes could be impacting patient safety. Those things can always be developed. I'm sure Ms. Webb can provide information as well. But just for the board's information, there's not a complete lack of action, especially before a final judgment is rendered. These types of remedies are normal in other types of court proceedings, especially at arraignment, if there is a finding of a dangerous person to the public. So I just want that to be kept in mind for the board. Thank you.
Thank you for your public comment. Are there other commenters present in the hearing room?
Hello, I'm Olga Airy. I'm a volunteer with Consumer Watchdog. A couple things stand out on item 5D that need more clarity. One, board staff engagement with organizations and groups. I didn't see the California Medical Association listed, and yet the CMA is supporting a bill known as AB 408 that the board proposed. This is the same bill that has zero support from any non-physician advocacy groups that I'm aware of, and not one single member of the public at past board quarterly meetings has indicated support of this bill. It's difficult to believe that not one member of this board or its staff has had contact with the CMA on this bill or anything else. Please clarify your engagement with the CMA in this report and future reports, given you have listed a lengthy list of organizations otherwise. Disclosure should be complete and thorough. 2, budget shortfalls and loans. It's very troubling to see the extent of this board's reliance on loans to fund its operations. Regarding loans for this year, the report references a potential new $27 million loan, but Mr. Vigues said today that no loans will be needed this year. Please clarify this. Regarding loans in general, do other DCA boards rely on loans with this frequency and magnitude? Do other state medical boards require loans to fund their operations? Without any wider context for these loans, it seems that you keep taking out loans to pay down prior loans. If this board needs a revolving line of credit to fund its operations, then how can this board propose a new health and wellness program for physicians or any new program? Where is a line item in the budget for devoting resources toward proposing this wellness program? I'm curious how much staff time has been diverted to proposing this program instead of enforcement. What concerns me is that you have been spending money you don't actually have, but must borrow. I'm hopeful you can turn this around this year, but your past history doesn't inspire confidence. Instead of devoting resources toward new programs, it seems a better use of time and money would be to meet with the DCA groups lending you funds for their best practices. After all, how are they able to stay solvent and with a large enough surplus to lend out? It seems other DCA boards have been more fiscally prudent than this one. Thank you.
Thank you for your public comment. Other commenters in the room? Okay, seeing none, Sean, let's open up the WebEx.
If you'd like to make a public comment on agenda item number 5, please do so by raising your hand. Type something in that Q&A window, or if you're in a call-only line, you can press *3. First up here, we have Marion Hollingsworth. Marion, you should be receiving that prompt.
Okay. Can you hear me now?
We can, Marion. Please go ahead.
Okay. Thank you so much. Good morning. I'm Marion Hollingsworth, patient safety advocate. Regarding the board's concern about the budget and reining in spending, I would like to suggest Googling doctors early in the investigation process. You probably think that's irrelevant and perhaps even stupid that I say this. However, I Googled a doctor who recently got an accusation because of an old discipline in another state. I won't say his name because I know the board doesn't allow that. But the reason I bring up this case is that the doctor died a year ago in prison in a foreign country. He had been there since 2019 for murdering his wife. This was the very first reference on Google, by the way. Bottom line is that you spent money investigating a dead man. If anyone had looked into this doctor's background or just Googled him like I did, they would have learned that he had passed. Knowing this would have saved the board a lot of time and money on an investigation and subsequent accusation from the AG's office. So my budget suggestion is to always look up a doctor, especially from another state, before launching an investigation. It could save you a lot of time and money. Also, if you're concerned about budgetary issues, shortening the meeting to 1 day does make sense, but the board should give the public adequate notice. What is listed as recess at the end of day 1 on the agenda is nebulous. That implies a break, not the end of the meeting. It could be interpreted that all bills would be heard. It doesn't say that day 2 would be canceled. You need to be more clear. Saving money should not equate to shortchanging the public. Thank you.
Thank you for your public comment. Next here we have Eric Anders. Eric, you should be receiving that prompt.
So Sean said something about emails not being secure, and that's not really a good excuse in this day and age of technology and computers. Secure email services are available all over the place, like MailHippo, which is actually HIPAA compliant. So if you wanted to use secure emails, you could. It just sounds like you guys don't look for these kinds of things to make it easier for complainants. As far as only the complainant being able to log in to see the complaint, it seems to me that all they'd have to do is give their login and password to anybody they wanted to, and anybody could log in using it. The app still logs you out. If you don't use it on a regular basis, the app will log you out. So you can't get constant reminders about doctors unless you use it on a regular basis. So Tina Manassian was talking about, how great it would be if it, told you, on a regular basis about a doctor. But if the app is logging you out, you're not going to get the notification. Then when you log back in, it sends you a backlog of all the notifications. Sometimes like we get, people that have a lot of doctors listed, we get a backlog of notifications for like 12 doctors all at one time. It just comes flooding in. So that's a problem with that app. And then lastly, I'm going to do kind of a Karen thing because I have kind of particular pet peeves about certain words. And since this word is used a lot with the medical board, the word is complainant. It's not complainant. There's no 2 T's in it. It's just a complainant, not complainant. Just my pet peeve. So thanks. Okay, goodbye.
Thank you for your public comment. Next here we have Kimberly Turbin. Kimberly, you should be receiving that prompt.
My name is Kimberly Turbin. I am from Reseda and I volunteer with Consumer Watchdog. I've noticed a significant turnover rate among your probation monitors, which raises some important questions. Since a considerable number of your disciplinary actions fall under the realm of probation, making these probation monitors responsible for oversight understanding the current staffing situation is crucial. Could you provide insight on how many probation monitors you currently have and how many probation cases each individual manages? Furthermore, with 4 vacancies in the probation department, how do you ensure effective oversight of probationary doctors practicing in areas where there are currently no monitors assigned? While we have sought this information before, it would be valuable to receive a presentation on your probation monitoring system. We would appreciate details regarding the numbers of probation monitors on staff, the allocation of doctors to each monitor, and the strategies you employ to maintain oversight of all probationary doctors, despite these vacancies. Thanks for your attention to this important matter. Thank you.
Thank you for your public comment. I don't see any additional requests in queue at this time.
Thanks, Sean. I'll bring it back to the board. Just checking one more time. Are there any more public comments in the room? Any other comments or questions from board members? All right, seeing none, we'll move on to agenda item 8, which is updates from external stakeholders. Again, we'll take questions and comments after we hear from DCA and HQIU. And first, I would like to introduce Judy Bucciarelli. Did I get your name right? From the Department of Consumer Affairs. Welcome.
Good morning, board members. Adjust this here. Again, my name is Judy Bucciarelli from the Department of Consumer Affairs, Board and Bureau Relations, and I'd like to thank you for the opportunity to present the DCA update to you today. My first item is regarding the governor's reorganization plan. In January, Governor Newsom released his proposed 25-26 state budget, which included a proposal to split DCA's oversight agency, the Business, Consumer Services, and Housing Agency, into 2 state agencies, the California Housing and Homelessness Agency and the Business and Consumer Services Agency. The proposed I'm going to refer to the Homelessness Agency as CHHA. The CHHA will oversee housing and homelessness solutions and safeguard civil rights. The new Business and Consumer Services Agency will be responsible for consumer affairs, licensing, and enforcement. The Department of Consumer Affairs would be among the 8 departments in this new agency. As part of the process in state government, the governor's reorganization plan was delivered to the nonpartisan Little Hoover Commission for review on April 4th of this year. The submission of the plan to the commission began an approximate 90-day formal review process. The commission held public hearings on April 23rd and 24th to receive testimony and for interested parties to provide input on the proposed reorganization. Our agency secretary, DCA Director Kirchmeier, and other impacted department leaders testified in support of the governor's plan and responded to questions from the commissioners. The commission is in the process of writing a report that will be submitted to the governor and the legislature. The report will offer a recommendation to the governor and legislature as to whether it believes the reorganization plan should go into effect. The commission sometimes offers recommendations for how the plan could be strengthened, either through administrative actions or subsequent legislation. The legislature will then have 60 days to review and consider the plan. The governor's plan becomes effective on the 61st day after it has been given to the legislature, unless either the Senate or Assembly adopts by majority vote a resolution to reject the plan. If approved, the Business and Consumer Services Agency will be created in July of 2025 with 1 year of transition and will become operative on July 1, 2026. In addition to several virtual briefings hosted by Agency Secretary Moss, there is detailed information available on the reorganization plan on the Business, Consumer Services, and Housing Agency website. We believe this is an extraordinary opportunity for DCA to better align with other consumer protection departments. A secretary within the governor's cabinet focused solely on consumer protection will only strengthen our mission, momentum, and delivery of services to California. DCA will continue to keep Board and Bureau leadership updated on the progress of the governor's reorganization plan. Next, I have an update on hybrid telework transition. On March 3rd, Governor Newsom issued an executive order requiring all state agencies and departments to update their hybrid telework policies for employees and increase from 2 to 4 days in office per week beginning on July 1st, 2025. On March 13th, the California Department of Human Resources issued guidance on implementation of the executive order. The guidance provides defined parameters for when agencies and departments can make case-by-case exceptions to the 4-day in-office minimum requirement. DCA has been working closely with a few programs on identifying additional space needed for this transition. DCA has been hosting biweekly meetings with Board and Bureau leadership to provide updates and respond to questions. We recognize that this transition will likely require adjustments for many employees, and we are working together to minimize the impact. We will continue to keep leadership updated on any additional direction received from CalHR. Next, I'd like to share some information on DCA's new Compliance and Equity Officer. On April 28th, Levi Hull began serving as DCA's new Compliance and Equity Officer. In this position, he is responsible for leading and coordinating department-wide quality improvement efforts to ensure consistency and regulatory compliance. This position oversees DCA's solid planning and training services, the Organizational Improvement Office, the Equal Employment Opportunity Office, and the Internal Audit Office, and also serves as the liaison to the department's Diversity, Equity, and Inclusion Steering Committee. As the department's equity officer, this position is dedicated to enhancing the diversity, equity, and inclusion, and accessibility policies, training, and activities throughout the department's programs. Levi brings more than 12 years of experience in leading multidisciplinary teams and driving strategic program development. With more than 9 years of experience in EEO compliance and program management, including nearly 3 years at DCA, he is an experienced leader with a deep commitment to fostering inclusive, equitable, and accessible work environments. As you know, your executive director is the chair of DCA's Diversity, Equity, and Inclusion Steering Committee and will be working closely with Levi. On behalf of the department, I would like to thank your executive director for his work and contributions as a member of this important committee. Next, I have a reminder about board member orientation training. Board members must complete BMOT within 1 year of their appointment or reappointment. BMOT will be offered virtually on June 18th, 2025, and again on October 22nd. Members can register for this training via the Learning Management System. And to close, each year during the first week in May, we celebrate Public Service Recognition Week. I'd like to close this report with a special thank you to the board, your executive director, and board staff for their hard work and dedicated efforts to achieve the department's mission of consumer protection. We are grateful for your partnership and appreciate your extraordinary service each and every day. This concludes the DCA update. Thank you again for the opportunity to be here with you today. And at this time, I'll turn the floor back to the board president, and I'm happy to answer any questions from the members. Thank you.
Thank you, Ms. Bucciarelli. We appreciate you being here, and we'll hold questions until after the report from HQIU. So Ms. Nichols and Ms. Whitley, please come on up.
Good morning. I am Chief Kathleen Nichols with the Division of Investigation. Also with me is Stephanie Whitley, Deputy Chief for the Division of Investigation's Health Quality Investigation Unit. It is our pleasure to provide the board an update on the Health Quality Investigation Unit, also known as HQIU. HQIU currently has 11 investigator vacancies, equaling a 13% vacancy rate. There are 5 candidates in background, one of which is in the final psychological and medical portion of the process. In the meantime, HQIU continues to screen new applications for each HQIU office that needs a position on a 30-day cycle so it can quickly fill the remaining vacancies. In addition, staff are actively participating in recruitment events statewide. HQIU has 14 new investigators going through the field training program. D of I provides a field training program for new sworn investigators lasting 15 to 20 weeks. Field training covers onboarding, observation of other investigators, and assignment to a field training officer who trains the new investigator on conducting investigations. Mandatory onboarding trainings include implicit bias, sexual harassment prevention, information security, and workplace violence prevention.
In addition to our FTO program, DOI also provides a multi-week internal training academy to new DOI investigators spanning 3 to 4 weeks. We call it the Mini Academy. The Mini Academy contains many unique training topics for DOI investigators, such as introductions to investigations, interviewing witnesses, interviewing subjects, administrative subpoenas, sexual misconduct by licensees, prescription drug investigations, reviewing of medical records, report writing, tactical operation plans and undercover operations, search warrants, undercover wires, impaired licensees, administrative disciplinary process, and many other various classes. HQIU has made good progress on cases over a year old and on the pending workload, as demonstrated in the updated graphs in the board agenda item 6B. In addition to sharing an automated monthly report with case status updates, HQIU leadership continues to hold weekly meetings with board staff to discuss cases, answer questions, and resolve issues efficiently. And this will conclude our update, and we will be happy to answer any additional questions you may have.
Thank you very much. Are there any questions or comments from board members? Dr. Yip.
I understand the California HR is trying to recruit some of the federal worker that lost a job. If someone has similar background, would that shorten your timeline as well as interviewed and training? And there must be some people with reinforcement background or investment background that may help to fill your vacancy. That's a 13% is a lot of vacancy.
We still have to go through the process. So for any federal employees that are interested in our positions, they would have to apply and be interviewed. They would still have to go through the background process. For those federal employees that might be peace officers in the federal system, there is a method through post where they can request a waiver. So the post would allow them to be a peace officer in California. And we have had a few candidates who have done that and been successful at getting that post waiver. And then we are able to hire them.
Other questions, comments? All right, seeing none, let's open it up for public comment. Anyone in the hearing room? Okay, seeing none. Sean, can you open it up for public comments on WebEx, please?
Yes, if you'd like to make a public comment on agenda item number 6, please do so by raising your hand, typing something in that Q&A window, or if you're on a call-and-only line, you can press *3 to toggle raising your hand. First request here we have is from Monty Goddard. Monty, you should be receiving that prompt on your end. There you go, Monty.
Hello.
We can hear you, Monty. Please go ahead.
Great. Again, my name is Monty Goddard. I wasn't planning on speaking this morning, but I do take interest in your meeting, so I've been observing it. But something that was just said caused me to ask this question. And I'll give you a little background. I'd say it was well over a year ago, maybe a year and a half ago. Your opioid prescribing guidelines are 2 years out now. And I've been disappointed in the impact they've had on the treatment of pain in California. I love the guidelines. They have not had an impact. So I periodically ask questions. And one of the questions I asked not long after they were distributed was whether or not the investigators had been trained on those new guidelines. And the response that was provided to that question was, they have been provided a copy. Now, I just heard it going down the list of things that the new investigators will be trained on are prescriber investigating or something like that, prescription investigating. And so I want to just ask my question again specific, and I'd actually like to have a complete answer to it. Are those guidelines being instructed, and I don't mean handed to potential investigators, are they being taught to the new investigators? That's my question. Thank you.
Kimachi? Sorry about that. At this time, I don't see additional requests in queue.
Okay, thanks, Sean. We will, oh, sorry, Dr. Thorpe, I didn't see your hand up.
Well, I didn't have anything before, but Monty prompted me to think about something. Well, I do have, I would like to have that question answered. Is that possible to have staff answer that question?
The answer to that question is yes. Besides just being provided a copy in our prescribing investigation class, the guidelines are gone over in great detail.
Okay, great. Thank you so much.
Thank you.
And I appreciate all you guys too.
All right, any other questions or comments? Okay, before we move on to agenda item 7, we're going to take a brief 10-minute break. So let's plan to be back at 11, I guess it'll be 11:17. Thanks, everyone. We're ready to get going, Sean. All right, welcome back. It's 11:19 a.m. We are back in session. As the Medical Board of California, we are moving on to agenda item 7, discussion and possible action on legislation. Mr. Bone.
Thank you, Madam President. Morning, members. Nice to be before you all today. It's been an exceptionally busy time in the legislature in recent months. Policy committees just finished reviewing and approving hundreds of bills, which are in the process of being reviewed by the Senate and the Assembly Appropriations Committees. Those two committees face a significant deadline next week, and in the first part of June, legislators will be working very long hours, voting on the bills that survive the Appropriations Committee ahead of a deadline for each House to approve bills that were introduced this year. In addition to all that, work on the state budget for the upcoming fiscal year is a huge legislative and administrative priority. As you heard earlier, the governor released his May revision yesterday to his budget proposal with a deadline under the Constitution to approve the budget bill by June 15. So lots of things going on right now. We have a total of 13 bills on the agenda today for discussion and possible action. So unless there are any questions beforehand, Madam President, I'm prepared to move to the first bill.
You may proceed.
Thank you. We will begin with AB 360, which would require the Department of Healthcare Access and Information, or HCI, to work with this board, the Osteopathic Medical Board, and unspecified higher education entities to assess physician education and training in menopause diagnosis and management, including various trends in practice patterns on this topic. Following this assessment process, HCI would be charged with submitting a report to the legislature by January 1 of 2027 with their findings and related recommendations to improve education, training, and health outcomes. Legislature recognizes that the board does not have the staff expertise to develop surveys related to this topic. Therefore, it is expected that the board's role would be limited to attending stakeholder meetings led by HCI and distributing electronic communications to the board's licensees, such as surveys that are developed or approved by HCI. Board staff believe that menopause is a worthwhile topic, and we are recommending a support if amended position to seek amendments to clarify that our role will be in fact limited to attending HCI-led meetings and the electronic distribution of communications to the board's licensees in furtherance of this effort. Happy to answer any questions, Madam President.
Thank you. Are there any questions from members? Dr. Thorpe?
So, Mr. Bone, just to be clear, I think what you've just stated is an excellent approach. It is the intent of AB 360 to, I mean, at one point, is it to mandate another CME for licensees in the state?
That's a different bill that we'll be discussing later. AB 432 is the CME bill. This is, I think, trying to get our arms around the
problem.
Yeah, right. And what does education, what does training look like? What do practice modalities look like? It's been a lot of conversation and some stories that I've read that talk about the lack of emphasis that menopause receives in postgraduate training and in medical school. And so this is an effort to, for the state to get its arms around that.
Dr. Tsai?
I have a question. Interesting to note that ACOG is against this. Do you know if there's a particular reason why they're against this?
Let me.
I think it's kind of ironic that, we're proposing, women's health initiative and the American College of OBGYNs is against it. I don't know if there's some issue with the legislation itself.
Bear with me. Okay. I understand that the information that I have in my analysis is out of date, Doctor, and that the ACOG removed their opposition based upon prior amendments. So I do apologize for the miscommunication. I believe the previous version of the bill, the previous version of the bill did have a lot of costs for the board, and it envisioned a much larger role for the board, which was addressed in a legislative committee hearing, and declining that call. And therefore, I believe that was at least I think that was the reason why the physician committee was concerned.
Okay. Any other, questions or comments? May I have a motion to approve staff's recommendation? Okay, who moved? Sorry, Mahmood? Mahmood, and a second from Dr. Yip. Let's move to public comments. Are there any comments on this bill from those in the hearing room?
Hello, my name is Lucas Evanson, and I'm speaking on behalf of the California Medical Association. CMA would just like to note, similar to ACOG, that we've since removed our opposition to the legislation following recent amendments. Thank you.
Thank you very much. Any other comments from those present in the hearing room? Okay, seeing none, can we go to public comments on WebEx, Sean, please?
Yes, if you'd like to make a public comment on agenda item 7A, you can do so now by raising your hand, typing anything in that Q&A window, or if you're on a call and only line, you can press *3. First up here, we have Savannah. Savannah, let me find you here in the list. Should be receiving a prompt there, Savannah. There we go. Looks like your line's open, Savannah.
Oh, can you hear me?
We can. Please go ahead.
Oh, okay. Very good. Hi, this is Savannah Dominicus with Assemblymember Pappin's office. I just also wanted to clarify that the OBGYNs and there's no opposition on this bill currently right now with the amendments that we took. Just want to clarify that and hear if there's any further questions. Thank you.
Appreciate your public comment. Next up here, we have Ryan Spencer. Ryan, you should be receiving a prompt anyway.
So, this is Ryan Spencer. I am the representative for the American College of OBGYNs. American College of OBGYNs. We did remove our opposition. Actually, thank the author for the bill in print. We do think analyzing medical schools and the current training, early education, to see where improvements can be made is an appropriate approach to see where there may be some voids. But yes, the bill has not been reanalyzed, and so it has not expressed our move to neutral. But we do appreciate the Aaron's presentation on the bill. Thank you.
Thank you for your public comment. This time, I don't see any additional requests in queue.
Okay, thanks. We will bring it back to the board. Are there any further?
I do have just a quick public
Go
comment.
ahead, sorry.
Marcus Friedman, Administrative Director for the Consumer Protection Policy Center. My comment is more just procedurally, especially going forward. I find it strange that there was a motion to act on this bill and seconded before public comment took place. That's just my concern going forward, that there's an action to do something and it's seconded before there's meaningful comment from the public. Thank you.
Thanks. Any more comments?
I guess in response to that, I mean, it's pretty typical in administrative or any kind of a body that's operating on with rules of order to make a motion and second it and then do the discussion and then vote. So I'm not sure that it's inappropriate to make a motion and second it with consideration for public comment and other comments that are being made, and then to vote on it at the end of that discussion.
Yeah, there's absolutely no problem with how the board proceeds on this. There's flexibility in the Open Meeting Act, and this is the typical process where a motion second is made and then we go to public comment. On occasion, we take public comment first, and that's also allowed.
Exactly. And I would add is a vote is done after that. So people have all the things to listen before they vote. So it can be, thank you, Kerry.
Right. And that doesn't stop if necessary to amend the motion, if that's the will of the board.
Thank you.
Thanks, everyone. Okay. Is there any further discussion amongst board members? Dr. Ayala Rodriguez.
Thank you so much. Aaron, we have a question. So between AB 360 and AB 432, both of them like talking about menopause. My understanding is that 432 is more specific, also provides like some recommendations about pharmacological coverage and things like that. Because like my only comment towards this is it possible to kind of reconsider for AB 360? Yes, HCAG is going to work towards identifying gaps and then eventually provide recommendations towards treatment, and obviously including like the health plans towards that, because from my perspective, like AB 360 and AB 432 could be a little bit redundant, like trying to achieve the same thing like with different interventions. I believe that AB 360 kind of says, this is an issue, let's look at the issue and eventually find the actual recommendations. Whereas like AB 432 goes more into just go on to this.
The two bills definitely take different approaches, Doctor. So yes, I would agree that 360 is focused on, again, getting the state getting its arms around what's currently happening. And then determining in the future, how things in state policy should differ. This is be a publicly available report, I expect, and so that would be available to anybody who wished to avail themselves of that. 432 is definitely more immediate in seeking to impact physician ongoing education and training through CME, and then, the insurance requirements. So they're taking, different but arguably compatible approaches to the topic.
Other discussion? Okay, seeing none. Ms. Struther, if you could please perform the roll call vote.
Dr. Ayala Rodriguez,
Yes.
Dr. Bolat,
Yes.
Ms. Chung,
Yes.
Dr. Helzer,
Yes.
Dr. Mahmood,
Yes.
Dr. Thorpe,
Yes.
Ms. Torres,
Yes.
Dr. Sai,
Yes.
Dr. Yip,
Yes.
Ms. Lawson.
Yes. All right, that passes unanimously. Next up, AB 408.
AB 408 is the board-sponsored bill to create a physician health and wellness program, or PHWP, consistent with national best practices to prioritize early intervention in health conditions that impair or could possibly impair a current or future board licensee from practicing in a reasonably safe, competent, and professional manner. Reinforcing one aspect of the need for this bill, just yesterday, MedPage Today reported on a newly released study of ACGME data showing that suicide was the leading cause of death among residents and fellows who are in training between the years 2015 and 2021. Since the prior board meeting, AB 408 has been approved in 2 policy committee hearings without any no votes. The first was in the Assembly Business and Professions Committee, which Ms. Lawson joined us for, and the second in the Assembly Judiciary Committee. Next week, we expect a hearing in the Assembly Appropriations Committee. During this time, we've also met with some bill opponents and look forward to continuing to work with them and determine if it is possible to resolve or at least mitigate their concerns. One group that I neglected to include in the analysis is that the Consumer Attorneys of California have an opposed unless amended position, so I apologize for leaving that out. The future legislative deadlines are included in the analysis and would dictate the timeline of the next steps for the bill as we hope it continues to progress this year. No action is required on this item, Madam President, and I'm happy to answer any questions.
Thank you, Mr. Bone. Are there any questions from board members? Seeing none, I think we will open it up for public comments from those in the hearing room.
Hi, thank you guys. Good morning. So I'm Christina Menor. I'm Dr. Anesthesiologist in private practice in Los Angeles, and I'm also the president-elect for the California Society of Anesthesiologists. I'd like to definitely support the board's efforts in AB 408 and would like to continue to support on behalf of the California Society of Anesthesiologists. This important legislation authored by Assemblymember Berman will authorize the medical board to reestablish the Physician Health and Wellness Program, ensuring that physicians can access the compassionate, confidential support that they need to recover from substance use disorders and mental health challenges. Physicians, including anesthesiologists, work in very high-stress environments and have become more demanding in recent times. We're all working longer hours, taking care of older and sicker patients. We need anesthesiologists. We need anesthesiologists to be healthy, and we need them in all of our locations where we provide anesthesia. Intensive care units, labor and delivery units, operating rooms, ambulatory care centers. We need our physicians to stay physically and mentally healthy to continue to provide the best care for all of our California citizens. I think that AB 408 will create new tools within this board to help physicians manage the effects of burnout, prolonged stress, trauma that come in while they treat their patients. 408 is an important step in protecting the mental and physical health of medical professionals that our patients rely on, allowing them to recover and return to providing the best care possible. We continue to support the board's efforts to move AB 408 forward, and thank you for your consideration.
Thank you for your public comment. Next commenter.
I'm Kay Funk, a retired physician who moved from Washington State to San Mateo 3 years ago. I'm here to speak to express opposition to AB 408 from the Stanford Medical Alliance for Disability inclusion and equity, and their partner organization, Disability in Medicine Mutual Mentoring Program. I reviewed the testimony given to this board by the Washington Physicians Health Program and FSPHP in May of 2024. Those advocates repeatedly called their program best practices and evidence-based, as did Mr. Bone. But in contemporary medicine, those words are very specific claims that the medical interventions advocated are founded on a base of well-designed and well-conducted research and scrupulous vetting to avoid bias. All respected medical publications adhere to these standards. Standards are epitomized in the Cochrane-style review and guidelines. And the guidelines of the U.S. Preventative Services Task Force are another accepted model on the standard of evidence expected for implementation of public health policy by changing medical practice. WPHP and FSPHP have never demonstrated comparable evidence. Presenting last year to the Board of Medical Professionals, it would have been appropriate to offer a comprehensive and public data presentation, but they did not. There was a PowerPoint which referenced 2 articles, and both of these are old and neither was well designed. Other than their annual reports, which are not in scientific paper format, PHPs do not publish their internal data. The Washington PHP is required by the Department of Health to contract to annually report suicides and ADA complaints about the program, but these do not appear in their public-facing annual report. PHPs are not known to have published outcomes data for any other diagnosis than substance use disorder and cannot be considered competent to treat any other diagnosis. We should recognize that medical science is under attack and being bent to political pressures. It's incumbent on medical leadership to defend scientific method. The California legislature should not be persuaded to start this far-reaching program without an adequate evidence base, and we urge that this initiative be placed on hold until we see an unbiased and scholarly review of PHP evidence. Thank you for your time.
Thank you for your public comment. Other commenters in the room?
Good afternoon, board members. Marcus Friedman, Administrative Director for the Consumer Protection Policy Center at the University of San Diego School of Law. CPPC remains in opposition to this bill. Back in February, in our meeting with the medical board, we raised new issues as to whether or not this medical board has looked into data as to whether or not these programs actually protect patients and whether or not there's data to show that it increases protection of the public. We were told that that data is out there, and that's when we began to look at that data. We have found, and we've testified in our legislative opposition, that in states that have best practices, and what we revealed through Public Records Act requests, is in Washington and New York, they get about enrollment each year far less than 1% of their total licensed population. We're talking 0.2%. As well as not a huge difference in the amount of complaints and the amount of those that are on probation with substance use disorders. Based on this information, it certainly seems that these types of programs do not move the needle any which way when it comes to patient protection. And we believe that looking at the patient satisfaction within these best practices or participant satisfaction is not an accurate assessment of success of these programs and whether or not they protect the public. Business and Professions Code 2001.1 states that the priority of this medical board is patient protection. Any other interest that this board seeks to promote, patient protection is first. If this board isn't asking those questions themselves, it needs to ask itself whether or not it's holding up to that statutory duty. We also raised antitrust concerns when it comes to these types of programs. A medical board mostly made up of the licensees that they seek to regulate and to license cannot claim state action immunity if challenged when making these decisions to divert a licensee away from discipline into these types of programs. It is not to say that you would lose antitrust. It's just that state action immunity cannot be used when these challenges arise. And this is something that the Judiciary Committee, in their analysis, has agreed as well, that this is a valid concern that the board should be aware of. I encourage this board to remain critical, to ask whether or not these programs actually benefit patient protection, because all the data that we have seen so far shows that it doesn't really move the needle either which way. And since this board has a duty by statute to prioritize patient protection, it needs to be asking itself those questions. Thank you.
Thank you. Other commenters in the room?
Okay, thank you. Tina Manassi, and I'm from Roseville. I'm also a volunteer with Consumer Watchdog. As I shared earlier, I am a victim of a doctor who was a participant in the diversion program. He was a substance abusing doctor. I was hurt in 2002. The harm I endured at the hands of Dr. Brian West still haunts me to this day. I wasn't alone in my suffering. There are countless other patients who were harmed, and tragically, many of them lost their lives because of his actions. When I first learned of Dr. West being in the diversion program, it was by accident. I just happened to find out he had a hearing with the administrative law judge. So I went down there with my husband, and what I heard was shocking to my core. And it made me angry that he was at his all-time high with his alcoholism during the time of my surgery. I wouldn't have chosen him if I would have known that. Of course not. Like I said, I'm not the only victim. I told you about Becky Anderson, but if you go to medicalcomplaint.blogspot.com, you'll see many of the victims of Dr. West, a participant in the defunct diversion program from years ago. When I found out about the diversion program, I called every news station, every newspaper, every radio personality to tell my story. And many people heard that story, and many other victims came forward. At a medical board meeting in San Francisco, I asked the board members, if it was your mother, father, brother, sister, daughter, or son, would you allow them to be treated or operated by a doctor in your diversion program? Raise your hand. Not one member raised their hand, and diversion went away, so we thought. I'm here to provide you with real-life examples illustrating how diversion programs not only fail to protect patients, but also enable substance abusing doctors to fail themselves to perpetrate their destructive behaviors, ultimately harming patients and those they are sworn to heal. The previous program was riddled with critical flaws that this bill has chosen not to address. A glaring issue lay in the practice monitors. Take, for example, Dr. Brian West's monitor, who was none other than his office manager. She lied about his participation in group meetings and even went on so far as to warn him about impending drug tests. His practice monitor, officer, manager, was also his drinking buddy. Their close relationship, combining professional oversight with friendship, obviously a conflict of interest. When Dr. West arrived to take his board certification exam in Las Vegas, he smelled so heavily of alcohol that the test monitor had no choice but to refuse him entry, identifying his condition as unacceptable. While Dr. West may symbolize the profound shortcomings of California's diversion program, he certainly wasn't alone. His story reflects a troubling reality. Countless substance abusing doctors slipped through the cracks, inflicting harm on even leading to ultimately deaths of patients. Many patients. I was involved in advocating for Donda West's law, named after Donda West, the mother of Kanye West, who tragically lost her life following a procedure performed by another substance abusing physician. This doctor, Jan Adams, eventually lost his medical license. We must ask ourselves, How many more lives were lost? How many individuals suffered lifelong consequences while these doctors continue practicing under a diversion program that seemed to prioritize their protection over the safety of patients? My time's expired? Okay, that's my story. And I'm not going anywhere. I'm back. I've been following medical boards for years, but I had to take care of myself the last 10 years. But I will continue to come back and I will talk to the media to keep the spotlight on this. Do not bring that program back. Thank you.
Hello, my name is Lucas Evanson, speaking on behalf of the California Medical Association. The absence of a physician health program in California has long placed both physicians and their patients at a disadvantage. Physicians, like anyone else, are vulnerable to mental health challenges and substance use disorder. Without a structured, confidential wellness program, too many struggle in silence, unable to seek help without fear of stigma or professional repercussions. By authorizing the creation of a confidential, evidence-based physician wellness program mirroring those in other states, AB 408 represents a significant step forward in prioritizing both physician well-being and patient safety. This proactive, public health-oriented approach has already been implemented in 47 other states and reflects best practices endorsed by the Federation of State Medical Boards. CMA has expressed its support for AB 408 alongside President Lawson and Mr. Varghese through public testimony and legislative committees and continues to support the board's efforts to stand up a program. CMA would like to thank the board and board staff for their leadership and courage in working to make this long overdue solution a reality. Thank you.
Thank you. Next public comment.
Thank you, Carmen Balber, on behalf of Consumer Watchdog. We continue to oppose your bill because it repeats the mistakes of the past failed diversion program. It puts patients at risk of harm at the hands of doctors who continue abusing substances while being allowed to practice secretly in the diversion program. And when that happens with a new program and someone is hurt, that's going to be on this board. As we've expressed many times, we strongly believe this is not a program that the board should be running, but we offered staff an amendment that could mitigate the worst dangers to patient protection. It's a simple change. If a doctor is referred to the diversion program by the board because the board learned of their substance abuse problem, the board needs to ensure that a violation of the program, whether it's a failed drug test or other violation, gets reported back to board enforcement and apply the oversight and accountability measures of the uniform standards. That kind of oversight would address the most dangerous way that the bill makes patient harm more likely by hiding doctor substance use when that information should be public. And frankly, that amendment reflects the concerns that several of the board members addressed in prior meetings where members of the board suggested there should be more rigorous oversight criteria for board referrals, that there should be a higher safety bar if there's non-compliance, and that you should start with true self-referrals and focus on doctors who are unknown to the board first. But none of those concerns were seriously addressed. And when we brought our amendment to staff, it was rejected. I have a feeling that most of you never really heard the details of it, which is why we're bringing it to you today. Many of you voted to seek this bill with the assurance that there would be the opportunity to amend it in the future. This is your chance to do that. The amendment also makes a critical distinction between, on the one hand, doctors who are known to the board because the board was sent an arrest report or a patient complaint or a hospital referral because of disciplinary action, which means the danger to patients is already acute. And the doctors that many of you seem to be concerned about who either have a mental health issue or are truly voluntary participants. And there's a very big difference, but the bill's definition is very Orwellian for participants right now. It calls voluntary participants folks who were referred to the board by the board in order to avoid discipline.
I'll just add that regarding the uniform standards, they were put in place when the old board shut down the failed diversion program to make sure in future, if there was ever another diversion program, there would be accountability and oversight. This bill eliminates those patient protections and leaves decisions about what the board does or does not know to the program, and that's a real problem. So I would just ask for a show of hands. How many of you believe that when a doctor is sent to diversion by the board in lieu of discipline,
Just a reminder, this is not a back and forth.
I'm
Ms.
just
Bauber, you know
telling you
that.
what,
and
I
your
know
time
that,
is
but
up.
I think you should ask yourselves this question. Should board enforcement staff be notified if a doctor fails a drug test so an investigation can start? And I pose that as a discussion point for all of you. Thank you.
Thank you for your public comment. Next commenter, please.
Thank you. Hello, I'm Alka Airy. I'm a volunteer with Consumer Watchdog. There are a couple things in this report I don't understand. For example, the report states the bill, quote, provides the board with new authority to prevent harm from occurring. How exactly are you preventing harm with this bill? And for whom are you preventing harm? This program would essentially allow physicians to hide their substance abuse problems from their patients. If a physician in this program acted negligently and breached the standard of care, would their substance abuse be disclosed to the injured patient or to a jury? This board should be promoting transparency rather than opposing it, especially when patient safety is at stake. Also, the report says nothing on how you expect to fund the program or how you intend to seek funding, and yet isn't that the elephant in the room? Do you intend to obtain another loan or tap the $27 million already in the governor's budget? If private funds will be sought, it will be important to address any perceived or actual conflicts. Physician impairment is a challenging issue to address because we all have compassion for the suffering. But when it occurs on the job and death is a possible consequence, it matters. Physicians do not have carte blanche to treat patients. They must earn that privilege, and for that effort, they are greatly rewarded. But at a certain point, we must all take responsibility for our actions. We can't blame others or hide behind excuses. We must face our demons in order to defeat them. Physicians who abuse substances while on the job are not the victims here, and yet this program would essentially treat them as such. I've already shared my sister died from a preventable anesthesia error. What I haven't yet shared is the physician's noticeable impairment at the time. The first time I met her anesthesiologist after the error, he was disheveled and unkempt in appearance with bloodshot eyes and slurred speech. In the minutes before she was connected to ECMO to save her life, and I was allowed one last chance to say goodbye, potentially forever, the anesthesiologist entered the ICU and laughed in my face. He seemed to think it was funny that my sister was minutes away from death. I'm not a physician, but as a former investment banker, I also wasn't born yesterday. He was clearly impaired. I remember that moment like it was yesterday and have prayed that he hasn't hurt anyone else ever since. If he had entered the operating room on that fateful day in the same condition that I encountered, then I wish someone had said or done something about it. But they didn't, and my sister died. Here's her picture. This medical board can't do it all. You can't license and discipline physicians and also provide physicians with supportive care. When you protect the privacy of impaired physicians through a program like this, you harm patients through your complicity. I wouldn't want that on my conscience. My fellow patient advocates have expressed their concerns about this program many times, but none of our concerns have been addressed. It's been a disappointing experience and shows this board doesn't adequately represent the public's interests. It seemed the board was working toward building trust with the public, but I see that is no longer a priority given the way this bill has been handled. Thank you.
Thank you for your public comment. Next commenter in the room. Okay, seeing none, we'll open it up for WebEx public comment, please, Sean.
Yes, if you'd like to make a public comment on agenda item 7B, please do so by raising your hand, typing something in that Q&A window, or if you're on a call-only line, you can press *3. First up here, we have Ryan Spencer. Ryan, you should be receiving that prompt.
Thank you, members. Ryan Spencer on behalf of the American College of OBGYNs and the California Radiological Society, simply just thanking you for sponsoring this bill, and we support it as well. Thank you.
Thank you for your public comment. Next here, we have Maria Bar Navarrete. You should be receiving that prompt. Okay, I don't see Maria's line opening.
Can you hear me?
Now we can. Yes, please go ahead.
Hello?
We can hear you, Maria. Please go ahead. Okay, I'll give Maria here a minute to. Nope, she just disconnected here, so we'll see if she requeues up. Next here we have Xavier De Leon. Xavier, you should be receiving that prompt. We can hear you, Xavier. Go ahead.
Perfect. Hello again. I'm Xavier De Leon from Bakersfield and a volunteer with Consumer Watchdog. I've spoken at the past public meetings raising concern about AB 408 and how it's leaving families like mine without real protection. Nothing has changed and we are still concerned. We participate in the regulatory process in good faith. We believe we were moving forward together, but instead the board switched directions and supported a bill that takes away a lot of the protections we've counted on. This new program you're pushing seems designed more to support physicians struggling with substance abuse than to protect the public. Where is the same level of urgency for safeguarding families like mine? As a board, your job is to strike a fair balance between the rights of doctors and the safety of patients. For families, it's simple. We want to survive the care we receive and return home to our loved ones. That's not too much to ask. We understand the importance of encouraging physicians to seek help, but the numbers from the past programs do not support the idea that many are voluntarily doing so. If you move forward with a new program, it must reflect a better balance, one that prioritizes both accountability and compassion. Thank you.
Thank you for your public comment. See Maria back here. I'm going to try sending her that request again.
My name is Maria Ibarra Navarrete. I am from San Jose. I am a volunteer with Consumers Watchdog. I find the issue of confidential programs for substance abusing physicians profoundly troubling. What is even more alarming is the lack of consequences for participants who fail these programs. In every conversation I have had with members of the public, there's a uniform reaction. A substance abusing doctor should not be permitted to practice medicine. People are shocked that this board would prioritize a physician's ability to work over the safety and well-being of our lives. This issue resonates deeply with us, as many of us have endured the unimaginable pain of losing a loved one. In the most tragic circumstances, we have tirelessly sought accountability from providers responsible for this harm, only to be repeatedly let down by this board. Now, it feels as if you are failing us again. What is the goal here? Your focus appears to be on crafting a program that garners to support physicians, yet it seems you are willing to jeopardize the lives of our families in pursuit of that objective. This is not just a matter of policy, it is a question of moral responsibility that should be weighed heavily.
Maria, can you hold on one second?
Yeah.
I'm sorry. I think
That's what happened to me earlier.
no, we lost network here in the room real quick. I still have Maria on here, but it's reconnecting here. Just a second, Maria. We'll restart your time. I'm sorry, you got cut off there.
Okay.
Not sure what happened there, Maria. Can we reset Maria's timer? I left it at that before she left. I'm sorry, I was listening to my headphones and I didn't hear where she got cut off, so I just suggest we just restart. Maria, would you mind restarting? I'm sorry.
Sure. Yeah. Thank you. Again, my name is Maria Ibarra Navarrete, and I am from San Jose, a volunteer with Consumers Watchdog. I find the issue of confidential programs for substance abusing physicians profoundly troubling. What is even more alarming is the lack of consequences for participants who fail these programs. In every conversation I have had with members of the public, there's a uniform reaction: a substance abusing doctor should not be permitted to practice medicine. People are shocked that this board would prioritize a physician's ability to work over the safety and well-being of our lives. This issue resonates deeply with us, as many of us have endured the unimaginable pain of losing loved ones in the most tragic circumstances. We have tirelessly sought accountability from providers responsible for this harm, only to repeatedly be let down by this board. Now it feels as you are failing us again. What is the goal here? Your focus appears to be crafting a program that garners the support of physicians, yet it seems you are willing to jeopardize the lives of our families in pursuit to that objective. This is not just a matter of policy, it is a question of moral responsibility that should be weighed heavily on all of us. Thank you.
Thank you for your public comment. Sorry about whatever happened there as well too, but hopefully we stay stable here. Next up here we have Eric Andrist. Eric, you should be receiving that prompt.
Okay, first, Carrie, stop interrupting people needlessly. You're always on a power trip. It's interesting how doctors and their union and the CMA are in favor of this. And remember that only a third of California's doctors are members of that club. And all the patient safety advocates are against it. Remember, you protect the public, not the doctors. Physicians can go to a private program like the majority of other workers in this country who don't have the option of such a program, coddled by the CMA, who always wants to protect their members at the detriment of patient safety. Why would doctors need such a program any more than any other worker in this country? Lots of doctors make a lot of money and can afford to go to private clinics. Why would any doctor want to have a board like this spying on them during their recovery? This board simply wants another way to make deals with doctors to make life easier for them without thinking of patient safety first, and to stroke the CMA who pulls this board's strings anyway. All these years since the other diversion program was dissolved, this board has feigned being in support of transparency to the public if any health and wellness program were to come forward. Now here we have someone in the legislature trying to take transparency away once again, and members of this board actually considering it. Anyone who votes in favor of this will no longer ever be able to say that they care about patient safety going forward, and will expose their alignment with the manipulative CMA. We will keep track of the votes on this bill in particular, as it will expose exactly where you stand on public transparency and safety. Remember, it's not this board's mandate to do anything other than protect patients, not their doctor members. You know, we often bring up something to light that Christina has a hissy fit over and tries to publicly shame us and put us in our place, and then we have no avenue to respond to her and correct her unless we do it on another agenda item. If you take public comment before the board comments, we have no recourse to speak about what the board members then say. Thank you.
Thank you for your public comment. Next, here's Marion Hollingsworth. Marion, you should be receiving that prompt.
Okay, do you hear me?
We do. Please go ahead.
Good afternoon. This is Marion Hollingsworth, patient safety advocate. I'm calling in to express my opposition to SB 408 because it takes away full informed consent from patients regarding their own health care. Regarding the person who spoke on behalf of anesthesiologists, I have a list of at least a dozen anesthesiologists within the last year alone who have been disciplined or have received accusations or even suspended for their drug use. These are all doctors who have taken advantage of the drugs that are literally within their reach while they work in the OR. By having this program confidential, you are enabling these doctors to not only have access to drugs, but to deny patients the right to refuse to have an impaired doctor work on them. Please don't take informed consent away from consumers. I'm sure you wouldn't want to take a chance with one of your loved ones or yourself. Consumers shouldn't be required to put their safety at risk in order to protect the reputation and financial status of any doctor. And finally, your claim to have this diversion program to protect the patients is just bogus. The investigator in my case told me it was the board's purpose to keep doctors in practice for as long as possible. When I asked her, what about public safety? She goes, oh, that too, like it was an afterthought. Please honor your mission statement to protect patients and vote no on 408. Thank you.
Thank you for your public comment. Next here we have Michelle Montserrat Ramos. Should be receiving a prompt on your end. Hi, Michelle. Looks like your line's open.
Good afternoon. I am Michelle Montserrat Ramos, and I am with Consumer Watchdog. This is not my first time opposing this program. To quote the powers that be, the pursuit of a new diversion program never stopped. The powers that be continuously sought to bring the program back, and I opposed it in 2008, 2009, in 2011, and again in 2012. We were successful in stopping those bills, and I was at the Capitol opposing those bills. Many of those years, Tina and I united our efforts. It's essential to highlight that during those legislative fights, the medical board also opposed those bills, understanding its commitment to California families. Then came 2016. We lost, yet our only beacon of hope for California patients was SB 1441, the uniform standards which came to be largely from a little remembered diversion hearing in 2008, where I was also given a last minute opportunity to testify before. The medical board opposed those bills. This leads us to a critical question. What is stopping you, this board, from striking a balance between physician rehabilitation and the paramount importance of patient protection with AB 408? Our concerns are, this board has categorized voluntary participants as substance abusing doctors that voluntarily enter the program, along with those who are referred by the board to the program. You have yet to make that distinction in this bill, that there is a difference between participants who voluntarily enter and physicians that are board referred. It is a distinction that must not be overlooked. We have met with board staff twice. We proposed an amendment to require that board referred participants are reported back to the board when they fill aspects of the program. And that the program must report the information to the board, specifically their names and the reason why they failed the program. It's time for the board to recognize the importance of accountability alongside the mission of rehabilitation, ensuring that patients are also protected. The board has refused our proposed amendments, asserting that they do not align with this board's vision. Board members, is this truly the vision you embrace? I can tell you, this was not the vision held by the previous members of this board. Moreover, the board's claim that California has been without a diversion program for 17 years is a little misleading. SB 1177 was passed in 2016, requiring this board to establish a diversion program contingent upon adherence to the uniform standards. Yet for 9 long years, this board chose to not recreate the program. This current board has prioritized the interests of the profession over the safety and well-being of California families. This is not acceptable to us, the public. I ask you, board members, is this truly acceptable to you? Thank you.
Thank you for your public comment. This time there's no additional requests.
Thank you to all the public commenters. Are there any
Apologies.
final public commenters in the room?
Sorry, President Lawson, last second one came in.
Okay.
Tracy Dominguez, should be receiving a prompt.
Okay, can you hear me?
We can, please go ahead.
Hello, I'm Tracy Dominguez and I'm from Bakersfield, and I am a volunteer with Consumer Watchdog. As an advocate, I talk to a lot of people in my community. Everyone hears about what happened to my daughter and my grandson. Now, everyone I cross paths with who gets to hear about the substance abuse doctor issue. And now how this board is trying to pass legislation that will take away existing protection for the public. Everyone I talk to is shocked that this board allows substance abuse doctors found under the influence in a hospital to continue to practice. They also are shocked that this board is willing to throw away built-in legislation consequences for doctors that fail a program because of your overall concerns. It is with a professional instead of a patient's lives. Okay. You may say that consumer protection is paramount, but we want to see your actions proven to us. Providing consequences for at least the board referring physicians would provide some form of protection for the public and substance abuse licensees. You are all worried about their reputations. You should be concerned about their staying on the path to truly seek help, not just to have a program to say you have a program. Thank you.
Thank you for your public comment. This time there are no additional requests in queue.
Any other comments from the public? Okay, seeing none, I'm going to bring this back to the board. This isn't a vote item, but I'd just like to ask our staff counsel, Carrie Webb, to, I guess, provide an update on some of the issues that we've heard raised during public comment. There has been a lot of work going on. That work was delegated to the board president and the board vice president to work on things during, as the bill has made its way through the process. So I just like Carrie to address some of those. And then, of course, any questions from all of you to either me, to Mr. Boner, to Carrie.
Sure. I just wanted to address some of the statements made and try to clear up the confusion. First of all, we know that substance abusing physicians and physicians who have other health conditions are already out there. They're already practicing. And yes, there are treatment programs available, but there are barriers for people to seek the treatment, whether people want to believe that or not. There are barriers, there are financial barriers, and there are concerns about that physicians have, that if they seek help, they will face discipline. What we want to do is shift the culture and invite people to seek help or invite their colleagues, friends, families to refer them to a confidential program so that they can get help. If the board refers a patient not through discipline, but not through a order of probation or some other disciplinary tool, that person is still a voluntary participant. They don't have to go through the physician health and wellness program. The board would then have to determine if there's sufficient evidence to pursue a disciplinary action, which we know takes an incredible amount of time and resources. A physician health and wellness program, in contrast, can move much more quickly if the person is impaired. So they can tell the person, you can't practice right now. They can contact the hospital, this person can't practice right now. If the person doesn't agree to those restrictions, that is reported to the board, and the board uses its existing enforcement tools, which could include an interim suspension order, but the board has to have its case ready to go within 30 days after that to keep that order in place before discipline's imposed. So the other significant thing to remember is that if patient harm occurred, or if sexual misconduct with any person is involved, the board can still refer the person to the program, but not in lieu of discipline. Enforcement action will still be pursued. As far as reports of violations to the program, those will be reported to the board through the executive director, his designee, which may be a committee established to help advise the executive director as to whether it's appropriate for this person to continue in the physician health and wellness program, or if it's time now to seek enforcement. What's different in this bill from existing authority, which, remember, we went through the process of drafting regulations, having significant public comment and input that led to a shift in the approach to pursue best practices pursuant to Federation of State Medical Boards, Federation of State Physician Health Programs, other individual states who've had longstanding experience in this space. But what's different under this current bill is that we're seeking an exemption for voluntary participants from the uniform standards for substance abusing licensees, because that is a barrier for people seeking help because of the publication on the licensee's profile if they're restricted from practicing, and because of the requirement that major as well as minor violations, which could be the person missed a support group meeting, the person missed a call-in, they could have been ill, they could have been in an accident. A lot of things can cause someone to have a violation that doesn't necessarily mean they have returned to an impaired condition or reached an impaired condition. So this program is designed to address the barriers for people getting help, whether they're voluntarily or because they're voluntold. Physicians who are referred pursuant to an order of probation will still be subject to the uniform standards. That's not changing. We're not seeking to change the uniform standards. We're seeking to have an exemption for people who are already not subject to the uniform standards. So I'll conclude there, and I'm happy to answer any questions.
Thanks, Carrie. Are there any questions or any discussion amongst board members about AB 408? Dr. Yip?
I think the gray zone of concern that I gather from several meetings is, let's say a physician A who know he has a problem with substance abuse and he or she may not be afford to see a private psychologist, et cetera, and may or may not be on the physician well-being committee of a hospital, and he or she hear about this program and want to go to the program to verify by the professionals, say, okay, you need to be intensively treat our patient, to adhere to like support group, sober, et cetera. And this entity had a discussion with the board staff that we have this physician who has not caused harm yet, but potential to cause harm to himself and the public, which is the patient. I think the concern of the public is, well, the physician on the website is still practicing anesthesiology, for example, ER physician, even though the professor say, well, you should not practice, you should take care of yourself in the next 30 days, 40 days, 60 days, etc. The physician, if he has a conscience saying stick to that and does not go to a surgery center, the surgeon may not know he's under treatment and tell the surgeon, hey, plastic surgeon, I can work more next, etc. And the patient can go there, and the public may not know this physician is being treated in this program, and the board cannot really take action according to my understanding unless you fail the program or to the point that you have deemed by the professional in the program say you're really at high risk of causing harm. I think this is a great zone we need to work on and clarify, because what I hear the concern from the public is that we may be hiring physicians who have potential to harm public, but has not happened yet. But we try to treat those professionals before they cause harm to themselves or the public. I think there's a great zone we may need to work on the details.
Well, right now, the only tool that we have is the disciplinary process, which we know takes time. And the physician health and wellness program can tell this person, don't practice. That person has to reveal where they're working. and the program, and they have to authorize the program to be in contact with the places where they're working, so that the program can tell them if they're not safe to practice. That action can be immediate. And if the person refuses to comply with that, that is the type of violation that would be reported immediately to the board. And then the board has its existing enforcement tools. What the uniform standards requires is that if they're not permitted to practice, that be posted on the person's profile. But if they're not permitted to practice and they're not practicing, they're not posing harm to patients at that time. But the fact that that's posted on their profile is very damaging and shaming. So it's not conducive to having people seek out help through a program. So it has to be addressed.
I want to use an example from, I'm not going to talk about the specifics of the case that was before one of our panels, but it involved a DUI. And that DUI occurred in 2017. And we heard that case this year. So in the intervening time period, that doctor wasn't getting treatment, was still practicing. There was no knowledge by anybody that he had this DUI. And it was a very significant case. And the idea behind this program is to get those physicians treatment sooner rather than later, because our process has a whole heck of a lot of flaws. We heard a report earlier today that says our enforcement timelines are going up, not down. And the idea here is that we'd capture a group of physicians that we know have real potential to cause harm and capture them much sooner than any of our processes could ever work. So I understand the concerns, but from my personal point of view, the sooner we can get physicians treatment, the program in some cases will require them not to practice, the better off patients are in California. Dr. Thorpe, did you have a comment?
Well, I just want to say, I think your example is one of a number of examples of people who are not physicians who are not getting treated now. They're a risk now. Getting them into a wellness program, the idea is not to get them to be able to escape scrutiny. We want to do it in a way that it's controlled, a way that it is safe for patients, but in a way that if the previous program that we were looking at, nobody was going to use it. It was so difficult to and so draconian that no rational person would ever submit to what we were considering. And so the reason we're looking again at this is not because we're careless or because we don't care about what the public or because we haven't heard your comments over and over again. We have heard you. It is because we want to try to find a program that will address the glaring problem we have in this state of physicians that are not being treated and are posing a harm, whether you like it or not. That's what's happening. And right now, the only option we have is discipline, and it's taking too long. It's just taking too long. And we have to find a solution where, in this particular case, a medical staff could have referred this abusing physician, this impaired physician, to the wellness program immediately, told him he couldn't practice, and referred him immediately, and he could have gotten care 5 years ago if this program were in existence. But it wasn't in existence. and we had no other option than to go through this laborious process of investigation and all of the things that we're doing. We're trying to speed those things up too, but this problem is a problem that we need to be able to have people who, I mean, there are people who are impaired who want help, but they don't want to be disciplined because, and for the obvious reasons, right? They need help, but they can't get to it without being disciplined. And that's a difficult problem. So it's not because we're trying to protect doctors. The real reason is because we want to have patients get safe care. That's the real reason. It's not about protecting doctors.
Other comments? Dr. Ballant?
Yeah, thank you, Ms. Webb, for the clarifications, and appreciate other board members' perspectives and our board president. And I do believe that this I think one of the comments, I won't say whom or whatever, but I think the analysis of moving, that things weren't, the needle wasn't moving either direction. I think what is important is this is a cultural shift. Now, I know it's must be very difficult to know what happened 10 years ago, 15 years ago, 20 or 25 years ago. But the fact is, I heard that, and we know this, that young doctors, before they've even become licensed, are having difficulty. They're afraid of putting in information that there may be a problem, but it also means there needs to be a cultural shift in the understanding of people that are educating our doctors and making it okay, and for our patients to understand that doctors are human beings as well. Now, if anyone that's listening to this, I think that the established organizations that hire doctors also have it is incumbent upon them, if someone sees or knows of a doctor being impaired, how awful not to report that if that's what's happening, or family members not being able to know that there's something out there to help. Now, I also want to say that I am, I hear the public, I understand it. I really believe that the development of what I think you refer to as the SAC, the Substance Abusing Committee, I think that works with the medical director. This board, I believe, will have high scrutiny of everything that happens, because I think, as Ms. Lawson says, when we get cases, we're getting them 7 years later. That's too long. Other people are suffering. I think that's the biggest message that I'm hearing from that and the cultural shift. We need a cultural shift, because what we did before and what we need to do now is an entirely new day. So working together with the comments that we've heard, I think is critical for us to hear and to continue this. So thank you for the clarifications.
Thanks, Dr. Ballant. Other comments? All right. Dr. Sy?
I think just like to point out in terms of taking care of the patient, there's the doctor, the physician assistants, the nurse practitioners. We all take care of the patients. And each of those separate boards, the PA board and the nursing board, have diversion programs because they know it's an issue. We take care of patients. Patient is our priority, but we have to make sure that when we take care of our patients, we're in our right mind. And so I think with those boards recognizing and having diversion programs, I think it's also prudent for us to look at why don't we have one? And I think the way to look at it is it's not replacing something, it's complementing something.
Any other comments? Okay, seeing none, this is not an action item. I do think it's 12:30 now. I think we're going to take our 30-minute lunch break, if that suits the board, and we'll be back at 1 o'clock to go through the rest of the bills. Does that work for everybody? All right, we'll see everybody back at 1 o'clock. Thanks. All right, welcome back, everybody, to the May meeting of the Medical Board of California. We're reconvening at 1:04 p.m. We're still on agenda item 7, discussion and possible action on legislation. I believe we're at item sub C, AB 432. Mr. Bone.
Thank you, members. Find my place. AB 432 would proposed two requirements. The first is to mandate that certain physician licensees of the board complete 10% of their required continuing medical education, or CME, hours on topics related to perimenopause, menopause, and postmenopausal care. By regulation, the board requires at least 50 hours of CME every 2 years. Therefore, this bill would effectively require physicians to complete at least 5 of those hours on those topics. With some exceptions that are described in the background section of the analysis, physicians generally have discretion to choose the CME content they believe is most appropriate for them and their medical practice. The bill proposes to place the CME requirement on general internists, family physicians, OBGYNs, cardiologists, endocrinologists, and neurologists who have a patient population composed of 25% or more adult women under the age of 65. Among the other provisions of the bill require health insurance providers to cover certain evaluation and treatment options for perimenopause and menopause that the treating care provider believes are medically necessary. Like we discussed earlier with AB 360, helping to promote access to quality care related to menopause is absolutely a worthy healthcare topic to address. Furthermore, physicians should be adequately prepared to treat their patients according to the standard of care on this or any other health concern. If not, they should refer their patient to a specialist who can deliver the appropriate care to them. As described in the analysis, the board has a history of not supporting topical CME mandates and has taken the view that each physician should decide for themselves what education or training they need so that they can most effectively diagnose, treat, and support their patients. In line with this history, board staff recommend you adopt an oppose unless amended position to seek removal of the language that mandates CME. Happy to answer any questions, Madam President.
Thank you, Mr. Bone. Any questions? Do you have a question? Dr. Ayala Rodriguez?
Just have a comment similar to the previously one made. Like, I really like data-driven decisions and things like that. And I think that what we're trying to accomplish with the previous one really is very important in trying to understand where the gaps are. There could be in training, there could be on CME, there could be at different stages. So I particularly like to try to understand better where that gap is. And in 2027, I believe the previous bill is gonna come with recommendations and address them. I imagine in short term and in long term, based on the needs that are going to be found. So in my particular case, I just found it redundant and kind of just jumping into a particular intervention without looking into the specific educational care gaps.
Okay. Thank you.
Yeah.
Other questions, Dr. Mahmood?
Yeah, my concern on this thing is 10% of CME for specialists like cardiologists and pulmonologists, they might have, but they have so many other requirements to learn more and kind of stuff. This is kind of, I think, hefty to put them through this. Maybe 10% one time, not 10% every 2 years, 50 CME credits. I think that is way too much. We should definitely come back and talk on that.
Great, thank you. Other questions or comments? Is there a motion to approve staff's recommendation?
So moved.
Thanks, Dr. Helzer. Is there a second?
I second.
Thanks, Dr. Tsai. Okay, we're going to open up for public comments. So there are public comments from those in the hearing room? No public comments in the hearing room on AB 432. Are there public comments on the WebEx?
If anyone would like to make a public comment on this agenda item, please do so by typing something in that Q&A window, raising your hand, or if you're in a call-only line, you can press *3. Several here from Eric Anderson. I'm going to call on him to see if he'd like to make a public comment. Afternoon, Eric. Yeah. Not seeing the line opening, so we'll go to Ryan Spencer here. Ryan?
Thank you, sir. Thank you, members. Ryan Spencer, again, on behalf of the American College of OBGYNs, District 9, and we're in support of the staff recommendation as well of oppose unless amended. As previously stated by one of the members working off the previous discussion of 360, we do think it's worth reiterating The ACOG's opposition is not a resistance to menopause training. In fact, it's the opposite. ACOG completely agrees that we need to explore and address any deficit in early medical training, and AB 360 may find that. But we really just can't agree with the approach in this bill, and prefer we focus on the root of the problem, which is there's just simply a lack of specialists that are available to treat individuals that are undergoing menopause. So ACOG recognizes that menopause is a unique universal health transition experienced by all women and deserves far greater attention in early medical training than it currently has. Those improvements could include integrating menopause into core curriculum, offering more clinical rotations on menopause care, incorporating menopause into clinical examinations, and on, all things that should be examined in the future. But like you said, mandating CME on a specific topic, even one as important as menopause, does set a concerning precedent. And as you know, and as you just stated, physicians need to retain that professional discretion to pursue continuing education, most relevant to their specific to their practice, even for OBGYNs. So as such, ACOG asked the board to adopt the staff recommendation of oppose unless the CME mandate is removed. Thank you.
Thank you for your public comment. Next up here, we have Angela Hill. Angela, you should be receiving a prompt on your end.
Good afternoon, everyone and members of the board. My name is Angela Hill, and I'm here today on behalf of the California Medical Association. We align our comments with ACOG and also support the staff recommendation of oppose unless amended on AB 432 to remove the CME mandate. CMA fully supports the intent behind this bill, increasing awareness of long overlooked medical conditions and improving menopausal care for patients are important and laudable goals. However, we do believe that mandating continuing medical education is not the right approach. Physicians are required to complete CME to maintain their licensure, but the selection of those courses is designed to be flexible and ensuring that physicians can select the topics most relevant to their unique patient populations and practice settings. So in its current form, AB 432 takes away that discretion and it forces certain physicians to dedicate 10% of their CME hours, regardless if it applies to their clinical work and the patients they're serving. And this is a concerning precedent that we believe can have unintended consequences of turning CME into another administrative burden for physicians who are already facing alarming levels of burnout and job dissatisfaction. Physicians dedicate dozens of hours each year to CME to stay current with the rapidly evolving fields and specialties, and we believe that mandating CME topics in the manner that AB 432 proposes will reduce CME's effectiveness overall and runs the risk of making the very purpose of CME something that no longer holds as much value. So for these reasons, we ask that you adopt the staff recommendations of oppose unless amended, because ultimately we believe that education on menopausal care should be encouraged but not mandated. Thank you for your time and attention.
Thank you for your public comment. This time I don't see any additional requests.
Okay, we'll bring it, excuse me, bring it back to the board for discussion. Any further discussion?
I would.
Dr. Blunt?
I'll be very brief, but certainly a woman's healthcare advocate as a family physician. And I really liked what Dr. Ayala mentioned, and that is, I think the first step to all of this is to understand the gaps. Mandating CME is always a challenge, and I was particularly struck by the list of subspecialty specialists that were added, because I think, you know, the care of women, if the intent of the bill is to look at the problem of perimenopause, menopause, postmenopausal, it's about awareness, and I think that's the prior bill does that, 380. So thank you for the opportunity to comment.
Thanks, Dr. Balat. And I also just want to go on record because I do think that it's laudable that we address this very important healthcare topic. It has, since I've been on the board, been our board practice to oppose bills that mandate CME on any topic. And I believe we actually have a board policy dating back some time on exactly that issue. So my vote to support the staff recommendation is nothing more than support of our past practice and our policy of not mandating CME for any specific topic.
And we can, I think, mandate to take the CME out and get the idea from the board.
That's right. So I think the staff recommendation is oppose unless amended to remove that CME mandate. Okay, any further comments or should we take a vote? All right, Ms. Struther, please take a roll call vote.
Dr. Ayala Rodriguez,
Yes.
Dr. Bolat,
Yes.
Ms. Chung,
Yes.
Dr. Helzer,
Yes.
Dr. Mahmood,
Yes.
Dr. Thorpe,
Yes.
Ms. Torres,
Yes.
Dr. Sai,
Yes.
Dr. Yip, Ms. Lawson.
Yes, that motion passes. Moving right on.
Next is AB 489, which is intended to prevent artificial intelligence systems from impersonating healthcare providers. It would do so by authorizing the various health boards to enforce their respective title protection laws against a person or entity that deploys such an AI system. So think of a text-based chat that you might engage in through the internet. If what you are chatting with is not an actual human, but is in fact an AI-driven chatbot, and that chatbot claims to be a physician, a psychologist, or some other healthcare provider, then this bill would expressly authorize the relevant licensing board to take action against the person or entity who developed or deployed that technology. Staff believe that this conduct is already prohibited by the Medical Practice Act, which could constitute the unlawful practice of medicine or violate the ban on the corporate practice of medicine. This bill, however, would make it very clear that using AI to impersonate a healthcare provider is not appropriate and would also provide authority to other licensing boards that may not have the same tools as this board does. Accordingly, staff recommend the board adopt a support position and happy to answer questions.
Are there any questions or comments from board members?
I move to support.
Okay, thank you.
Second?
All right, we have a motion and a second. Let's go to public comment and then we'll bring it back for discussion. Any public comment from those in the room?
Hello, my name is Lucas Evanson on behalf of CMA. CMA appreciates the staff analysis and just asks the board to support take a support position on this bill. Thank you.
Thank you. Any other public comments from those in the room? All right, how about on WebEx, Sean?
Anyone would like to make a public comment, please do so by raising your hand using the Q&A window, or just if you're on a calling line, press *3. First up here, we have Ryan Spencer. Ryan, you should be receiving that prompt.
Thank you, sir. Simply American College of OBGYNs District 9 and the California Radiological Society also support the measure. Thank you.
Thank you for your public comment. This time there are no additional requests in queue.
All right, we will bring it back to the board. Any comments? Questions? All right, seeing none. Mr. Other, please call the roll or perform the roll call vote. I guess not call the roll.
Dr. Ayala Rodriguez,
Yes.
Dr. Bolat,
Yes.
Ms. Chung,
Yes.
Dr. Helzer,
Yes.
Dr. Mahmood,
Yes.
Dr. Thorpe,
Yes.
Ms. Torres,
Yes.
Dr. Sai,
Yes.
Dr. Yip,
Yes.
Ms. Lawson.
Yes. All right, that motion carries. Next up, AB 742.
Yes, which would require the various DCA boards to expedite the licensing process for an applicant who is a descendant of an American slave. The requirements of this bill are contingent upon the enactment of a companion bill, SB 518, which would create the Bureau for Descendants of American Slavery. Further, the requirements of AB 742 would not kick in until that bureau establishes a process to certify that an individual is such a descendant. As discussed in the analysis, staff reviewed the timeframes for licensure for the 3 prior complete fiscal years, comparing the timeframes for expedited against non-expedited applications. The chart on page 2 of the analysis shows a less than 2-week difference in the amount of days to receive a license on average over that 3-year period. Whether an application qualifies for expedited review or not, the board will not issue a license until the applicant has met the relevant requirements. After the application is initially reviewed, it is quite common that the board staff identify various missing or complete items from that application. In that situation, the staff will inform the applicant of what deficiencies there are in that application, what needs to be done to remediate them. Some of the more common deficiencies are noted in the analysis. Staff believe that the most effective approach to helping applicants get their license more quickly is to add certain new staff positions. These employees could be charged with helping applicants who qualify for expediting to remediate their deficiencies with, again, missing or incomplete documents. To do so, staff suggests that the bill be amended to include language that directs the staff to establish a new unit. This could be modeled after the language which was added to our prior sunset bill, which led to the creation of the complainant liaison unit. We think this approach would have a meaningful impact to help reduce processing timeframes for applicants who qualify for expedited licensure. Staff also suggests an amendment to make it clear that to qualify under this bill, the applicant must provide documentation from the new bureau that confirms that they are a descendant from an American slave. This technical amendment would avoid the need for the board then to conduct a rulemaking. Therefore, staff recommend a support of amended position to seek these amendments, and I'm happy to answer questions.
Any questions, Dr. Ayala Rodriguez?
Yes, thank you so much. I'm in support of this, but my only concern is about misleading like any stakeholder about any meaningful difference with expedited. Do we have like a particular goal for expedited licenses in terms of differences in like they should have an outcome at least 30% sooner or any form of goal attached to being expedited? Because when there's a 8-day difference, like in real world, sometimes, yes, that's always important to have a license sooner, but 1 week might not be that much.
I'm not aware of such a goal. If other staff from the board want to correct me, I'm not aware of such a goal, doctor, rather than when somebody, and there's multiple ways that you can qualify for expedited or priority review. Those terms are used interchangeably, in the code, at least we interpret them as, interchangeably. There's no specific time frame that I'm aware of. Rather, they get a higher priority on the staff list when something comes in, they get looked at, more quickly than other applicants do.
Okay, Dr. Mahmood and then Dr. Thorpe.
So I'm still a little confused. Maybe I am slow. What are we trying to achieve? Like getting the license 2 weeks earlier? That's all. For that thing, we're going through the whole thing. I honestly, it doesn't make much sense to me to create a whole unit, do all this thing, and just get the license 2 weeks early.
Sorry, go ahead.
Can there like be okay? I just don't know what we're going to get the end result out of that. This is just like somebody's trying to, I don't want to be rude, like make a bill so that they can put in their resume. That's all. I don't think this bill is really achieving anything significant except that making so much work, creating a new unit, spending so much dollars on that. And we might have like 2 or 3 applicants in a year, but that's going to do that. It doesn't make sense to me.
If this helps a little bit, Doctor, the bill is not aimed directly at this board. It's across all of the boards in DCA. I don't have a good handle on how, their timeframes may look differently than ours when if they compare expedited versus non-expedited, like we did. But I think that underscores the data. The data underscores the fact that deficiencies, things that are missing, things that are incomplete, or you have some sort of an issue that comes up in the course of, your postgraduate training and the board becomes aware of that, then you might go into senior review, which is a separate process to provide additional scrutiny for that application before a license is issued. So those are the factors that we see are why applications some take a longer time than others before they are approved. But that may be a different situation with some of the other boards. I can only provide you data for our board.
You were just perfectly fine. You give the right detail and all that stuff. I just wanted to make sure there's not point I'm missing or something like that.
Yeah, and so then just finally the staff's recommendation is kind of rooted in trying to take a very productive approach, a positive approach. It's like, well, if we really want expedited licensure to kind of live up to its promise, then providing additional staff resources to help address the issues that lead to a longer time frame to get a given application approved than providing some more staff who can be specifically focused on that. We thought that was a good solution.
So I would think instead of increasing the, adding another unit and a whole lot of stuff, can we just give them a little concession on the expedited license fee so that they can be considered expedited anyway?
Repeat that? On the fee, you said?
On the fee, isn't there a different fee for the expedited license?
No, there's another bill that we're going to talk about later in a moment that
That's
suggests a fee for other classes of applicants to qualify for expediting, but that is novel. This bill, as well as the other expedited applicants, do not have to pay a fee.
All right.
Dr. Thorpe?
I'm trying to figure out what the point is here. I mean, honestly, what's the point?
If you, I'll just kind of direct you to
No, I mean, I read the bill, but I mean, I just, so the licensure of any, we license anyone who qualifies for a medical license, correct?
Yes.
Doesn't matter. There's no designation between race, gender, sexual orientation, nothing.
Correct.
You get a license if you're qualified for a license.
True.
And so, I mean, I understand that there has been a historical problem with slavery in the past. So again, that's the other question is, are they talking about current? I mean, it's people who are currently slaves, they're in slavery now?
Descendants of slaves.
But so we're talking about the historical enslavement of African people in our country 200 years ago. We're not talking about people that are sold in sexual slavery or slavery today. That's not what we're talking about. We're talking about the historical American slave where they brought people from Africa and other places to enslave them for.
I believe this comes in part from the Reparations Task Force report. So this is
a recommendation.
A recommendation that's coming out of that report that's now being advanced into law.
I just think I don't agree.
Fair enough.
And may I one more
Yes.
comment? In addition to like the concerns that I have about, which I'm going to echo about the government efficiency, I'm actually curious. I don't know that this necessarily is going to pass legal muster, and that it would necessarily be in accordance to federal anti-discrimination law. And I want to say that just in light of the current ongoing conversations that are happening both at the state level and at the federal level, that is my concern with the way this is presented. I'm not sure that it's going to survive legal scrutiny.
All right. Should we open up for public comment? Any public commenters in the room? Actually, did we have a motion in a second? We did not. We'll go to public comment anyway. We'll do that afterward. Sean, how about on WebEx?
Anyone would like to make a public comment on this agenda item, please do so by raising your hand using that Q&A window, or if you're in a call-in-only line, you can press *3. Give a few seconds to see if anyone queues up. I don't see any requests at this step. Oh, last second one.
Yes.
So Aaron, I mean, is this, I'm struggling with this. I'm sorry. Is this something that is going to create a problem for you if we, I mean, maybe there's a lot of sentiment to pass this, but it seems like if we decide to I don't know,
well, so like I said, Dr.
take
Hurley,
another place other than support.
as I said earlier, I was trying to take a positive approach to suggesting a course of action that would lead to, we think, a meaningful reduction in the timeframes for not just this class of applicants, but as well as for, as well as for others. And we'll talk about that more in a couple of bills. There's several groups already that qualify for, for expedited licensure. The board has supported some of those bills in the past. So I understand the concerns and, you appreciate, Ms. Torres' comments as well.
I'll make a motion to move for support if amended.
Thank you, Dr. Sai. That's the staff recommendation. Dr. Ayala Rodriguez, you want to second that?
Yes.
Okay, so we have a motion and a second for the staff recommendation. I think now we've had public comment. There was no public comment.
Correct.
Even though we called for it. Yeah, Dr. Balat?
I have a question for you.
Yeah.
I get the sentiment. I wonder, is it possible for us to take a neutral position?
Well, we have a motion on the
If
table.
I could make a friendly amendment.
I'll entertain whatever Dr. Bolat is trying to.
What I'm trying to say is I would take a neutral. I think what Dr. Thorpe said was very important, or maybe it was Dr. Mahmood, that what we're doing is we're being equitable to all parties, and we're looking for the qualifications and putting things through a review process that is there to protect healthcare consumers regardless. And if there is something about an to expedite the unit that may come up in another bill, that's fine. I think this, I would like to propose the friendly amendment that we take a neutral position on this. I think it's a very, a neutral position. That's my recommendation. Motion for the board to make a neutral position on this bill.
So I guess,
There's a
do we need to, is there a second for that?
What do you mean by neutral? I don't understand.
The board can take no act. So
Yeah.
the board can take no action, and then the board would not adopt any position, which is
Yeah,
neutrality.
that's where I think we should do that.
Yeah.
Now, neutral means that, okay, let them do that. No action
The board can take no action, and then the board would have
Just
no
stay away from
position
this.
on the bill.
until they have done all the stuff and they can come back.
So there's a second from Dr. Mahmood.
Just have a question about that. If we take a neutral position, one of the things that you are recommending as part of the amendment is to request for the FTE, right? So if we take for the support to expedite a possible expedited, if we take a neutral position and then this continues moving along, do we have the opportunity to request for that support later on? Supported?
So we can certainly put this on the next board meeting agenda, which would be in late August. So that would be not quite a month before the legislature wraps up their work for the year. And then I'll continue to track the bill and present it again as it is. It's very likely it will change. I don't say that based upon any specific knowledge about this one. Rather, that's just common with bills as they go through the legislative process. So, and I don't, again, the board doesn't have to take an action to say we're neutral. I mean, in my viewpoint, we're neutral on everything until you take a support or oppose of some flavor. So if the board decides to take no action on the bill, then, and that's your will, then that's fine. And then we'll just keep an eye on it and we can put it back on the future board meeting agenda to update you then.
So that's how would you want to?
Right. So there's been a motion and you second it. We have to vote on this.
No action.
It can be withdrawn.
Right, and unless you agree to
I
withdraw your
agree.
motion.
So what I'll do is I'll withdraw my motion for support if amended, and then this way we put your motion on to vote, and then.
No action.
We don't have to vote on no action,
You
folks.
do not have to,
Yeah.
you don't have to vote on no action. So if the motion is withdrawn and the board, we decide to move on to the next bill, then
Okay.
no action is taken.
Then I withdraw my motion, and I think we table this to find out what happens in the future.
We can
I agree.
monitor it and report back
Yeah.
at the next meeting.
I'll agree to withdraw my.
I wish I had my Robert's Rules of Order,
Yeah.
which I used to have when I was on a city council. I used to have this great book.
You're supposed to vote.
All of it. Okay. Does anyone else want to make any other motion for us to consider before we move along?
So no action
There's
is
no action. We're moving on.
very good. All right.
What's next?
Thank you, members. AB 876. This would codify a scope of practice for certified registered nurse anesthetists, or CRNAs. CRNAs are registered nurses who have received additional education and training that qualifies them to provide anesthesia care services. In the course of my research, I've discovered that the Board of Registered Nursing is designated in the Business and Professions Code as the entity authorized to define or interpret the practice of nursing. However, there is little in existing statute that describes the scope of practice specific to a CRNA, which this bill attempts to establish. Further, I understand that the actual duty of any individual CRNA may be determined by the policies of the facilities where they practice in, and that many work in anesthesia care teams that are physician-led. Supporters and opponents present vastly different views on the impact of the bill and the risks and benefits to consumers. Scope issues can be particularly challenging to evaluate, and I believe they are best done through a deliberative interested parties process when possible. In the absence of such a process or something comparable, staff are unable to provide a recommended position on this bill. Some possible actions for the board to consider today include taking some sort of a position, taking no position, and directing staff to monitor the bill's progress, as we just did with the prior bill, or provide some sort of direction to gather more information and report back at a future board meeting. Happy to answer any questions, members.
Any questions, comments? Okay, let's open it up for public. Sorry, Dr. Helzer.
Thank you. I have a question that perhaps Ms. Webb can answer. Just by way of background, I practice in a hospital that uses the anesthesia care team model, where anesthesiologists and CRNAs work together to deliver patient care, but that team is led by physicians. I believe that model provides high quality, safe care, and I would very much like to preserve it. My question is that my reading of this bill, in Mr. Bone's memo, it refers to a decision, CSA versus Brown, that it's my understanding that's a non-binding advisory opinion by the court regarding CRNA practice. And the language of this bill would give that opinion the force of law. If that were to be the case, I'd be concerned that that would affect rules adopted by hospital medical staffs to require physician supervision of CRNAs. And I'm wondering, Ms. Webb, if you could comment on the implications of that change on hospital medical staff bylaws.
I wish I felt comfortable doing that in this moment, but I don't feel comfortable answering such a specific question. Certainly, that the decision is an appellate court decision, not a California Supreme Court decision. This is complicated, and it's because it's for CRNA who's licensed and regulated by the nursing board. I just not prepared to answer such a detailed question right now.
Great, thank you. So if in fact this were to limit the ability of a medical staff to make those decisions, I would see that as a significant scope of practice expansion that I would be uncomfortable with.
Thanks, Dr. Helzer. Other questions, comments? Dr. Yep.
My understanding, the medical staff bylaws supersede that, but CRNA may be a different entity. Like for MPPA in the private office, you can see the patient and the supervising physician may audit like 10% of the chart, etc. But the hospital bylaw in our hospital, actually all the charts, all the patient need to be countersigned by the supervising physician. So the bylaw do supersede that. Thank you.
Other comments, questions? Does anybody want to make a motion? We don't have a staff recommendation.
I would, yeah, I would be I would be most comfortable with not taking a position on this bill.
Okay. Other thoughts?
Yeah, I think I would be with the neutral thing.
Okay, well, let's hear public comment and then we can officially decide.
Mhm.
Thank you. Thank you, Madam Chair. And for the rest of the board. So again, I'm Dr. Christina Menor. I'm an anesthesiologist. I practice in private practice in Los Angeles. I'm the president-elect for the California Society of Anesthesiologists. And this bill is a significant overreach. I agree with Dr. Helser's interpretation in the sense that this would alter the current scope for nurse anesthetists in the state of California and would allow practice beyond their current education and training through elimination of critical physician oversight. Compromises patient safety, restricts access to anesthesiologists, and I want to make note, the board may or may not be aware of happenings that occurred through CDPH or California Department of Public Health investigations last year, the last few years, which have already revealed patient harm in facilities where nurse anesthetists had practiced without any physician involvement. I'll note that these violations occurred because this was against state statute. However, they did occur, and with that and the public reports from CDPH have shown real harm that occurred to patients and to people, our patients of the California state. So anesthesiologist, as you know, is a high-risk specialty. Even a minor error can result in a life-threatening complication. In 2024, CDPH and CMS both uncovered real instances of this harm at Doctors Medical Center of Modesto and Stanislaus Surgical Hospital. Both had immediate jeopardy violations cited for multiple issues, but two of the issues included nurse anesthetist only care in the anesthesia workspace. This information confirmed that cutting corners in providing medical anesthesia directly by nurses in a nurse-only model compromises patient safety. I urge the board to consider review of this investigation and can assist you with any summaries or information on that you may have. Our proponents of AB 876 state that it will improve access to care. There is no evidence that CRNA nurse anesthetist only care will improve access to care in the state of California or any other state that has had any research in this arena. Although well-intended, the bill is terribly misguided and fosters inequity, creating a two-tier system for patient care, where affluent and urban patients may have access to physician-led care, and others in underserved areas and rural areas may not. All patients deserve equitable access to physician-led care, regardless of financial situation or where they live. Proponents have also argued allowing nurse anesthetists with less oversight will alleviate these shortages, improving access, like I stated.
Let's conclude.
Thank you. I appreciate our colleagues in nurse anesthesia. We do work in care team models. However, physicians and nurses have two different places in the practice of anesthesia. I urge you to have an opposition or a no on this bill. And I'm also available if you have any questions, either about, I can assist Dr. Helser if you have questions or any issues about either the things in Modesto or about the bill specifically.
Thank you.
Thank you.
Other public commenters in the room?
Hello, Lucas Evanson on behalf of the California Medical Association. CMA aligns its comments with some of those shared by the California Society of Anesthesiology. CMA appreciates the staff analysis and would like to emphasize the importance of rigorous training standards, play in patient safety. Recognizing that critical role, CMA believes appropriate guardrails should be placed around the practice of individuals with less stringent training requirements. For that reason, CMA is opposed to AB 876 due to our patient safety concerns. We urge the board to similarly establish an opposed position. Thank you.
Thank you. Other public comments? All right, Sean, let's go to the WebEx, please.
If you'd like to make a public comment on AB 876, please do so by raising your hand, typing anything into that Q&A window, or if you're on a call-only line, you can press *3. First up here, we have Charles Allen Griffith. Charles, you should be receiving that prompt. Good afternoon, Charles. Looks like your line's open.
Oh, thank you. Can you hear me okay?
Yes, we can. Please go ahead.
Yes, I'm Chuck Griffith, CRNA. I'm speaking as a member of the California Association of Nurse Anesthesiology. I want to thank you for this opportunity to speak in support of AB 876. This bill is meant to clarify certified registered nurse anesthetist practice in California. The bill is supported by the California Board of Registered Nursing, which determines the scope of practice for nurse anesthesia, as a means to clearly support our practice. This bill does not expand the scope of CRNA practice. It simply clarifies what we're doing and where we're doing it, codifying nurse anesthetist practice as supported in California case law and Attorney General opinions. The bill amends the Nurse Anesthetist Act portion of the California Nurse Practice Act to clearly specify and support CRNA's essential role in California's healthcare system, to safeguard medically underserved patients' access to high quality and timely anesthesia care, and enable, especially for small rural healthcare systems, to utilize qualified providers like CRNAs in the most cost-effective manner as they struggle to survive and provide surgical and OB services. It is true that much rural anesthesia care is provided by nurse anesthetists because smaller institutions often are unable to afford our more expensive anesthesia colleagues. So I would ask that the board would consider this information as they determine their position on AB 876. Thank you so much.
Thank you for your public comment. Next up here, we have Melanie Rowe. Melanie should be receiving that prompt.
My name is Melanie Rowe. I'm a CRNA in California and the director of the California Association of Nurse Anesthesiology Practice Division. AB 876 does not change how CRNAs practice in California. It does not expand scope of practice. It simply clarifies what we have been doing all these years. When a facility asks about how CRNAs practice in the state, we have to lead them to Attorney General opinions and BRN opinions issued in the 1980s. And then also the Nurse Practice Act and case law that was upheld by the California Supreme Court in 2012 that the board referenced earlier. This has worked for many years, but can be confusing and cumbersome. This bill puts all of that established nurse anesthetist practice in statute form. The result would be clarity for the over 3,000 CRNAs in the state to maintain our essential role in California's healthcare system. Healthcare systems can continue to choose who they use to staff their anesthesia departments just as they do today. This bill does not change anything that is currently in practice. It literally only provides a clear and concise Nurse Anesthetist Act. This bill does not enact any of the opponent's arguments heard today or in the analysis. We are happy to meet with the medical board and answer any questions you may have had about the bill, and we appreciate the analysis that was written for the board. Thank you.
Thank you for your public comment. Next up here, we have Thomas Batchelor. Thomas, you should be receiving that prompt. Good afternoon, Thomas. Oh, looks like Thomas just disconnected. Can double back if you reconnect, Thomas. Next, we have Catherine Bowles. Catherine, you should be receiving that prompt. Catherine? Yeah, we can hear you, Catherine. Please go ahead.
Right. Hi, everyone. My name is Catherine Bowles. I'm a practicing attorney. I'm a registered nurse. I appreciate the opportunity to speak today. I currently serve as the attorney for the California Association of Nurse Anesthesiology, as well as any number of physician groups, CRNA-led groups, and physicians and nurses working together to provide anesthesia in the state of California and in 10 other states throughout the United States. I want to note, one, that AB 876, as Melanie stated earlier in her comment, really isn't an attempt to expand the scope of practice for CRNAs. It's merely an attempt and a response in part to the CDPH survey activities that occurred last year to really just codify what our existing scope of practice is in the state of California. Because right now it's in this case CSA v. Brown, it's in this advisory opinions from the BRN, it's in the Nurse Practice Act, and it's in the Attorney General Opinion 83-1007. One person, I believe, raised and asked what the authority of CSA v. Brown is, so let me clarify for everyone here. CSA v. Brown was decided in the First District Court of Appeal in California. It is mandatory authority. It is the law if you are residing in the First District Court of Appeal, which includes the city of San Francisco. It is also persuasive authority legally for every other appellate court in the state of California. This opinion actually was challenged further and attempted to be raised at the California Supreme Court level. The Supreme Court denied cert, which can mean many things. It can mean they were not planning to change the opinion of the appellate court, or it could mean something else. We will never know. But that is where we stand today as it relates to this case. So this case is the law. The second point I want to make is that one of the board members mentioned the importance of being data-driven. Thus far, I've been pretty disappointed by the comments that have been put forth by CSA and CMA because they're really not data-driven. There's a lot of going back and forth about, well, we will decrease patient safety, we will harm patients, patients must have access to a physician anesthesiologist. And the evidence and the research studies that have come out have not supported that there are statistically significant differences in patient outcomes from patients being treated by CRNAs versus patients being treated by physician anesthesiologists. So if you take a look at the data, I believe that you will find, again, this bill is not really doing anything to harm what exists now in practice. Final comment I want to make is that I understand that the medical board is in a difficult position. I appreciated the analysis that was provided. It appears to be relatively neutral and consistent with prior legal analysis put forward by the Medical Board of California with respect to the fact that CRNAs do not practice under physician supervision, haven't done so under Medicare rules since 2009, and haven't done so under Medi-Cal since 1987. If the board has any questions or things that they would like me to address, I'm happy to do so. Thank you.
Thank you for your public comment. Next here we have a call-in user from the 916. Should be being prompted to press *6 to unmute.
Hi, can you hear me?
We can. Please go ahead.
Okay. Hi, my name is Jeff Cherry. I'm a nurse anesthetist here in the Northern California region. Been listening in intently. I have been practicing independently and in an anesthesia care team model since 2000 up here. I have been in every practice environment, and I can tell you care availability will suffer with the putting down this measure. We're asking for just a neutral stance from the board. Right now, the OB anesthesia care in 2 counties in which I have and do currently practice would be severely affected by anything but status quo. This bill is not asking for anything new. It's codifying all the myriad ways in which the practice has been going for the last 40 years. There's nothing new that this bill is pushing for. It's codifying current practice. And furthermore, I do have a relative that had a huge delay in care in the valley because of some work surrounding trying to limit CRNA practice. So I chose both as a CRNA and as a citizen. I wish you would remain neutral on this bill. Thank you.
Thank you for your public comment. You're back on mute there. And lastly in queue right now, we have Kristen Roman. Kristen, you should be receiving that prompt. Good afternoon, Kristen.
Yeah, are you able to hear me?
We can. Please go ahead.
Okay. Thank you, members of the Medical Board of California, for allowing me to speak today. I'm Kristen Roman, a certified registered nurse anesthetist and president-elect of the California Association of the Nurse Anesthesiology. I'm here to express our strong support for AB 876, a bill that does not change the CRNA scope of practice in any way. AB 876 should not be a controversial bill. It simply refines existing definitions, it increases transparency of current practices, and it reaffirms CRNA practice as it's existed in California for the past 50 years. CRNAs are advanced practice registered nurses with advanced education and training to provide safe anesthesia in all settings for all types of anesthesia. CRNAs have had independent practice authority in California since 2009. In 2012, this authority was challenged, yet the California Supreme Court affirmed our right to practice independently. This is the law. Nothing in AB 876 restricts, expands, alters, or modifies the existing scope of practice as set forth in California Society of Anesthesiologists v. Brown in 2012. For the past 13 years, there have been few, if any, concerns raised about the safety of our existing practice. CRNAs practice in all care team models. I work in a medically directed model 3 days a week. Other days, I work fully independently at an ambulatory surgery center. Each facility's bylaws define practices it deems appropriate for their particular facility. AB 876 will not change this. The autonomy of individual health centers remains untouched. Similarly, the liability and responsibility for anesthesia lies with the anesthesia provider, regardless of whether they are a physician anesthesiologist or a CRNA. AB 876 will not change this. We're here today because misinterpretation of existing law led to the cancellation of over 1,000 cases in Assemblymember Flora's district. A CDPH surveyor claimed there was potential for patient harm because she misunderstood California state law and believes CRNAs are unlawfully practicing without physician supervision and unlawfully prescribing anesthesia medications and anesthesia modalities. In fact, there was no actual patient harm, yet CDPH cited the hospitals with an immediate jeopardy, the highest level of citation and crime. The clarity and transparency provided by AB 876 will ensure that this never happens to Californians again. I urge your support of AB 876. Thank you.
Thank you for your public comment. One more here now from call-in user in the 949 area code. Should be prompted to press *6 to unmute.
Hi there. My name is Jonathan McGarity. I'm a nurse anesthetist and a member of the California Association of Nurse Anesthesiology. I am calling to express my support for AB 876 and echo a lot of what has been said here. This is not a bill that expands any scope. It doesn't change our scope. It just codifies what we're currently doing and protects patients, Californians' access to quality and timely health care. I think the main points have been said. I'll just share a bit of personal experience that some of the special interest groups have used exploited language in the Nurse Anesthesia Act that has led to delays in care and cancellations of care in my practice. So just wanted to share that. Thank you for the opportunity and have a great day.
Thank you for your public comment. That was the last request in queue.
Thank you to all the public commenters. Anyone else in the room? All right, seeing none, we'll bring it back to the board. I think we had no motion.
Correct.
We had a
No action.
take no action position. Does anyone want to
Yes.
change their mind? Okay, we're gonna move on to AB 967. Is that right?
Yes, thank
Great.
you. That is the 967 is the second bill on the agenda today related to expedited licensure. This one would require the board to expedite the review of an out-of-state applicant who intends to provide direct patient care as defined, and if they provide a fee of up to $250. Supporters of the bill state that out-of-state physicians are experiencing long delays in the licensure process. The data shows, however, as we discussed earlier, only a slight decrease in the timeframes to issue an expedited license. Rather, deficiencies and applicants who require further review due to criminal history, administrative discipline, postgraduate training issues, or other circumstances tend to be the reasons why an applicant requires additional time to be reviewed and approved. As discussed in the analysis, if the board receives a complete application, a license can be issued within 7 to 10 days after that review. Again, the board believe that the most effective approach to helping these applicants would be to add new staff positions that could facilitate addressing the deficiencies that they face. Funded by an appropriate fee amount, these new positions could support all the applicants who qualify for expedited licensure, not just those who qualify under AB 967. Further, the effective date of this new authorization to expedite these applicants should be delayed for at least 6 months following the legislature's approval of new staff positions. Accordingly, staff recommend a support if amended position, and the proposed amendments are discussed on page 4 of this analysis, and happy to answer any questions.
Comments, questions? Because I have some comments on this one.
Yeah.
Staff recommendation is a support if amended position. Guess I would have us think about whether we should take an opposed position for at least a couple of reasons. One, to do this would require a rulemaking process. I can't tell you how much time goes into rulemaking processes, right, Carrie? And an incredible amount of staff time. It also, not that these amendments are bad amendments for any reason, but the idea that we're going to add new staff, especially in this budgetary environment, so that we can save people between 8 to 14 days, assuming they've have all the information, seems like a poor use of our resources and, you know, ineffective from a government perspective. So I don't support us doing these things, which I guess would mean we take a opposed position potentially, but I'm open to other ideas and suggestions. By the way, it's not that I don't want to expedite anyone's license applications. That's a laudable goal, but this doesn't really expedite their license application. So
Agree. As the bill written right now, it doesn't really move the needle, but with the potential of adding new positions that could address the reasons for a delayed application, that was the thought process behind that, but not to be argumentative with the president.
I mean, and there's many different ways, I suppose, of adding staff positions and coming up with these sort of things. This does not seem like a wise use of our time or resources, to be honest. Dr. Thorpe?
I move an opposed position.
Thanks.
And I second that.
Thanks, Dr. Mahmood. Okay, let's open it up for public comment.
Hello, my name is Lucas Evanson on behalf of the California Medical Association. Thank you for the opportunity to speak on AB 967 by Assemblymember Valencia, one of CMA's sponsored bills. As noted, AB 967 would establish an option for out-of-state physicians looking to provide direct patient care in California to expedite their license application process so long as they pay a $250 fee, which would go to fund the expedited license. CMA continues to focus on addressing physician shortages across the state, though it may seem unrelated, the licensing process can facilitate or create barriers to getting qualified physicians into the state. We have received some reports from our members about losing out on physicians that they were hoping to hire due to lengthy licensing timelines. We appreciate the board's work, or the medical board's work, to improve application processing timelines. To that end, AB 967 is an effort to ensure that physicians can be recruited to move to California and have certainty that they will have an active license to practice when they relocate. We appreciate the thoughtful staff analysis of the bill and the proposed support if amended position. We ask that the board take that recommendation, and we will review the amendments with the author's office and our internal team. We look forward to continuing this conversation with you and your staff. Thank you.
Thank you. Other public commenters? How about on the WebEx, Sean?
If you'd like to make a public comment about this agenda item, please do so by raising your hand or typing anything in that Q&A window. If you're on a call-only line, you can press *3 again. First up here, we have Katie Guthrie. Katie, you should be receiving that prompt.
This is Katie Guthrie with Assemblymember Valencia's office, the author of AB 967. Just would like to start by thanking Aaron Bone for his engagement on this bill on behalf of the medical board. We've had quite a few discussions on this proposal, so really appreciate his questions and then him answering questions I've had as well. As it's been stated, we've brought forth this bill to address delays in licensure for out-of-state physicians. We have heard from physicians in our district at clinics that they have experienced long wait times as such as 10 months to over a year in obtaining their license from the medical board. And those delays were for various reasons, but ultimately it impacted them from starting their job, which they had job offers lined up and they were unable to practice since they were waiting on a license. That is really ultimately why we brought forth this bill with the Medical Association in order to address those delays. And ultimately, we have are up against workforce shortages in the healthcare industry. So this would also, get on board more health professionals and ensure patients have sustained access to care. So really appreciate, your consideration. We will continue engaging with your staff on this bill to try to reach some common ground. So appreciate it again.
Thank you for your public comment. Time I don't see any additional requests.
Thanks. Any additional discussion at the board? Dr. Ayala Rodriguez?
Thank you so much. Been thinking about it, and my only concern is like from the HCI report that it says that nearly 40% of the physicians and surgeons estimate retiring by 2033. And as I hear about this bill, I think, how can we prepare? Like, what can we do? What can we do differently? And I think that if we don't have a time frame attached to the expedited license, the bill as it is, it wouldn't help. If we had a time frame, like eventually we're going to need to expedite license to a certain degree, because there's going to be certain positions that we're not going to be able to find people as fast as possible. And in certain rural areas, we only have one physician and we need to find a replacement. Telehealth expands, like there's like more things that I believe that we're going to be in the need of expediting a license in the future. As it is, there wouldn't be meaningful, but there's a potential for this to be very meaningful if we had a time frame attached to that expedition. But just a comment on that.
Thank you, Dr. Ballant.
Similar to Dr. Ayala's comment just a moment ago, I think that looking for a method. First of all, let's get fact versus fiction. If we would, I would love to see the actual out-of-state timeframes. I mean, it's common statements that it does take time. What I do appreciate, though, is that it's we don't want a quick fix. We want a long-term fix on expediting overall applications to meet the serious situation with the retirees. So I wonder if President Lawson, can we oppose with unless amended in the sense that we want to learn more and keep the conversation going. If we simply oppose, that may be, and I hear you, and you have the most expertise of all of us here serving as our board president, if that would be something we might entertain so that we can continue the dialogue.
Okay. Anyone else? Mr. Reyes, did you want to weigh in on?
Yeah, I just want to address a few things that Dr. Ayala Rodriguez brought, and also to shed light into what we are doing internally with licensing staff. As it is listed in the summary, Mr. Bowen's summary, there's a link in there to our website that shows the processing, initial application review processing timelines that is updated daily. Currently, it is listed like about 40 days to review an application. And like Mr. Bowen mentioned, if the application is complete at that time, within 7 days, the license is issued. Our goal is to bring that down to 30 days. And I've seen that happen, below 30 days to review time. But it all relative to the workload, the number of applications received versus staff available. That's on one side. The other things we are looking into, we are in communication with national entities like ECFMG and FSMB to cut short on the primary source verification tasks to electronically, automating those processes so we don't have to rely on actual paperwork coming in. So we can interface their system with our systems to get those primary source verification documents faster. At the same time, you heard Mr. Torres make a mention about FSMB's alternate pathways for licensure. There are 13 states already passed that kind of legislation already. 10 other states have pending legislation in looking into alternate pathways for licensure. We are at the staff level had an initial discussion about bringing an outside like FSMB or other states that have that legislation in place sometime at the near board meeting to make a presentation to the board to see what we can adopt in California. So these discussions are happening already. It is our goal to cut the red tapeism and bureaucracy and issuing a license, and it is very near and heart to our heart. So just wanted to have that comment.
Thank you. Other comments? So we do have a motion pending with an opposed position.
Can I ask a quick question?
Sure.
We're talking about saving 8 days, and then I hear 7 to 10 days. If 7 to 10 days compared to 72 days, that's a significant difference. So are we comparing apples and oranges? Because once the application is complete, it takes 30 days to review, or does
No.
it takes, okay.
Once an application comes in, it takes about 30 days to review the initial review process. And at that time, if all the deficiencies are met, it takes like about 7 to 10 days to issue a license. And there are exceptions that I just need to point out. There are some applications that do have some, lack of a better word, baggage that would go into a different pathway for additional review. And those will take more time to review. And Marina, you can chime in where I missed.
Sorry, I just wanted to add regarding expedite timeframes. So what an expedite means right now is applications come in and volume does impact the timeframes, of course. The expedite apps go to the top of the pile. So for example, this is just a hypothetical. If it's currently taking us, 30 days to review a new application from the time it's received, we're going to be reviewing those expedited apps first. So those are going to get reviewed much, much quicker. Internally, I want to say the goal is about to review those apps within a couple days. Again, depending on volume, maybe you get hit with a bunch of expedite apps at any particular month. It's just a high month, but we do have internal goals to review expedite apps faster. And then also once it's reviewed, if it's deficient and there's additional documents coming in after that, again, the goal is to review those within a couple days. So they go to the top of the pile. So if I have 50 deficient applications, if I get a piece of mail in for one of those deficient applications, or it's not mail anymore, I got to stop saying that, electronically something comes in for that app, I'm going to review that first out of the other ones I have that I also receive documents for. So it does depend on volume, but that's how it's basically expedited. It goes to the top of the pile of all your apps. Your priority or expedite review apps are going to be reviewed first. So it is much faster but on average, because of the deficiencies from receipt to licensure, it doesn't make a huge difference. But it does for the initial review of the application and for any subsequent documents that come in. But for the overall timeframe from receipt to issuance, that's dependent on the deficiencies.
Carrie, did you want to make a comment?
Yeah, I wanted to remind everybody that we did have a period of significant backlog based on legislative changes that the board disapproved of, took opposed positions on. But staff have worked super, super hard to bring down the time frame. So the concern about delays, there was a period of time where certainly that was a problem that the board took a lot of steps to resolve. And I'm sure that no one is suggesting that we license individuals where we don't have primary source of their education and postgraduate training. And so we have to have those documents. If someone has convictions of crimes substantially related to the practice of medicine, I know you all want staff to review that carefully. A pattern of malpractice, other unusual circumstances, you would expect board staff to review those carefully. So expedited bills, these are all the issues that, give us pause. And the bill does not set the fee. So as it's worded, the board would have to do a rulemaking. And what would the fee be? Because it has to go through the same process. So it's just a conundrum. Doesn't make a lot of sense to staff that we're going through this.
I mean, it to that point, it doesn't make a lot of sense to me that we're going through this. So not only are we going to have to then, if this is approved, we're going to have to go through the rulemaking process. So this board's going to spend, I don't know, a couple of meetings talking about it. Staff's going to spend a bunch of time working up what the expedited fee is. I mean, when we're talking about systems problems and we're tinkering around the edges, hoping to solve the problem for one small cohort. And, as the person that usually ends up with an email in my inbox that says, hey, I've been trying to apply for a license for months now, 100% of the time when I forward that to staff, 100% of the time, it's never come back saying, whoops. They come back saying, there's a deficiency with this application, or it's going through some higher level of review 100% of the time. So there's usually some reason why it's taking longer than everyone would expect. I think this is a waste of our resources. I really don't, if folks are focused on helping us be more efficient, next time we go through sunset, support some fees so we can get some more people broadly for us to do that, rather than tinkering around the edges with bills like this.
Madam Chair. And also it gives every time we come up and keep on increasing, find ways to increase the fees and kind of stuff. If you want to increase, make the process more efficient and increase for everybody. It will become like a VIP culture. Okay, you can give $500 more and you can get on the top of the line. I think we should treat everybody as a priority. And if it's needed, as you said, the next review, we can go up and feel a bit more. But I think we should not leave it for the dialogue. I stick with the motion Dr. Top gave, and I second it.
Yeah, I mean, the oppose is fine, in my opinion. Oppose if amended is fine. I think everybody's heard my comments. But
Oppose.
Anyone want to make a substitute motion?
I don't know if it's within the rules of order, but I wouldn't be opposed to amending my motion to oppose if amended.
Or unless amended?
I mean, oppose unless amended.
What amendments are we seeking?
What is the amendment you're seeking, by the way?
Yeah.
Actually,
I'm going to withdraw
I
my.
don't know. I have to say, I realize I just want to go on record that I'm opposing a California Medical Association bill.
Please make sure to send out a press release on that. Yes.
Yeah.
All right. I think we've got a motion on the table to
Sounds like it's opposed. Straight oppose.
Straight oppose.
Okay.
Yes.
Okay. Ms. Struther, would you please perform the roll call vote?
We did public comment. Yeah.
We did. I think so.
Dr. Ayala Rodriguez,
Yes.
Dr. Bullock,
Yes.
Ms. Chung,
Yes.
Dr. Helzer,
Yes.
Dr. Mahmood, Dr. Thorpe,
Yes.
Ms. Torres,
Yes.
Dr. Sai,
Yes.
Dr. Yip,
Yes.
Ms. Lawson.
Yes. All right.
That was lively. Thank you, members.
I didn't expect that one to take as long as it did. AB 985.
It's our second anesthesia-related bill today. This one would establish the Anesthesiologist Assistant Practice Act, which authorizes a new mid-level healthcare practitioner known as an anesthesiologist assistant, or AA. These individuals would be authorized to work under the direction and supervision of anesthesiologists and assist in the development and implementation of anesthesia care plans for their patients. 22 other jurisdictions around the country authorize AAs to support anesthesiologists and provide care to patients. Under this bill, AAs must complete an appropriate training program and hold an active certification from the National Commission for Certification of Anesthesiologist Assistants. The bill provides title protection for AAs, requires that they work under supervision, and allows them to assist in the development and implementation of care plans for patients. The bill does not include licensure for these professionals, which staff note creates certain risks for patients. Like with AB 876 discussed earlier in the meeting, engaging in a deliberative process is ideal to evaluate significant changes in how care is delivered to patients. Some possible actions for the board to consider today include taking some sort of a position, taking no position, and directing staff to monitor the bill's progress or gather more information and report back at a future board meeting. But we have no position recommendation at this time, and I'm happy to answer questions, Madam President.
Comments or questions? Dr. Helzer.
Thank you. I think there is a clear need to expand the anesthesia workforce in California. Many hospitals, including my own, are short-staffed in their anesthesia departments, and we're having a difficult time recruiting and retaining qualified providers. So I think the intent of this bill is commendable. I am concerned about the lack of provisions for licensing CAAs, and I believe that that any mid-level practitioner engaged in a high-risk patient activity and handling controlled substances should be licensed as other mid-levels are.
Thank you. Other comments?
I strongly echo your words, and I think we should not support this until the licensing is involved in this thing, because they are directly patient care criteria, and you cannot let people play with people's life without having, and if they don't have license, there's no liability, there's no punishment. So that should be definitely, we should not only just put amended, if we want to support this, we should put that there should be a licensing requirement.
Thank you. Other comments? All right, let's open it up. Excuse me.
I'm curious, where more PA, more MP who go into specialty field like orthopedics, vascular surgeon, stroke team, and all that. I'm just curious in the anesthesiologist profession, is there any thought about having PMP be part of the assistant team, pre-op, post-op, and provide certain relief of the burden, rather than create another category which is not licensed or regulated?
I'm not aware of any current training programs specifically for PAs to participate in anesthesia care, although I believe this is analogous to what is being proposed here.
Okay, does anyone want to make a motion?
I'll make a motion with only support if licensing requirement is added and there's a due diligence done on what are the licensing requirements are.
To ask a clarifying question, if I may, Doctor, the board has I would say, a robust recent history of not supporting bills that would seek to place licensure for a new profession in this board. We had that with athletic trainers and at least another one, the name escapes me. So when you say licensure, you don't mean that this board should take on the licensure of responsibility. It should be an unnamed licensing board.
Exactly. Yes. Not this board. And to be very honest, it's athletics trainers are completely different than this particular entity. This is a direct patient care in a critical situation. Although they'll be working under supervision, but still they have a lot of responsibility. But yes, not medical board is going to take that licensure. They should have on their own entity, or somebody else should take it.
Okay, thank you.
Sorry, so we had a motion to oppose unless amended to include a licensing requirement. Do we have a second? Do we have a different motion? That motion dies because it didn't get a second.
Public comment?
Public comment.
Hi. All right. Thank you guys again. Dr. Christina Menor, anesthesiologist, president-elect for the California Society of Anesthesiologists. CSA is the proud sponsor of this AB 985. As was earlier heard, there were issues in Modesto, and one of the biggest issues was concern that cases were canceled because of access issues. One of the issues to address this is a workforce, and this is an alternate group of practitioners who can provide such a workforce in a very easy setting, in the sense that there are many CAAs outside of California who are from California practicing in other states currently, who can return to California and are willing to return here to provide services to patients of California. As we face this continued anesthesia shortage, it's exacerbated by increasing demand for workload, increasing patient age as well as physician age, and expanding use of anesthesia services outside of the operating room. So multifaceted approach. We need to increase nurse anesthetist training. We need to increase anesthesiologist residency programs. But we also need to introduce this new class of anesthesiologist providers, anesthesiology providers, to allow for additional workforce in the state. They're highly trained professionals who work under direct supervision of physicians, anesthesiologists. In addition to this workforce, they will immediately help fill this gap and capacity to help increase access to physician-led care. They do not replace anesthesiologists. They do not replace CRNAs or nurse anesthetists. Opposition will state that this is something, why do we need to bring a new class of practitioners into the state if nurse anesthetists are already providing some of this care? The reason is what Dr. Helser said earlier. There are not enough nurse anesthetists. There are not enough anesthesiologists in the state. This allows for additional workforce. This is a team care approach, and it is necessary to maintain the highest standards of anesthesia practice in California while providing an immediate solution for this crisis. We are willing and able and look forward to hopefully working with the board on solutions to get this class of practitioners into the state. And, if you have questions or comments, we are open to hearing those. Thank you again for your consideration, and strongly urge you to support AB 985. Thank you.
Thank you.
Oh, yeah, I just had some clarifying questions not for Mr. Bone or for others. And here's my question. Maybe I didn't read it or I don't see it. What are the roles, responsibilities of this new group that's being proposed to serve? I mean, when I read it, it made me think about medical assistants. Now, and I'm thinking about AAs or
MAs.
MAs, and these are
AAs. A lot of A's, doctor.
So yes, a lot. Yeah. So these AAs, who are these AAs? What's the training? Where are they getting trained? By whom?
So that may be best answered by the sponsors and the other supporters of the bill. But the questions that you're raising, doctor, are fantastic, and they illustrate the challenge with scope bills and, limited staff time and resources to really dive into these sorts of questions that I think, the board or some other licensing entity, to Dr. Mahmood's point, would love to lift up the hood and really see, what goes on in training and then, authorizing one of these individuals. So unfortunately, I can't be, more specific than that, doctor, but that's the challenge with evaluating some of these bills.
Thank you.
Okay. I mean, I'll say the bill says that the anesthesiology assistant may assist the supervising anesthesiologist in developing and implementing an anesthesia care plan for a patient. So, they're using discretion, which that they're like medical assistants, they're not licensed. And so, the board is not getting fingerprints and ensuring that they meet the requirements for their training. And they have very close contact with patients and controlled substances. And not just in hospital systems. This is not limited to just hospital systems. So, you're talking about folks in private practice that may not have the same type of credentialing.
All right, let's public comment.
Yeah, I was just going to say, just to follow up, I think the right people are on the line, Doctor, that will be able to hopefully help fill in some of the gaps that you were asking.
All right. Can you fill in the gaps? I'm just kidding.
Unfortunately, no. Hello, my name is Lucas Evanson, and I'm speaking on behalf of the California Medical Association. We align our comments with the California Society of Anesthesiology. This bill will increase the capacity of the California healthcare workforce while preserving the physician-led model of anesthesia care. For that reason, we ask that the board support this critical measure to ensure physicians have the support they need to provide the highest level of care for patients. Thank you.
Thank you. Additional public comment in the room? Any on WebEx?
If you'd like to make a public comment here for AB 985, please do so by raising your hand, typing anything in that Q&A window, or pressing *3 if you're on a call-in only line. First up here, we have Shane Angus. Shane, line should be available to open.
Good afternoon. Thank you very much. Good afternoon, board and president and members of the board. My name is Professor Shane Angus, and I am an anesthesiologist assistant. I've been practicing for 25 years outside of California at some of the top medical centers in the nation. I happen to also be a 6th-generation Californian, a Santa Barbara native, and a UC Berkeley graduate. And I'm also the executive program director for Case Western Reserve University's School of Medicine, Master of Science in Anesthesia program, and I speak today solely on my own behalf. Let me start by reassuring the board. AB 985 intends to increase access and maintain quality in line with state and national approaches via delegation, an approach that already is used in many other states across the country. Additionally, to the point brought up earlier in the questions, our students reflect the highest standards of medical education. They meet and often exceed typical medical school entry averages. Our average GPA of a 3.8 and an MCAT of 508 is squarely in between the allopathic and osteopathic average acceptance scores. Many come from top national university, of course, including California, like myself, and they bring frontline experience as firefighters, paramedics, nurses, researchers, and veterans. As I said, I've been practicing for over 25 years, but this profession itself is over 55 years old, and it has an exemplary safety record built on a rigorous graduate level curriculum with national certification and mandatory recertification. The delegation, supervision, and medication handling are already covered and governed. Specifically for us, it functions under the U.S. Drug Enforcement Agency Rules 21 CFR 1300.01, where controlled substances are managed through our attending physician. Just like any other mid-level professional, CAs function under supervision, and the responsibility of the care remains with the attending anesthesiologist, which is already regulated by this board. The medical liability, importantly, and this oversight are exactly covered the same between all professions. So it's the CA malpractice insurance, which is written by the same carriers as our colleagues within the ACT, the care team, with the same risk class and the same premiums. There is no divergence in risk profile, whether delegatory or licensed, in the states in which we practice. Credentialing, case assignments, and supervision ratios are all managed locally, and this is specifically done in areas related to delegations, such as Texas and Michigan's, where CA has been practicing for over 25 years in delegatory approach, similar to what this is trying to do. We also work in some of the nation's premier institutions. In those specific 2 states, we work at MD Anderson, UT Health, Texas Children's, throughout Dallas and Austin and the Valley, and in many leading institutions within Michigan. There is a familiar path that has been successful across the country. Many states, Ohio, Wisconsin, Colorado, New Mexico, began with delegation-based approaches and later moved to licensing once the workforce demand increased and there was enough legislative support and need to recognize it. AB 95 creates an alignment between California and national standards and
Please
sets the
conclude.
stage. for the hospital to move forward. Thank you for your time.
Thank you for your public comment. Next, here's Melanie Rowe. Melanie should be receiving that.
Hello, thank you. I am Melanie Rowe. I'm a CRNA in California and the director of the California Association of Nurse Anesthesiology Practice Division. This bill is dangerous and unprecedented. Our patients in California deserve better care while under anesthesia. Regarding some of the previous comments, if there are anesthesiologist assistants who would like to return to California, Texas Christian University has a transition program because our education is very different, our background is very different, and it will be faster for them to go through that transition program. And we welcome them to California and become CRNAs here and help us with our workforce issues. On behalf of California Association of Nurse Anesthesiology, we agree with the medical board analysis. Thank you.
Thank you for your public comment. Next here we have Charles Allen Griffiths. You should be receiving that prompt.
Yes, hi. I'm Chuck Griffiths, nurse anesthetist. To me, AB 985, supported by the California Society of Anesthesiologists, is an attempt by a medical specialty to capture and maintain market share. AAs, remember, cannot work without an expensive physician anesthesiologist supervisor who does not give patient care in their supervisory role. When you hire an AA, you have to hire a physician anesthesiologist to supervise them who will not be caring for patients. So to increase the number of anesthesia providers in California, yeah, if we need more, let's increase the CRNA and medical residencies. You know, these are proven providers that can provide safe care. AAs do not have required patient care experiences prior to their training in anesthesia as a specialty, like nurses and physicians in anesthesia, who both have thousands of hours of experience before we actually go out into the clinical arena. So what I would say is, why bring in a provider that requires hiring two providers, one of which is unlicensed in the state? It's redundant, it's expensive, it's an unnecessary measure. Stick to CRNAs working independently and physician anesthesiologists working independently and taking care of patients instead of supervising somebody. And remember, CRNAs can function safely and independently as supported by many national quality studies and California law. So this measure will increase the cost of anesthesia care by requiring two providers, where only one can often be sufficient. So thank you. And I would really like you to consider opposing this bill. Thank you.
Thank you for your public comment. This time that's the last request in queue.
Okay, we'll bring it back to the board.
So I think to reflect on Dr. Bolat's comment, I think they're going to be more like PAs than MAs. I think they're probably going to be able to intubate, give meds, rather than just being an MA, draw blood and take vitals. Because I think that's what it sounds like. And with that said, would this be a better issue for the nursing board and the PA board to reflect than the medical board?
Well, the bill right now, doctor, doesn't call for any role for any board because there's no licensure. There's no. Oh, yeah, I don't know if those. I don't know. So there was no position taken on the other anesthesiology bill. So,
Yeah,
Want to make a
I would-
motion, or do we just want to move along?
I would say we stay neutral on this. I mean, it appears to me, and I don't mean to be crass here, but there is a content, there is an issue of market. There's a number of issues between the CRNAs and the anesthesiologists, and this appears to be kind of an end around move to me. But that may or may not be true. Is this the best move? I don't know. This gentleman who said he's been practicing as a certified anesthesia assistant for years and doing it in all these great places. I mean, I'm not questioning that. We don't have that kind of experience here in California. I guess I would just prefer to stay neutral on this bill and wait and see how things play out in the legislature and get a report back in August and see where we're at.
And if there's any other comments that, I mean, we have the one from Dr. Mahmood about licensure. If there's any other comments that the board would like to share that the sponsors should take into consideration as they are continuing to work with the legislature, this is a great opportunity to provide other feedback, as I know they're right behind me and listening.
I just would say that I think this, I'll go back to what Dr. Thorpe just said. I think this is something that still needs a lot of work. I think between the CSA, CRNA, it's a big issue, and I'm myself not prepared to take an action on this. And so I would say I'd just like to recommend that we move on at this point.
So let's move on to SB 387. Yes, is that what's next?
It is, Madam President. That bill proposes to update the definition of an academic medical center so that City of Hope may qualify to sponsor applicants under the Special Faculty Permit Program. The members should have received a new version of the analysis, which states updated analysis up in big red letters at the top of each page. The bill would change two of the definitions related to qualifying as an academic medical center, or an AMC, which include the number of resident physicians in training and their accreditation requirements. It is expected that under this bill that City of Hope would be the only new organization to qualify under this bill, as the other comprehensive cancer centers in the state are affiliated with a medical school and therefore already have access to this program. The updated analysis was issued so that it could include amendments requested by Cedars-Sinai, which would ensure that they maintain their position on the Special Faculty Permit Review Committee, and would also allow each AMC to seek up to 5 new permittees each year, rather than under current law, it says 5 for all AMCs. Staff do not have concerns about these amendments, and the stakeholders have requested specifically that the board members provide feedback to them on it. Staff do not have a recommendation on the bill in chief, but if the board believes that City of Hope is suitable for inclusion in the Special Faculty Permit Program, then a support position would certainly be appropriate, and we're happy to answer any questions. And the sponsors and advocates are here as well, and they look forward to addressing the board.
Questions, comments? Anyone with a motion to start, or should we go to public comment? Let's go to public comment.
Thank you. So Chair Lawson and members of the board, I'm Dr. Mark Stewart. I'm a professor of hematology and a blood and marrow transplant physician specialist at City of Hope Comprehensive Cancer Center. I'm also the chief medical officer at City of Hope in Duarte. I came to California about 4.5 years ago from the Fred Hutchinson Cancer Research Center and University of Washington in Seattle, where for 20 years I was the chief medical officer for the cancer center there. So I continue to practice and provide training in oncology and hematology, and I care for bone marrow transplant patients at City of Hope. So cancer diagnosis and treatment, as probably many of you know, is advancing quickly. Many of these advances are developed and delivered at our nation's 57 National Cancer Institute designated comprehensive cancer centers, which includes City of Hope. City of Hope is home to the largest bone marrow transplant program in the nation, and we are leading center for cutting-edge clinical trials in what we call CAR T-cell treatments, or a form of immunotherapy. We serve more than 120,000 patients annually. Treatment innovations that have been developed at City of Hope have saved hundreds of thousands of lives annually around the world. We have large centers in Duarte and Orange County, and we have 35 outpatient centers in Southern California that really bring City of Hope care to patients in their communities. All of our specialists are dedicated to one concept, that is delivering the best care to patients afflicted with cancer. So City of Hope is an academic medical center that since 2018 has trained more than 320 fellow and resident physicians as part of its ACGME training program in highly specialized areas, including hematology, oncology, cancer survivorship, reconstructive urology, reconstructive microsurgery, radiation oncology, and of course, transplantation. In reviewing the existing criteria for the Special Faculty Permit program, City of Hope qualifies, as you heard, under all criteria except for the number of GME fellows that we train annually. We have exceptional training programs currently as reviewed by our ACGME organizations, and we believe that the California Physician Specialty License Program could help City of Hope and even more effectively serve the needs of our cancer patients in our state by allowing us to bring in top international cancer care innovators from outside the United States who can join our faculty to train our fellow and resident physicians in new advanced care technologies, cutting-edge surgical techniques, and innovative clinical trials.
Please conclude.
Okay, ultimately, this helps bring innovations in the laboratory into the clinics to help our patients. And in essence, in summary, we think that this bill or the revision of this bill brings new innovations and care technologies to the patients that need them, and I ask you to support this bill. Happy to answer any questions.
Can I just take a point of personal privilege? I had the significant honor of spending 3 months at the Fred Hutchinson Cancer Research Center when I was a medical student many years ago. But it was a transformative experience, and I just had to throw that out there when you said Fred Hutchinson Cancer.
There's a great book out now you might be interested in by Fred Applebaum.
Oh, wow.
About Don Thomas and the story of transplantation.
Yeah, and I have firsthand experience. I am from that area, and I have a huge regard for City of Hope and work they're doing, and the way you're expanding and covering all over Southern California. It's tremendous facility, and it's really doing great work.
Thank you.
All right. Thank you. Next public commenter.
There we go. Good afternoon, Madam President and members of the board. Alfredo Medina here with Manat Phillips and Phillips on behalf of Cedars-Sinai Medical Center to address the proposed amendments to SB 387 as outlined in the analysis. We appreciate the board's consideration of the language, and as drafted, it clarifies the eligibility requirements of the Special Faculty Permit Review Committee. Joining me virtually is Kimberly Fernandez, Manager of Academic Programs at Cedars-Sinai, who is available to provide technical support and answer any questions you may have. Thank you once again for your time and consideration.
Thank you. Point of personal privilege to say hello to my former colleague from Manat.
Thank you.
Any comment? Any more public comment in the room?
Hello, my name is Lucas Evanson on behalf of the California Medical Association. CMA appreciates the staff analysis and asks that the board adopt a support position on this bill. Thank you.
Additional public comment in the room? Okay, how about on WebEx?
If anyone would like to make a public comment on SB 387, please do so by raising your hand, typing anything in that Q&A window, or if you're in a call-only line, you can press *3. Give you a few seconds to see if anyone queues up. Not seeing any requests at this time.
Madam President, I'll make a move.
Okay, bring it back to the board. Dr. Mahmood?
I will make the motion to approve.
Second.
To support? Okay. Dr. Sai?
Has to say something. I think it's been trying.
Okay, so we have a motion to support, a second from Dr. Sai. Dr. Yip, you have a comment?
I need to abstain myself from voting. I just want to disclose I'm on the staff at City Hope. Two of my son are City Hope surgeons, and my daughter-in-law also City Hope anesthesiologist. I also sponsor a fellowship program that recruit bright scholar from South America and Europe to learn about the City Hope oncology. We're the first institute in Southern California that provide that performed the first robotic prostate surgery. So it's an institute that is an international level. Thank you.
Thank you. Any other comments?
Madam President, if I may, could I ask a clarifying question of, I think it's Dr. Mahmood made the motion, that in your support, is that also your support is inclusive of the proposed amendments in the bill? So not only we support the bill, supportive of the bill in chief,
With the amendments,
would also support the bill as it is proposed to be amended?
Yes.
Great. Thank you for that clarification.
Just for, there's
Your mic, please.
I'm not sure part of the proposed or motion that there's a line that say it need to be if they have not held a special permit under section 2113 for 2 years or more, present data application, the board may choose to waive this requirement. So I'm not sure it need to be attached to that or separate.
I'm sorry, Doctor, where are you reading from?
Reading from your notes.
From my memo? Oh.
Update analysis.
Okay, good. Well, it's a good read. You're in a good, which page are you on, Doctor?
That's existing.
Yeah,
law.
yeah.
It's not being changed in this bill.
No, I'm just saying that when he proposed to support, do you also need to make that waiver? I'm just saying that.
No, that's not being impacted by the bill. Yeah.
Thank you.
Yeah, the point is the board supports City of Hope's inclusion in the program and supports the language, the amendments that are in the analysis.
And then
For Cedars.
They need to come back for the special permit committee to get approval waiver.
Well, so under the bill as it would be amended, Cedars would retain its spot on the committee. I don't know, somebody would have to forward the application on from City of Hope. I'm not sure how that would work exactly, but City of Hope would be able to put forward their application. They wouldn't have a spot on the committee. The committee would continue to do their work. And then this board approves the suggested applicants.
All right, roll call vote.
Dr. Ayala Rodriguez.
Yes.
Dr. Balat.
Yes.
Ms. Chung.
Yes.
Dr. Helzer.
Yes.
Dr. Mahmood.
Yes.
Dr. Thorpe.
Yes.
Ms. Torres.
Yes.
Dr. Sy.
Yes.
Dr. Yip. Ms. Lawson.
Yes. That motion carries. Thank you all for joining us.
The next bill, if I may, Madam President, is SB 470, which extends for a 4-year period the sunset date on an existing law that authorizes state bodies like this board to meet remotely under certain circumstances. This law has been in effect since 2024 and was authorized to provide state bodies some increased flexibility to meet remotely following the time when state bodies were meeting almost entirely remotely during the COVID-19 pandemic. Under this current law, the board's advisory bodies, like the Special Faculty Permit Review Committee and the Midwifery Advisory Council, meet remotely. This current authority helps to reduce the cost and time to hold such meetings and facilitates member participation and engagement. The board supported the prior law that this bill seeks to extend, and staff recommend a support position.
Comments, questions, or a motion?
I move to support.
Thank you. All right, we have a motion and a second. Let's open it up for public comment. Seeing no one jumping up in the room, is there any on WebEx?
If anyone has a public comment on SB 470, please raise your hand, type anything in that Q&A window, or if you're in a calling line, you can press *3. Give me a few seconds to see if anyone queues up. Not seeing any requests at this time.
All right, we'll bring it back to the board. Any comments or questions? All right, Ms. Struther, will you perform the roll call vote, please?
Dr. Ayala Rodriguez.
Yes.
Dr. Balat.
Yes.
Ms. Chung?
Yes.
Dr. Helzer?
Yes.
Dr. Mahmood?
Yes.
Dr. Thorpe?
Yes.
Ms. Torres?
Yes.
Dr. Sai?
Yes.
Dr. Yip?
Yes.
Ms. Lawson?
Yes. All right, that motion carries.
Next is SB 508, which modestly expands an existing licensure exemption that allows out-of-state physicians to treat patients via telehealth who have an immediately life-threatening disease or condition. If a physician does not need a license to practice medicine in California, unfortunately, then the board would be unable to take disciplinary action against them if they act in an unprofessional manner. Under SB 508, the patient would continue to have authority to see the same physician even if their disease or condition is in remission. The board opposed the prior bill from 2023 and recommended an opposed position on this bill as licensure exemptions increase the risk that patients will not be treated within the standard of care. And we're happy to answer any questions.
Comments or questions? Dr. Thorpe?
I just don't see any reason why we would change our position on this bill. I mean, yeah.
On the policy in general.
On the policy
Yeah.
in general.
Is that a motion, Dr. Thorpe?
I move to oppose.
Second.
I mean,
I'll second that.
I move to take an opposed position on this
A second.
legislation.
All right. Dr. Helzer seconded. Others tried to as well. Okay, let's open it up for public comment.
Hello, my name is Luke Sevenson. Speaking on behalf of CMA, we appreciate the staff analysis and ask that you take the staff's recommended position. Thank you.
Thanks. Any other commenters in the room? All right, Sean, how about on WebEx?
Anyone would like to make a public comment on SB 508, please do so by raising your hand, typing anything in that Q&A window, or pressing *3 if you're not calling only line. Go ahead and call on Eric Andrews here in case he'd like to make a comment. Okay, I'm not seeing him accepting that request, so I don't see any requests at this time.
Okay, let's bring it back to the board. Not seeing anyone jumping up to comment, or let's please please have a roll call vote.
Dr. Ayala Rodriguez?
Yes.
Dr. Bullock?
Yes.
Ms. Chung?
Yes.
Dr. Helzer?
Yes.
Dr. Mahmood?
Yes.
Dr. Thorpe?
Yes.
Ms. Torres?
Yes.
Dr. Sai?
Yes.
Dr. Yip? Ms. Lawson?
Yes. Moving right along now.
Thank you, members. SB 626 is our next bill, which laudably aims to improve access to quality perinatal mental health care in two ways. The first is to amend current law to require health insurers to develop a program that would provide mental health screenings during pregnancy, the perinatal, and postpartum periods in accordance with guidelines adopted by the American College of OBGYNs, or ACOG, or standards from other recognized bodies if the ACOG guidelines are not aligned with the provider's scope of practice. In addition to the requirements for insurers, the bill similarly requires licensed care providers who provide perinatal care to do so in accordance with ACOG guidelines or standards from other recognized professional bodies, again, if the ACOG guidelines do not align with the provider's scope of practice. The bill also states that this proposal does not require a provider to follow any specific guidelines if they are inconsistent with the standard of care, and includes language indicating that the bill does not limit the authority of a licensing board to determine whether a practitioner has met the standard of care. The board staff are concerned with the language in the bill that aligns the standard of care with professional guidelines. Guidelines can certainly inform the standard of care, but they do not dictate necessarily what a provider should do with a particular patient. Relatedly, the relevant ACOG guidelines include an important disclaimer that states that they are an educational resource to aid clinicians and are not inclusive of all proper treatments or as a statement of the standard of care. Further, ACOG states in those guidelines that they are not intended to replace the independent professional judgment and may not reflect the most recent evidence. While well-intentioned, staff are concerned that the language related to professional guidelines might not always lead to an appropriate diagnosis and treatment. I've already begun a positive dialogue with the author and the sponsor, and have tried to explain the challenges of legislating the standard of care And the most recent amendments in the current version of the bill were made after that dialogue commenced. We all agree with their goal to improve the quality of care, and that's certainly very worthy, but there just simply may be differences in how to accomplish that through this bill. Accordingly, staff are recommending that the board adopt a supportive amended position to seek amendments that would simply and clearly state that patient care, including the required insurance programs, should be provided according to the standard of care. This may require ongoing dialogue with the author and sponsors. Therefore, staff recommend delegating authority to the president and the vice president to work with staff to determine appropriate amendments that would address the board's concerns. We're happy to answer any questions.
Comments or questions?
But definitely very much needed. This is really a need of the hour. Everybody needs to go through this thing. And I think the staff recommendations are very appropriate. We should have some kind of guidelines, but this is really needed.
Okay.
Mental health.
Are you making a motion to move staff's recommended position?
Yes.
Okay. All right, we have a motion and a second there. Let's open it up for public comment. I don't see anyone jumping up in the room. How about online?
If anyone would like to make a public comment on this agenda item, please do so by raising your hand, typing anything into that Q&A box, or if you're on a call only line, you can press *3. First up here, we have Casey. Casey, you should be receiving that prompt.
Can you hear me okay?
It's a little muffled, Casey, but we can hear you.
Okay, thank you. Sorry, I'm with my kids in the car here. Thank you. Good afternoon. I'm Patsy Gardner-Manjikian. I'm a mom of 3, a board member of Maternal Mental Health Now, a volunteer co-founder of the California Coalition for Perinatal Mental Health and Justice, and a proud co-sponsor of SB626. I want to thank Erin Bone and the board for engaging thoughtfully with us on SB626. This bill was born out of lived experience and collective frustration with the gaps in California's perinatal mental health care system. In 2016, I had what many would consider a perfect pregnancy: private insurance, a public health degree from UCLA, a strong support system, and I'm white. I took a standard depression screen and felt fine, but no one asked about my history of anxiety, depression, or previous psychotic episodes. I gave birth, went home 4 hours later, and couldn't sleep for 5 days. I began hallucinating. My husband called my OB and midwives, and none of them recognized the symptoms of postpartum psychosis. At the ER, I was transferred to a psych ward where I was bound in leather restraints and sedated. My recovery took 7 years and cost over $30,000 out of pocket. And I'm one of the lucky ones. Black and Latino women are disproportionately impacted and far less likely to receive care. Over 80% of pregnancy-related mental health deaths are preventable, yet only 15% of those who screen positive receive treatment. SB626 is our coalition's response to these gaps. It builds on existing law by clarifying that perinatal care providers should screen, diagnose, and treat perinatal mental health conditions using clinical guidelines appropriate to their life stage. The bill was recently amended to remove insurance coverage mandates for medications and digital therapeutics, and its primary focus is now on care coordination and follow-up. We understand the board's concern that clinical guidelines, such as those from ACOG, should inform but not define the standard of care. So it's not mandate ACOG adherence. Rather, it allows for any applicable evidence-based guidelines relevant to the provider's license. ACOG's guidelines are widely used and often co-endorsed by organizations like CMPCC, APA, and SAMHSA. Our goal is not to lock in one pathway, but to support provider discussion, ensuring that someone goes up and that ACOG guidelines are looked to as best clinical practice that can smart equity accountability and access, and respectfully support continue to engagement. Thank you.
Thank you for your public comment. At this time, I don't see any additional requests in queue.
Okay, we'll bring it back to the board. We had a motion and a second. Any further comment? Okay, Ms. Strother, if you'd please perform the roll call vote.
Dr. Ayala Rodriguez.
Yes.
Dr. Bullock.
Yes.
Ms. Chung. Yes. Dr. Helzer,
Yes.
Dr. Mahmood,
Yes.
Dr. Thorpe,
Yes.
Ms. Torres,
Yes.
Dr. Sy,
Yes.
Dr. Yip,
Yes.
Ms. Lawson.
Yes. SB 641,
We regrettably come to the last bill.
Regrettably.
members, regrettably.
regrettably.
SB 641 authorizes all DCA licensing boards authority to waive certain licensing requirements during a declared disaster or emergency, including examination eligibility and timing requirements, licensure renewal deadlines, continuing education deadlines, license display requirements, fee submission, and delinquency fees. The bill also prevents a licensing board from charging a fee for replacing a wall certificate to licensees whose home or business is in a declared emergency or disaster area. And the bill suspends the requirement to report a change of mailing address to each board if that licensee's home or business mailing address is in a declared disaster area. Board staff believe that the authority offered by the bill could provide this and other boards flexibility to help licensees endure emergency situations and promote access to care. We recommend a supportive amended position to seek the following changes, which would also obviate the need for regulations. One, authorize a board designee to determine whether and how to exercise the authority to waive licensing laws. Two, provide licensing boards with more flexibility to determine the length of time to waive the licensing laws. The minimum length to get these waivers is 1 year, which may be too long depending upon the circumstances. And finally, to authorize a board designee to determine when impacted licensees must resume paying to replace proof of licensure, aka wall certificate, and resume reporting their change of address. Happy to answer any questions.
Any questions or comments?
I move to support. Being from the fire area, I know a lot of people are affected by this, so I move to support.
Thank you. All right.
So, as in support the staff recommendation? Okay.
Sorry, support.
Thank you.
If amended.
Thank you, Doctor.
Great. I think we had a prior second from Dr. Helzer. Any public comment in the room? Any comment on the line, Sean?
If you'd like to make a public comment here on SB 641, please do so by raising your hand, typing anything in that Q&A window, or pressing *3 if you're on a call-only line. Give you a few seconds to queue up.
Okay.
I don't see any requests.
Great. We'll bring it back. Any comments? Ms. Struther, if you perform the roll call vote for us.
Dr. Ayala Rodriguez,
Yes.
Dr. Bulat,
Yes.
Ms. Chung,
Yes.
Dr. Helzer,
Yes.
Dr. Mahmood,
Yes.
Dr. Thorpe,
Yes.
Ms. Torres,
Yes.
Dr. Sy,
Yes.
Dr. Yip,
Yes.
Ms. Lawson.
Yes. All right, that motion carries. Any last minute additions from the legislature to the agenda?
12 members,
Okay.
actually. No. Thank you for your patience, members.
Thank you, Mr. Bone. I believe we have time permitting to get through our the remainder of our agenda items, unless anyone wants to stay for another day. But let's head on through. All right, we're skipping agenda item 8, which would be calling this meeting to order again, and we're moving on to agenda item 9, which is discussion and possible action related to the Midwifery Advisory Council. And Doug, I think you're handling this for us. Is that right? All right.
Unfortunately, Madam Wisner is unable to attend. Unable to attend due to a medical emergency, so I'm going to present on their behalf as best as I can. So the background, in the last MAC meeting was held on April 3rd, 2025. And at this meeting, the following actions were taken, and the MAC was provided with the following information. Approved meeting minutes from September 12th, 2024. Received an update from the MAC chair. Received an update on midwifery legislation. Received an update from the task force on Medi-Cal related issues. Received an update on the midwifery program. The MAC voted to select Karen Rosley to fill the public member vacancy effective June 30th, 2025. Received a verbal presentation on midwife access to audiology equipment for newborns. Had a discussion on accessibility and sustainability of California midwives, and received a presentation on the LMAR and opportunities for better data collection. So for the requested action, after review and consideration, approve the appointment of Karen Rosley to the public member position for the 3-year term that will expire on June 30th, 2028, and approve the following agenda items for the next MAC meeting, which will be held September 11th, 2025. Approval of the minutes from the April 3rd, 2025 MAC meeting, report from the MAC chair, report from the task force on Medi-Cal related issues, update on midwifery related legislation, if applicable, update on the midwifery program and the 2024 licensed midwife annual report, the LMAR, vote on 2026 MAC meeting dates, presentation on frequency and rationale of free birth, discussion on environmental exposures faced by midwives, discussion on midwifery payment model, discussion on accessibility and sustainability of California midwives, discussion on presentation to the board, and discussion on community birth partnership initiative. So the recommendation is to approve the MAC's recommendation to appoint Karen Rosley to serve on the MAC effective June 30th, 2025, and approve the agenda item as requested by the MAC.
All right. Do we have any questions, comments, or a motion? All right. Move to approve staff's recommendation by Dr. Thorpe. Do we have a second? A second by Dr. Mahmood. Let's open it up for public comment. I'm not seeing any here. How about on the line, Sean?
Anyone who would like to make a public comment on this agenda item, please raise your hand, type something in that Q&A window, or press *3 if you're on a call-in only line. This is agenda item number 9 for clarification. Give you a few seconds to see if anyone queues up. Not seeing any requests at this time.
All right. Let's bring that back to the board. Any comments? Ms. Struther, if you'd please perform the roll call vote.
Dr. Ayala Rodriguez,
Yes.
Dr. Bolat,
Yes.
Ms. Chung,
Yes.
Dr. Helzer,
Yes.
Dr. Mahmood,
Yes.
Dr. Thorpe,
Yes.
Ms. Torres,
Yes.
Dr. Sy,
Yes.
Dr. Yip,
Yes.
Ms. Lawson.
Yes. That motion carries. Thank you. Thank you for filling in. Okay, we're moving on to agenda item 10, discussion and possible action on recommendations from the Special Faculty Permit Review Committee. Dr. Helzer?
Thank you. At our meeting on March 5th, the Special Faculty Permit Review Committee reviewed 2 applications for a special faculty permit under Business and Professions Code Section 2168.1 A1B. You can find a detailed summary of the applicant's qualifications under agenda item 10 in your meeting packet. The first applicant is Dr. Somnath Chattopadhyay, who is applying for a special faculty permit at the Loma Linda University School of Medicine. Dr. Chattopadhyay is an expert in the field of living donor liver transplantation and hepatobiliary surgery. In addition to performing many of these procedures in recent years, he established a robotic living donor hepatectomy program at a major hospital in Western India. He has an active research program related to living donor transplantation. And his experience is critical to Loma Linda's goal to establish a living donor liver transplantation program. And this will be very important due to the shortage of available organs from deceased donors, and will improve access to liver transplant care. If approved, he will be appointed as an associate professor in the Department of Surgery and as the surgical director of the living donor liver transplant program. His duties will include performing adult liver and kidney transplants, living donor hepatectomies, and hepatobiliary surgery. The committee reviewed his application and qualifications and recommends approval for a special faculty permit at Loma Linda for Dr. Chattopadhyay. The second applicant is Dr. Alexandria Lelouch, who is applying for a special faculty permit at the Cedars-Sinai Medical Center. Dr. Lelouch is an expert in the field of plastic and reconstructive surgery, with particular expertise in vascularized composite allograft procedures and free flap reconstruction. Among his notable accomplishments are he was a participant in the world's first face retransplant and the first penis transplant in this country. He has an active research program in the field of composite allograft procedures and immunomodulation with the goal of facilitating the first immunotolerant face transplant procedure. If approved for a special faculty permit, he'll be appointed the director of the Vascularized Composite Allotransplantation Lab in the Division of Plastic Surgery at Cedars-Sinai, and his duties will include performing complex reconstructive surgery and aesthetic procedures. The committee reviewed his applications and qualifications and recommended approval of Dr. Lelouch for a special faculty permit at Cedars-Sinai. I'd be happy to answer any questions.
Are there any questions or comments from members? Dr. Ayala Rodriguez.
I just have a question about the special faculty permit. Many times for surgery teams, like it's a care team and they supervise like nurse practitioners, things like that. In this particular case for the special faculty permits, do they also are allowed to supervise nurse practitioners? Because for example, in other countries, sometimes nurse practitioners do not exist and that could be changed.
There's not a limitation under the law for them to be able to do that.
Thank you.
All right, other questions, comments? Any members of the public? How about anyone on WebEx, Sean?
Yes, if
we
you'd
don't
like
have
to
a
make
motion,
a
whatever.
public comment
Figure it out.
on agenda item number 10,
Yes.
please do so by raising your hand, typing anything in that Q&A window, or press *3 if you're on a call-in only line. Give you a few seconds here to see if anyone queues up. Not seeing any requests at this time.
Okay, let's bring it back to the board.
I made a motion to set.
Thank you. All right, so we have a motion from Dr. Yip, a second from Dr. Sai. I'm not seeing any further comments or discussion. Ms. Struther, if you'd perform the roll call vote.
Dr. Ayala Rodriguez,
Yes.
Dr. Balat,
Yes.
Ms. Chung. Yes. Dr. Helzer,
Yes.
Dr. Mahmood,
Yes.
Dr. Thorpe.
Yes.
Ms. Torres.
Yes.
Dr. Sai,
Yes.
Dr. Yip,
Yes.
Ms. Lawson.
Yes. All right, moving on to agenda item 11, updates from the Physician Assistant Board. Dr. Sai?
So I'm the speed bump to you guys getting out of here. So I will make it short and sweet. I was appointed to the physician board last year, following in the footstep of Dr. Hawkins. As a member of the Physician Assistant Board, I serve in an ex officio capacity, participating in the meetings, but no voting rights. So I will provide a sort of a liaison between the Physician Assistant Board and the Medical Board. So they held their meeting on April 21st, 2025. Some of the highlights is that they also completed their sunset review and the process went well. One of the issues on their future agenda item is to review the PA practice agreement. As many of you know, the PA board is an offshoot or was an offshoot of the medical board as the physician assistant committee. At that time, there was a delegation agreement that was formed back in 2008 and revised in, or 2004 and revised in 2008. And it's been many years now. So their next focus is to review the current sample of the practice agreement and see if it needs to be updated. The next thing is that they also hold quarterly meetings 4 times a year. However, due to budget constraints and the amount of agenda items, they're planning to change the number of meetings to 3 times a year. One of the interesting facts that I got from their annual review of licensing is that in the last 5 years, number of PAs in California increased from 18,000 licensees to 27,000 last year. So they had almost a 50% increase from their in their 5-year rates. And so I think, one of the interesting things will be to see how that is in comparison to other states. I think the need for ancillary care providers to provide more care to patients in a timely manner is a real critical focus. Lastly, interesting to note, as I mentioned previously, they do have, the PA board does have a diversion program, and they renewed their contract with Premier Health Group based in Newport Beach. And so I think our physician wellness initiative is very timely and needs to be further advanced. And that concludes my report from the PA board.
Thank you, Dr. Tsai. Any comments, questions? Okay. How about from members of the public? Oh, I'm sorry, Dr. Yep. You didn't, when I looked this way, you weren't fast enough.
Well, I'm trying to be humble. So
Yeah.
according to the Department of Labor, PA is the second most favorable profession in this country. And actually, I was going to bring up like the anesthesiology. They should think about training PA, like urology. We have a PA fellowship. Actually, assistant robotic surgery and all that, that were very helpful. So with the amount, with the increased number of PA, they're motivated. I think it would be a very useful source of healthcare provider in the future. Thank you.
Thank you. Other comments? Any members of the public? How about on WebEx?
If anyone would like to make a public comment on agenda item 11, you can do so by typing anything in that Q&A window, raising your hand, or pressing *3 if you're on a call-in only line. Give you a few seconds to see if anyone queues up. Not seeing any requests this time.
Okay, we'll bring it back to the board. That's not an action item, so there's nothing for us to do. And so the only thing standing between us and adjournment is my favorite agenda item, future agenda items. Agenda item 12. Any board members with future agenda items? Requests? Dr. Helzer?
I'd like to give credit for this to Dr. Bolot. Based on our discussion at the panel meeting yesterday, we discussed the possibility of having a presentation to the board by the PACE program. We often send physicians to PACE for a clinical competence evaluation, and it'd be very helpful to learn more about that. Thank you.
Thank you. Any other requests? Any requests from folks in the room? Sorry, Dr. Thorpe.
Again, I have to credit my colleague, our president. Yesterday in the panel meeting, it comes up frequently, and I don't know if you guys experience this as well, but there are system problems that that get identified because a physician is part of the system that creates that there is an adverse event, a death, a severe disruption in a patient's life, whatever, and frequently it's the result of the system, not just the clinician, or it's more than one clinician that are involved in making a decision. And I don't know quite how to phrase this, but I would like to have some kind of recognition, or at least some presentation on the problem of the systems of healthcare that appear to be falling apart in California.
Yeah, I agree with you. I mean, we talked about that briefly. At the
I don't know
panel.
how to.
I don't know how.
It may be too big.
We should, well, no, I mean, perhaps Dr. Helzer and I can work with staff on developing, some sort of presentation or something for us to think about in terms of, I mean, it's come up in multiple contexts. It's come up in contexts where, there's some sort of problem with everything from the nursing care to the physician care, and the hospital system, authorizing certain procedures that perhaps it should have. It's come up in that context. It's also come up in the context of who was supposed to be available for what phone call and when. And so there's lots of different ways that it manifests itself in the disciplinary cases that we're reviewing. But it puts us in a real tricky position when our authority as the medical board is to discipline an individual physician who may have only been perhaps a minor part of a massive systems failure. And what do you do in those circumstances? So let's figure out how to.
One consideration would be to consider the issue. So CDPH, the nursing board, our board, I don't know, Board of Pharmacy, maybe, but some kind of collaborative process where we look at how could we, if we reported to each other, or if there was some kind of built-in, I don't know, I don't exactly know. I'm sorry. I'm very fuzzy about this, but it does concern me because I feel like we're really looking at, we see one aspect of the problem, and the problem is much bigger than that. And we are not, and we're going to end up disciplining a doctor who, like you say, may have only had a small part to play in that. And it seems inappropriate.
Right. Dr. Yip.
Yeah, after the panel meeting, I was thinking, actually talking to Reggie. I know Reggie has done a lot of outreaching, and as a matter of fact, we have him come to Los Angeles to talk to maybe 50 to 80 medical staff. But one of the thought I have last night is actually have Reggie maybe invite JCO to give a presentation. They're the one that credential hospital. So we can hear what criteria they use, and then they can hear from us what challenge we have. So maybe we can feedback to them when they survey hospital, what are the things, the guidelines and credential and all that. So maybe Reggie can talk to JCO and start a conversation, and maybe they can come to present a talk on how they survey hospital, and do they miss anything? What are the milestones? Have they achieved anything? Any improvements, patient safety? Yeah, thank you.
Thank you. All right, Dr. Ayala Rodriguez.
Thank you so much. I would say that to me, something that would be important to eventually bring to the table is like what happened to AB 890, like the nurse practitioners 103, 104, because they started receiving the 103 certifications like in 2023. Right now, we're starting to see more and more 103 MPs, but there's a lot of systems that they still haven't updated their policies and procedures. They are still requesting supervising physicians, so they're still involving us to a certain degree. And as there's more independence towards the 103 MP, like the system still requires for physicians to sign forms, but they're no longer the supervising physician and things like that. So as that continues to evolve, the 103, and then next year, I believe the 104, I think that we have to circle back on that one.
Great.
I'm going to bring this back again. I think we should have one thing, role of artificial intelligence in medicine and risks involved with that, because this is going to be upcoming a lot of issues.
Sure.
So
Great. Okay. Any future agenda items in the room? How about on the line, Sean?
If you'd like to make a public comment and request a future agenda item for agenda item 12, please do so by raising your hand, typing something in that Q&A window, or pressing *3 if you're on a call-in only line. First up here, I saw Monty Goddard. Monty should be receiving that request.
I just did. Thank you, Sean. This is going to be the same old suggestion for a future agenda item I've made now about 3 meetings in a row. Kind of ties into your spirit of collaboration with the other boards. And once again, I'm suggesting that you guys schedule a presentation similar to the one that the Board of Pharmacy received in October of last year about the impact of the state AG's nationwide settlement with the 3 major distributors of controlled substances. Specifically, the impact that settlement's 54-page injunctive relief has had on the supply of medications from the manufacturer to the patient. This is a critical issue. It's not going away. It's getting worse. And it's ripe for the pharmacy board and the medical board to join forces and maybe bring in a couple other medical boards and see if there's some influence the collective may have going up the chain with the state AG's office to see if at least get the awareness of this issue out so that it might at some point get rectified. Thank you very much.
Thank you, Monty. At this time, I'm not seeing any additional requests in queue.
All right, we'll bring it back to the board. Anybody else?
Well,
Okay.
just to say, I mean, I know that Reggie and is working on some of these issues that Mr. Goddard is concerned about. We're trying to do our best to try to get this collaboration together. It is in the process, but it's not easy to get the Board of Pharmacy, the PA board, the Board of Nursing together in one place to actually have a conversation. And whether it's on WebEx or whatever, just getting everybody's schedules organized. So we are working on trying to, I say we, Reggie's working on it. I'm just going along for the ride.
Great. All right, thank you.
Madam Chair,
Yes.
I can fill in the gaps on that one. Yes, we are working on it and we have made considerable progress. We're working with the DO board, pharmacy board, medical board, and we have invited 2 other prescribing boards. So this is a joint forum that we are going to be hosting in Sacramento. The date and all the other details are still in the working progress, but it'll be a hybrid meeting with in-person attendees and virtual attendees. And we have quite a really lengthy agenda already working on. We are trying to find presenters at this time. So I don't have all the details worked out, but it will be reported out to the board in the future meetings.
Great, thank you. All right, with that, agenda item 13, adjournment. Thank you everyone for participating in the May Medical Board meeting. Our board's next quarterly meeting is on August 21st and 22nd of 2025, and there being no further business, the meeting's adjourned. Thank you.